immunofluorescence. In that, he was trained at St. John's Hospital for disease of the skin in immunofluorescence. And as of today, I think he's the most knowledgeable person on the subject. And he's also a student like me of Dr. C.R. Srinivas. Dr. C.R. Srinivas incidentally was the one who brought immunofluorescence into India in dermatology with the help of Dr. Balbir Singh Bhogal from St. John's Medical Hospital for disease of the skin in London. Introduction. Immunofluorescence is a histochemical staining technique, like many of the special stains we do, which identifies, number one, antibodies bound to antigens in tissues, as well as circulating antibodies in body fluids. So the moment I say this, there is already a classification going on in your mind. Immunofluorescence is an essential investigation in the diagnosis and management of vesicobullous autoimmune as well as connective tissue disorders, which we encounter in our practice with any degree of reasonable footfall. It is considered the gold standard for diagnosing autoimmune bullous diseases. Going forward, I'll be able to cite some cases of mine where you can treat pemphigus before it involves the skin. It's also useful in assessing disease severity and prognostication. Now, to look at the history, in 1941, Kuhn et al. Pioneered the technique of demonstrating pneumococcal antigens in tissue using fluorescent labeled antibodies. Why did they do that? Because this was the era of infections. Remember? For such of us who started practice in our 80s and 90s, infections were a very crucial part of our practice, unlike today. Coming forward to 1963, the first major dermatological application, immunoglobulins and complement are demonstrated at the dermoepidermal junction in systemic lupus erythematosus, which we use even to this day, decades later, and is known as the lupus band test. And going forward to 1964, Bittner and Jordan, this was I think at the Roswell Park Cancer Institute in the state of New York. That is actually that city is called Buffalo. It is on the edge of, adjacent to Niagara Falls. So these guys discovered circulating antibodies in the sera of pemphigus patients using the indirect immunofluorescence technique, permanently altering the study of blistering diseases. Okay. What's the principle? The viewing of antigen-antibody complexes under fluorescence microscope uses antibodies tagged to a fluorochrome instead of doing something like hemotoxylin, eosin, Congo red, or reticulin. What we use here are fluorescent antibodies tagged to a fluorochrome. The mechanism is they absorb specific wavelengths, and the electrons move to an excited state, and then on returning to the ground state, they emit visible light in the blue, green and red spectrum, depending on the chemical used. Now what are the fluorophores? Fluorophores. Fluorophores are similar to like photophores. Like if you take a tube of glass and line it with a particular kind of chemical, it gives a light of a particular kind. It may be your tube light or it could be your UV light which you use for full body phototherapy. Alright. So those are called phosphors. Similarly, fluorescing chemicals are called fluorophores, of which there are two important. One is most commonly used is FITC, which is fluorescein isothiocyanate, which gives apple green fluorescence. So when we think of DIF, we think of that green blue color, which we see on the slide. Then we have got TRITC, that is tetramethylrhodamine isothiocyanate, which gives red fluorescence. Now what are the types of immunofluorescence? There is direct and indirect immunofluorescence. In direct immunofluorescence, it detects tissue-bound immunoreactants in the skin or the mucosa or the plucked hair, and the primary antibody is labeled with the fluorescein dye, in the sense that this is a test done on the human tissue. Contrarily, indirect immunofluorescence detects circulating autoantibodies in the patient's serum, which means the substrate here is either monkey skin or a cell culture or something other than human skin. What you are detecting is a circulating antibody in the serum. Secondary antibody labeled with a fluorochrome is used to recognize a primary antibody. Now in direct immunofluorescence going forward, the DIF is a single step procedure. A 3 to 4 mm punch biopsy is optimum for it. It identifies in vivo bound antibodies, complement and fibrinogen. Please let me repeat that. It identifies in vivo bound antibodies, complement and fibrinogen. The fluorophore labeled antibodies are only these: anti-IgG, anti-IgM, anti-IgA, anti-C3 and anti-fibrinogen. So here we have a diagrammatic representation of how a in vivo bound antibody in patient skin is FITC tagged with anti-human IgG, and it goes and binds to the site from where it fluoresces and becomes clinically visible to us. What are the indications? In direct immunofluorescence, bullous diseases, we are all familiar with this: pemphigus, pemphigoid, herpes gestationis, dermatitis herpetiformis, linear IgA bullous dermatosis and epidermolysis bullosa acquisata. Then connective tissue diseases such as discoid lupus erythematosus and systemic lupus erythematosus. DIF is highly characteristic in vascular diseases such as allergic vasculitis, enox-schondlin purpura, and polyarthritis nodosa. In other diseases such as PCD and lichen planus. And DIF is only suggestive in connective tissue diseases such as MCTD, that is mixed connective tissue disease, systemic sclerosis, dermatomyositis, and psoriasis. Now, how do we select a biopsy site? It depends on what condition you are attempting to use the test for. If it is an autoimmune bullous disease, you would lose a perilesional skin 1 to 2 centimeters from the border of the blister or erosion. You are not going to send the blister, but healthy skin adjacent to it. In vasculitis, you would look for a fleshly erupted purpuric spot, most proximal part of the limb, because the farther distal it is from the heart, the older is the lesion likely to be, and is the less is the possibility of you detecting the immunoreactants. In SLE and other connective tissue diseases, we look at the lesional skin of the sun-exposed area and non-lesional skin of the sun-protected area. In DLE, amyloidosis, lichen planus, and porphyria, we look at the lesional skin. So transport of a biopsy specimen, this is sent in Michel's medium, which is the most ideal transport medium. It can keep the immunoreactants active for up to 6 months at ambient temperature. You can send it in normal saline or phosphate buffered saline if the sample can be shipped within 24 hours to the lab. This is what we do in routine practice in Bangalore city. It can also, you send it in honey. Immunoreagents will be preserved for up to 2 weeks. This is a via media. It avoids, please avoid contamination of the specimen with formalin. Please label your bottles very, very carefully before you do the biopsy. Specimen, lesional specimen, especially EIBD, goes into the formalin. The perilesional goes into saline or any of the other carrier mediums. You can call the lab, they will send you Michel's medium bottles. You can keep it in your refrigerator, you can use it. Even contact for 2 minutes will destroy immunoreagents and render the samples useless if they are exposed to formalin. So please bear that in mind. Now embedding, the biopsy is oriented in a central fluid portion and covered with optimal control temperature and briefly dipped. It has an initial rinse where the biopsy specimens rinsed in phosphate buffered saline or rotator at 4 degrees or rotated for 4 degrees centigrade for 8 hours to remove ammonium salts and blood proteins. Sectioning, sections of 4 to 6 micron thickness are then cut using a cryostat. It's mounted on PTFE coated adhesive slides, which is available under the following trade names. PTFE is a kind of mixture of glycerols and epoxies which are water soluble. Now panel preparation. The slides are treated with FITC labeled conjugates which are IgG, IgA, IgM and C3 fibrinogen in separate panels. They are incubated for 1 hour at room temperature in a moist chamber and washing 3 times in phosphate buffered saline to remove the excess reagents. This is the reason why they need to be water soluble, dipped in distilled water and air dried. Mounting and evaluation. They are mounted using buffered glycerol and covered with a cover slip, and prepared sections are examined under a fluorescence microscope. This is a costly piece of equipment. So is the cryostat which is used for it. Now, interpretation of DIF. It is analyzed based on the below parameters. The type of immunoreactant can be any one of these, such as the ones mentioned here, and the location of the immune deposits, whether it is the intercellular junction, it's a basement membrane zone, whether it is a intercellular location in the epidermis, or is it the basement membrane, or is it below the basement membrane zone. And the extent of staining, focal or diffuse, homogeneous or non-homogeneous, and intensity of staining, semi-quantitative grading of strength of fluorescence, so there's 1+ to 4+. Pattern of immune complex deposition, which can be granular or linear. This is the central crux of it. If any of you want to take a picture, this is the one that is most important. I'll give a minute. Okay, fine. Now in pemphigus, what you get is intracellular space staining. Autoantibodies against desmoglein 1 and 3, DSG1 and 3. Fluorescence may be localized to or more intense around the upper layers of the epidermis in pemphigus foliaceous as opposed to the other types of pemphigus. So you can see the intracellular staining with IgG in pemphigus vulgaris vis-a-vis intracellular staining more intense in the upper layers in pemphigus, in the other types of pemphigus. Bullous pemphigoid. There is a linear basement membrane zone staining with IgG, C3 or both. The autoantibodies are against BPAG1 and 2, which are like 180 and 230 kilodaltons in molecular weight. In vasculitis, the cutaneous small vessel vasculitis, blood vessel wall staining with C3 and fibrinogen. This is of some clinical importance, I'll tell you. In HSP, granular staining of IgA plus, or it may be not be positive for IgA, and stain for the other immunoreactants alone. For example, on the left we see a blood vessel wall staining with C3 and granular staining of granular staining with IgA in HSP. So once you get this granular staining with IgA, it means that the gut and the kidneys are likely to be involved, and you are looking at having to counsel the patient to receive steroids for a period of 6 weeks to 4 months as a kidney saving measure. Your patients will be very, very resistant, but you have to be sure, absolutely and unforgivingly sure before you talk to them, and this is the key to that, finding IgA. Now, serration pattern analysis in DIF. You can get two types of serration, U serration and N serration. This is due to U serration. In that you see deposition of immunoglobulins between the rootlets of basal keratinocytes. They have a grass-like appearance. This is seen in epidermolysis bullosa acquisita, which is kind of a therapy-resistant condition which does respond to adapsone. Now, N serration is a deposition of immunoglobulins along the rootlets of the basal keratinocytes, which is seen in bullous pemphigoid, especially of the anti-P200 pemphigoid, mucous membrane pemphigoid, that is cicatricial pemphigoid. Anti-200 is a easy to deal with condition, again responds to dapsone, whereas cicatricial pemphigoid is a horrible condition which leads to blindness and hardly responds to anything, though there are multiple guidelines on how to go about it. Connective tissue disease, granular staining of BMZ usually with IgM, seen seen with others as well. In addition, you find colloid bodies and epidermal ANA may be seen in SLE. Then in lichen planus, you can get ragged or shaggy basement membrane zone staining with fibrinogen, clusters of colloid bodies with IgM. KMC Manipal did a lot of work of immunofluorescence in lichen planus. Now, in indirect immunofluorescence, it is a two-step semi-quantitative serological technique. Indirect immunofluorescence titers may correlate to disease severity, thus predicts the prognosis and monitors the response. So you use this for two purposes, diagnosis as well as monitoring. Step A, primary antibody binding, and step B is fluorophore conjugated secondary antibody binding. The indications are as follows. All these conditions you can use indirect immunofluorescence to do your prognostication or monitoring. What we do is 3 to 5 ml of the patient's blood is collected and centrifuged to separate the serum, which is where all the antibodies are found. The preparation of the substrate, NHS, that is washed with phosphate buffered saline and embedded using OTC compound. It is a snap frozen in N-hexane and cut into 4 to 6 micron sections using cryostat. I'll finish in the next minute. Sections of 4 to 6 micron thickness are then cut using a cryostat mounted in PTFE coated adhesive slides. The trade name is there in the bracket. IIF technique, incubation with patient serum. The specimen is incubated with the patient serum in 1:10 dilution for 60 minutes. It is incubated with FITC labeled antibodies for an hour. Antigen, if it is IgG or IgA, the concentrations are mentioned there. It is 3 times washed in phosphate buffered saline, 10 minutes each to remove excess reagents dipped in distilled water and air dried. Mounting and evaluation is next done as already mentioned. Now we get these biochip mosaic slides. This is used, this is offered to us by Lalpath Lab and many of the leading labs where you can look for all the antigens. It's a single test costing 8,000 rupees. You can ask for this biochip and straight away they will give you the full pattern. Meaning to say all the antibodies against which you are looking for is already available on the chip. They're already there. The antigens are already there on the chip, the serum which is tested against this. So it will cost you around 8,000 rupees in Bangalore. It may vary in other cities. It is really worthwhile in the management of bullous dermatosis if you are not very, very confident clinically. Salt split skin is to differentiate between epidermolysis bullosa acquisita and bullous pemphigoid. This is a technique, you dip it in hypertonic saline and then you do the immunostaining. Depending on whether you see the staining on the roof or floor of the blister, you get to diagnose different conditions. Now, in the roof pattern, the band is seen in the epidermal side. It is seen in about 75% of bullous pemphigoid and pyoderma gangrenosum. The combined pattern is seen in both dermal and epidermal. This is primarily in bullous pemphigoid. The floor pattern is seen more likely in epidermalis bullosa acquisita, bullous SLE, and anti-P200 pemphigoid. And here are the references. Thank you very much for a patient hearing. And I hand the session back to the chairpersons. Mic, please. Chairperson's mic. That hand, yeah.
Thank you, sir. Thank you for the elaborative session on immunofluorescence. Now the stage is open for all. Any query? Any query from the audience? I have a question.
Yes, ma'am.
Is there any role of immunofluorescence in psoriasis?
No, why do we? I mean, the psoriasis can be very easily diagnosed clinically, unless you want to distinguish it from subacute cutaneous lupus erythematosus, because sometimes you get polycyclic lesions which are psoriasiform in nature, and there you find that your psoriasis therapy such as phototherapy actually worsen it. So if you are looking at diagnosing subacute cutaneous lupus erythematosus, that's the only place where immunofluorescence will help. You can either do DIF or DIF is actually preferred because the antibody titers in subacute cutaneous lupus erythematosus may not be as high as in SLE. So that's the only place. Otherwise, for the regular psoriasis, if you look at the hospit sign, you'll take the history, look at the lesion, you look at the salmon pink patch with the flaky scales, and then you're done that way.
Thank you, sir.
Yeah, it is. That biochip is a very recent development. They even check out for envaplakin. There are 8 antibodies, including envaplakin, yeah. So it's worthwhile. And 8,000 rupees is it's a real deal. Given how much the therapy costs, like for example, fantastic, great, fantastic. That's because it's a medical college. Labs have to make a profit, okay.
Thank you, sir.
Well, thank you, ma'am. Thank you all.
Thank you, sir.
That was such an enlightening session. I would request our chairpersons and speakers to kindly collect their memento. Now, before proceeding forward, I would like to give a kind reminder to all our speakers that there will be a beep 3 minutes before the end time, so kindly keep it in mind. Proceeding forward, for the next session, I would like to invite Dr. Ashok Samanta sir, Dr. R.R. Madhukar sir, and Dr. Smarnika Satyapati ma'am to kindly come on the stage for chairing the next session.
Good afternoon, everybody. I will request to come, Dr. I will request Dr. Hrishikesh Chandran to come over the dais. He will deliver his lecture, Dermatoscopy of Vitiligo and Beyond. Dr. Chandran, please.
Hello. Good afternoon to all. I'm very much, it's a proud moment for me to present in this conference, so not wasting much time. Mainly why I meant dermatoscopy of vitiligo and beyond is, as we all know, in dermatoscopy of vitiligo, we get mainly as depigmentation and various patterns in vitiligo. But main thing which we have to focus when we talk about vitiligo is how are other lesions or how are they seen. So a general intro. As we all know that vitiligo is an autoimmune disorder of pigmentation. There is loss of functional melanocytes and melanin from the epidermis. And in normal skin has a depigmented disorder. Actually this we all know that it is a depigmentation disorder. Okay, so coming to the main difference point in dermatoscopy between a hypopigmented and depigmented lesion. So when you come to that, it is mainly in the pigment network. When it comes to hypopigmented lesion, you will have present with faint or it will be reduced, whereas in depigmentation there will be absent pigment network. Now, as I told, we know that this depigmentation mainly when it comes to vitiligo. Now, how it is seen in various other hypopigmentation disorders, let us go through it. Now first coming to is pityriasis alba. So here is a schematic diagram and here is a dermoscopy diagram, and here as I have written in that A diagram it shows focal white scales, ill-defined margin, and hairs are normally pigmented. But whereas in vitiligo we won't see scales, and ill-defined margin can be seen at times, and hairs are either pigmented nor pigment is lost. Dermatoscopy shows white scales here, faint pigment network, and also brownish white background. Now next coming to is pityriasis versicolor. Actually mainly it's a clinical finding, but still in dermatoscopy what we see is also an ill-defined margin, normal hair color with perifollicular hypopigmentation, scales along the skin creases. That is what mainly seen. And now here when it comes to dermatoscopy, the red arrow as you can see here is the perifollicular hypopigmentation, whereas the green arrow there is increased scales along the skin creases. Now coming to idiopathic guttate hypomelanosis. Now in this you can see here is the diagram. In A diagram is showing the various pattern also, and what we see is a whitish structureless area with well demarcated hyperpigmented borders. And first it is a petalloid pattern, B is a feathery pattern, C is a pneumaloid, and D is amoeboid pattern. Now here in dermatoscopy here you can also see a cloudy whitish structureless area with well demarcated hyperpigmented borders. Now next I am coming to is nevus depigmentosis. So what happens in nevus depigmentosis? Here is a schematic diagram which shows there is a faint reticular network is there throughout with perifollicular hyperpigmentation and irregular or serrated margins. Now when it comes to dermatoscopy, here you can see here there are faint reticular network throughout in this. Now coming to nevus animicus, here as you can see in the schematic diagram, as you can see here, there is focal area of decreased vascular structures and normal pigmentary network, and because there is a decreased vascular structure here, you can see compensatory flare in the perilesional areas. Coming to the diagram here in the dermatoscopic diagram, here you can see decreased vascular structure, and perilesional you can see compensatory flare of the vessels. Now coming to progressive macular amyloidosis, here I couldn't get a dermatoscopy diagram. So here what you can see is a faint reticular network and a few white scales limited to the skin creases. Now next coming to the hypopigmented type of mycosis fungoides, here what do you see? Mainly you see distorted reticular networks and spermatozoa-like vessels. Now coming to prebaldism, here what it is? Here there is diffuse white glow, absent reticular network and normal pigmented hair. So this, while we are comparing with vitiligo, in this area here, in case of vitiligo, the hair will not be normally pigmented. Now coming to ash leaf macules. When ash leaf macules, as you can see here, there is network. There is showing a reticular network. There are darkish brown to light brown, and also there is absent with normal pigmentary hair also. And here is the dermatoscopic diagram showing the reduced pigment network. Now coming to lichen sclerosis et atrophicus. Here, see there is an early stage and it's a late stage of inflammatory stage. So here in early stage, what we see is a pink background with red globules, there are linear vessels and white structureless area and brown peppering. When it comes to the later stage, what we see is there are various white structure and there is fine linear vessels and peppering of blue-gray dots, as you can see here, and shiny white streaks. Now coming to dermatoscopy, here you can see structureless white area with brown peppering. Now coming to the hypopigmented patch in leprosy, what do we see? There are different cases, whereas in first schematic diagram is of BT Hansen disease. Here there is a broken reticular network, reduced density of hair, and where circular broken hair is seen, and there is decreased follicular opening, diffuse white scales and yellow-orange areas. Now, when it B diagram, it is a lepromatous type. Here also broken reticular network, reduced appendages and focal white areas. Now coming to the dermatoscopy, here there is a broken pigmentary network, white skin crease, absent of appendages and chrysalis-like structures. Now, I have told almost how much ever I can cover based on hypopigmented lesion. Now coming to the vitiligo proper. So in vitiligo, the dermatoscopic pattern I have classified based on disease severity. So when it comes to disease severity, there is stable, there is unstable, and there's a vitiligo which is on treatment. Now I have separated, see, actually the thing is that we can't say everything specifically for this and specifically for that. Out of various studies and out of various papers, we can like categorize them like, okay, when it comes to stable vitiligo, these are the findings, unstable, these are the findings. Now here, based on stable vitiligo, the major finding which we see here is marginal hyperpigmentation, perifollicular hyperpigmentation and reticular pigmentation. But when it comes to unstable vitiligo, there can be trichome pattern, comet tail with microcarbonization or reduced pigmented network, perifollicular depigmentation to be noted. Actually, when in stable vitiligo, there will be hyperpigmentation and there will be starburst pattern, polka dots. Now, when in case of some lesions where it be stable, when you do dermatoscopy, and some lesions will be unstable. So when the patient is on treatment, we will see all these features. Plus what we mainly see when they are on treatment, there will be erythema and telangiectasia. Now here, just like I have told what all are the main, this thing, a diagrammatic representation. Here is a normal pigmentary network. Here you can see perifollicular hyperpigmentation. Here there is perifollicular pigmentation and this is perifollicular depigmentation. This in case of unstable vitiligo mainly it is seen and this is seen in stable vitiligo. Now here there is reduced or absent network and here there is reverse network, means follicles are all fine, they are pigmented, but there is a change in the other network. And here there is leukotrichia, which is white hairs, and here you can see this is a lesion and there is polka dots showing the unstable pattern, and here you can see microcorbinar phenomena. Here this thing shows the comet tail, and here now what you see here is perilesional or marginal hyperpigmentation, which is mainly seen in stable vitiligo. And now there is starburst pattern. This is starburst pattern and here is trichome pattern. Why trichome? 1, 2, 3. 3 different colors are seen around here. And here we can see erythema with telangiectasia. Just same thing which I have told. Just skipping through. Now this is the dermoscopic image. Here you can see perifollicular hyperpigmentation. This is the lesion and this is the margin. So there is marginal hyperpigmentation. Here reticular pigmentation is seen here. Here the black line which is showing here is the comet tail from the lesion, that is microcarbonization. Here there is trichome pattern and here we have polka dot, that is satellite lesions. Next there is erythema with telangiectasia along with repigmentation eyes. Here there is leukotrichia and here you can see the black arrow shows reduced pigment network, whereas the green it shows the ill-defined borders which is seen in vitiligo cases, mainly unstable cases. Now mainly I'll tell, see, dermatoscopy can both use as a diagnostic and a prognostic. Now diagnostic, what is its main this thing? It helps to reveal the characteristic pattern which aid in the diagnosis, like reduced or absent pigment network, perilesional hyperpigmentation or perifollicular depigmentation, leukotrichia and distinct vascular patterns. Now these features, what they do? They also help us to differentiate. Sometimes when we see at first we might think it's vitiligo, but once we do on dermatoscopy we'll see various features just like I have told right now. Here like whether it can be pityriasis alba or nevus depigmentosus or post-inflammatory hypopigmentation. So important what it is, one main it is assessment of disease activity, like when it comes to unstable, if the disease is progressive, we'll see starburst pattern, trichome pattern and various confetti like depigmentation which indicates unstable or progressive disease. Now diagnostic, now therapeutic. What therapeutic what? It plays a major role in monitoring the treatment response. For example, you have put the patient on treatment and you call the patient next time. And then once you do the dermatoscopy, then if you see perifollicular and marginal repigmentation, which says that it is like the treatment is working, and it also shows the early indication of melanocyte reserve activation and treatment efficacy, often preceding the visible clinical improvement. Visible clinical improvement which might take 2 or 3 months, but while on doing dermatoscopy, while we call them on follow-up, this can be seen way before. And on identifying leukotrichia or absent perifollicular pigmentation, means while on treatment the patient is responding poorly to the treatment, so that it help us to change another therapy. What other therapy we can do? Now, next, okay. Now, prognostic role. Prognostic, like what there's a specific pattern shows the prognosis. Unstable vitiligo, we say it will take time. Like if it is in acral or acrofacial areas, then there will be like poor response. It shows all that. We can correlate with disease stability, repigmentation potential, making dermatoscopy an invaluable tool for patient counseling and individual treatment. Based on how you see, you don't need to give empirical treatment. Based on patient's condition, you can see individual treatment. And while we incorporate this, it help us to enhance the diagnostic accuracy and optimize our treatment strategy, and there will be improves prognostic value. And our conclusion is the same thing we told. It's a non-invasive tool. When it comes to stable vitiligo, there will be marginal hyperpigmentation, perifollicular pigmentation, and reticular hyperpigmentation. In unstable, there will be trichome pattern, starburst, comet tail, or polka dots. Patient with good response, what do they show? There are patterns of stable vitiligo such as marginal hyperpigmentation, perifollicular reticular pigmentation. Those who have poor response, they show trichome, starburst, comet tail, polka dot pattern. Hence, dermatoscopy can be used to monitor the disease activity, response to treatment, and hence prognosis of the disease. Thank you.
Thank you very much, Dr. Rishikesh. It was indeed enlightening, and you helped with the other indications also. Any questions from the audience? Sir.
Has anybody looked at, there is this condition called progressive macular hypomelanosis,
Yes, sir.
right? Which looks like the post-inflammatory pigmentation following pityriasis versicolor, or it can simulate pityriasis lichenoides chronica.
Yes, sir.
That is one thing. Has anybody looked at the dermoscopy of that? Secondly, just a moment. Has anybody looked at the dermoscopy of hypopigmented secondary syphilis, which is on the rise now? These are two questions. Remember, progressive macular hypomelanosis, secondary syphilis. If you have read about it, please let us know. Or if you have seen, even better.
Actually, progressive macular hypomelanosis, actually, like you told, actually after the condition, it took me time to diagnose the condition. So while I was diagnosing, I was very much confused whether it was PIH, because there were many reticular patterns, and there are distorted patterns also seen. But in case of syphilis, I haven't seen as such, actually, sir. But there is true, like after syphilis, the lesion, once they recover, I have seen hypopigmented pattern, but haven't done dermoscopy in that, sir. Thank you so much. Thank you for giving me this opportunity, and I thank the organizing team for this, allowing me to do my presentation at this conference. Thank you so much.
Thank you.
Thank you so much, sir, for such an enlightening session. I would request our chairpersons and speakers to kindly collect their memento. Proceeding forward, for the next session, I would like to invite Dr. Amrit Singh Bhatia, Dr. Chandan Kumar Satyapati, and Dr. Girish Kumar Shah to kindly chair the next session. Dr. Amrit Singh Bhatia, Dr. Chandan Kumar Satyapati, and Dr. Girish Kumar Shah, kindly join us on the dais. I would request our chairpersons to kindly introduce our speaker.
Very good afternoon to all the esteemed delegates. So our next speaker is Dr. Subhasri Madwal, who is currently working as an assistant professor in the Department of DVL, IMS and SAM Hospital, Bhubaneswar, Odisha. To her name, there are many presentations, and she is the assistant editor of IJTV, Indian Journal of Pediatric Dermatology, and her special areas of interest are pediatric dermatology, leprosy, and clinical dermatology.
Good afternoon, everyone. All the faculties and delegates present here. My topic of presentation is the bedside tests in dermatology. In our day-to-day OPD practice, the bedside tests play the important cornerstone in establishing the diagnosis, and this test supports our provisional diagnosis, because the bedside tests are usually, the result is rapid and these are non-invasive in nature, and this also has high accuracy and high specificity when done with appropriate laboratory procedures and meticulous examination of that microscopic features. So coming to the bedside diagnostics that we usually prefer in case of infective diseases. So here are two cases. The left one is multiple grouped vesicles and bulla over an erythematous base presenting along the T5 dermatome, which is probably a herpes zoster case, and the right side image also present multiple bullous lesion discretely over the face. So if any type of bullous dermatosis presented to the OPD, it may be any infective case, it may be any autoimmune bullous conditions, and among the infections, it may be due to the viral infections or may be due to the bacterial infections like bullous impetigo or staphylococcal scarlet skin syndrome. In all these cases, we have to do first the Jank smear, because the Jank smear is the most sensitive and specific test when performed on early vesicular or pustular lesions. So we have to choose the early vesicular lesions and always prefer the lesions within 72 hours. And in case of herpetic infections, the diagnosis will be based upon the multinucleated syncytial giant cells. And in case of, if the patient is a child presenting with bullous impetigo, so in those cases the inflammatory cells and the neutrophils and gram-positive gram-positive cells are seen. Then coming to the role of Jank smear in other viral and deep fungal infections. So sometimes the molluscum contagiosum, the early lesions were confused with other umbilicated lesions like or Milker's nodules or ORF, both presented as umbilicated papules. But in case of molluscum, if you do the Jank smear, we can found the Henderson-Peterson body, and in case of ORF or Milker nodules, the eosinophilic inclusion bodies like Guarneri bodies are present. So these are the clinical images of molluscum and the inclusion body seen in Jank. Then coming to the deep fungal infection like cryptococcosis, which is presented as numerous umbilicated papules, pustules. In those cases, Jank smear demonstrates yeast forms with a gelatinous capsule that is demonstrated by the halo. So coming to the key clinical and histopathological features of bacterial infections using the bedside diagnostics. So in case of botryomycosis, if we do the gram stain, because in case of infective diseases, gram stain is the first bedside test to be considered. In case of botryomycosis, we can see the balls of gram-positive cocci, and in case of meningococcemia, if a patient presented with multiple petechial lesions with high grade of fever and neck rigidity, in those cases, if we do the gram stain, we see the gram-negative diplococci. And in case of impetigo, I have already described, that is the neutrophils and intraepidermal split can be seen. Then this is the image of ecthyma gangrenosum clinically presented as necrotic epidermis with a center adherent eschar. In this case, the gram stain shows the numerous gram-negative rods, that is the red color rods. Then coming to the cutaneous tuberculosis lesion like lupus vulgaris, early lesions can be, in those cases, diascopy can be helpful to see the apple jelly sign and leprosy. The most common infiltrating granulomatous disorders in our OPD is Hansen disease, which can be confused with lupus perniops, sarcoidosis, multiple papillonodular lesions of post-Kalager dermal leishmaniasis, or the diffuse hypopigmentation of PKDL also can be confused with lepromatous leprosy. So when a patient presented with multiple infiltrated plaques over face, over the extremities, or over any of the body, then we should do the slit skin smear first. So the procedures of slit skin smear is common to us. First, the site is cleaned with spirit and the proposed site to become avascular by the pinching with thumb and forefinger. Then we have to make a slit of 5 mm length and 3 mm depth with the 15 mm BP blade. Then turn the blade at right angle to scrape the wound several times to collect the tissue fluid. That is the important part, because if the RBC is mixed with that tissue fluid, then the report may be inappropriate. Then smear on a glass slide in a circular muscle to minimum of 8 mm size, and 2 or more smears can be made on a glass slide. Then after that we can stain with the Zn staining. So cover the slide with the concentrated carbol foscin for 15 minutes. Then the slide is kept under the gentle stream of water, and then put the decolorizer, that is the 5% sulfuric acid. Then cover the slide with the counter stain, that is 1% methylene blue, for 10 seconds. Then wash in running water and examine the smear under oil immersion lens to see the solid uniformly stained bacilli or the dead bacilli presented as the fragmented granular deposits. Coming to the diagnostic uses of KOH. So potassium hydroxide examination usually indicated in case of dermatophytic and candidal infections of skin. When we usually confuse the candidal infections with other intertriginous dermatitis like our flexural psoriasis or Hailey-Hailey disease, in those cases KOH examination is very helpful, and sometimes we are also confused with the tinea pedis and chronic foot eczema. So in those cases also KOH examinations play the important role. And the dermatophyte infections of hair, that is the ectothrics and endothrix, also can be delineated with KOH examination. So in those cases we have to scrape the inflammatory edge or the scales of the dermatosis with a scalpel blade and just put 10% KOH and see under the microscope. So in case of superficial dermatophytosis, we can see the refractile septate hyphae. In case of pityriasis versicolor, that is the spaghetti and meatball appearance can be seen. In case of candidal dermatitis, we can see the pseudohyphae and budding yeast. And in case of nail KOH, we have to put the 10 to 20% KOH and keep the KOH for 2 to 4 hours to dissolve the nail keratinocyte. And in case of superficial or subcutaneous deep fungal infection like your chromoblastomycosis, in those cases also KOH examination from the subcutaneous nodules with black dots, then we can see the copper penny bodies or medullary bodies. And in case of lobomycosis, which is clinically presented as keloidal plaques, in these cases we can see the thick walled spirules with an arrangement of brass knuckles or puff beads appearance. So these are the clinical images of chromoblastomycosis where the septate bodies like your medullary bodies can be easily seen, and the below one is of lobomycosis, in which also multiple thin walled spirules with a knuckle beads like appearance can be seen with KOH examination. So these both are the images presented as tumified mass with multiple discharging sinus, and the right one is slightly hyperpigmented than the eumycetoma is pigmentation is more as compared to the actinomycetoma, but by clinically sometimes it is very difficult to distinguish between these two entities. So we have to keep the saline soaked gauze overnight and then see the grains with the KOH examination. We can see that hyphae confirms eumycetoma, and with the presence of gram-positive filamentous bacteria confirms actinomycetoma. Then coming to the other bedside diagnostics in parasitic diseases like scabies, however, it is usually diagnosed clinically and dermoscopy also can help. So in these cases, the mites, scabula and eggs can be seen. In case of cutaneous leishmaniasis, we can find intracellular mastigotes like LD bodies in an arrangement of swarm of bees appearance. Then coming to the intradermal tests, these tests are also widely used as a bedside test to detect type 1 and type 4 hypersensitivity towards exogenous and endogenous antigens. All the intradermal tests include the injection of antigen into superficial layer of dermis through a fine bore needle. Conventionally 0.1 ml is universally used, and proximal part of the flexor aspect of forearm is preferred. Among all the intradermal tests, tuberculin tests can help to diagnose our tuberculitis, in which the mantle will be more than 10 and more than 15 millimeter. And other intradermal tests like autologous serum skin test for the diagnosis of autoimmune urticaria, and pathogen test is the most important to help in diagnosing Behçet's disease, and also it is help in other neutrophilic dermatosis like pyoderma gangrenosum and inflammatory bowel disease and Sweet syndrome. So in skin pathology, a sterile needle prick or an intradermal injection of normal saline can be given to the volar aspect of forearm. Generally, the needle is inserted vertically or diagonally at an angle of 45 degree to the minimum depth of 3 to 5 millimeter. Oral pathology also can be done, but it is less sensitive than the skin pathology. Then coming to the other autoimmune blistering disorders like pemphigus vulgaris, bullous pemphigoid or linear IgA disease, in those cases, the acantholytic cell examination under the Jank smear is very important, and bullous pemphigoid can be delineated with the presence of abundant eosinophils, and Darier's disease can be presented with corpse runs and grains with Jank smear. Then coming to the acantholytic cells in pemphigus vulgaris, it is clearly seen that the round keratinocyte with hypertrophic nucleus and the basophilic deep staining at the periphery of the keratinocytes. Then Nikolsky sign, that is the most common sign we usually do in case of bullous disorders, that indicates the disease activity and positive only in intraepidermal acantholytic conditions. Then coming to the bullous spread sign and Asbo-Hansen sign, it is also helpful in case of pemphigus vulgaris. Then coming to the differentiate between psoriasis and Ritter's disease. So the common bedside test is Grates test, in which psoriasis there is gradual accentuation of scaling, but in Ritter's disease the whole hyperkeratotic crust can be removed in toto. So Grates test auspice sign is helpful in case of erythematous plaques. Then diascopy can be helpful to delineate just simple erythema from vasculitic lesions. Dermographism and Darrier sign in mastocytosis also common bedside tests we can do. Then coming to the patient if presented with erythematous indurated plaque with the central atrophy, in those cases the carpet tack sign by the removing of the adherent crust and seeing the underlying patulous follicles can be helpful. Then coming to the diagnostic microscopy used in case of commonly sexually transmitted diseases, in which dark ground microscopy to help in primary syphilis, secondary syphilis and early congenital syphilis. Gram stain in case of gram-negative diplococci from urethral discharge. Then wet mount slides in bacterial vaginosis, we can see the clue cells. Then coming to the gonococcal urethritis, gram stain can be helpful to show the intracellular gram-negative diplococci. Dark field microscopy can see in the spiral treponema pallidum. Then after all, there are so many bedside investigations, but time is limited. And last but not the least, dermoscopy is the most helpful in case of pigmentary dermatosis, any dermatosis over scalp, to differentiate between the benign and malignant disorders, scarring and non-scarring alopecia. So it is the most useful bedside diagnostics in our day-to-day OPD practice. Thank you.
Thank you, Dr. Subhasri, for such an informative talk on a simple topic like bedside, and it is very, very useful in day-to-day clinical practice. Now, any question from the audience? I think there is no question from the audience, so we end this session.
Okay, thank you.
That was an enlightening session. I would thank our chairpersons and speakers and would request them to please collect their memento. So moving forward, now we are moving to our next session, which is infectious spectrum in dermatology. For chairing this session, I would like to invite Dr. Abin Basu, Dr. Mohanlal Gupta, and Dr. Prasanjit Das on the dais. Dr. Abin Basu, Dr. Mohanlal Gupta, and Dr. Prasanjit Das. Kindly come on the dais for chairing the next session. I'd request our chairperson to kindly introduce our speaker.
Good afternoon, everyone. The next session is Are We Losing Tinea? And the speaker is Dr. Vikas Shankar, who is an associate professor of dermatology in Nalanda Medical College and Hospital, Patna. And he has numerous publications and presentations. And he is a very much well-known dermatologist. Who is a member of expert committee of Central Drug Standard and Control Organization, member of expert committee on PGRC, member of ethical committee NMCH Patna, and presented papers at international, national, zonal, and state conferences. He is also author of in 3 cases and reviewer in 3 international journals and recipient of several awards. And he is also ex-honorary Secretary General of Bihar. And so also recipient of IDVL President Appreciation Award 2021 and 2026, and convener of IDVL Community Dermatology in 2021 and IDVL Constitution Committee in 2025, and also organizing secretary of in Meet Dermacon 2019 Patna, and scientific chairperson in Dermazone East 2023, Clinicon 2023, 24, 25, Clinicon 24, 25, 26. And also ex-member of IDVL SIG, leprosy, and SIG pruritus. And his areas of interest are leprosy, geriatric pruritus, dermatophytosis, aesthetic and lasers, and community dermatology. I invite him to speak on the topic.
Thank you, Chairperson, for a very nice introduction. A very warm good afternoon to all. My topic is, are we losing tinea, resistance, and relapse? So the story of dermatology decade, tinea everywhere, all around, but satisfaction yet to found. So there is no conflict of interest. So the objective of this session is to say about the changing pattern and treatment option, resistance and relapse, role of microbiology and how to overcome. So as we know, dermatophytosis is an extremely common superficial fungal infection and occur worldwide. It may be severe and life-threatening complication in premature and immunocompromised individuals. There is medical, economical, and social burden with increasing trends. Tinea term been used for more than 15 years, and Roman thought it is moth-eaten, and Britishers first utilized the term ringworm in 16th century, though it's a misnomer. Dermatophytes are molds belonging to the 3 genera of fungi imperfecti, and dermatophytes and yeast are the common pathogen in human, and molds do not usually cause disease in immunocompetent patient, but it is the secondary invaders. We can classify dermatophytes as trichophyton, microsporum, and epidermophyton. And there is more than 40 species is well described, 22 of genus Trichophyton, 16 of genus Microsporum, and 2 species of epidermophytons, we can classify it through this anthrophilic, zoophilic, and geophilic. So coming to the pathogenesis, when there is slight trauma or abrasion, and there is increased warmth and moisture, and increase in the CO2 tension, the fungal spore arthrochonidia attached to the skin, and the invasion is facilitated by the enzyme keratinase. The fungus germinate and penetrate through stratum corneum, and it will infect the keratin, which eventually desquamate. But the inhibitory factors are sebum and serum. The mode of transmission are from person to person, animal to person, contact to inanimate objects like infected toys, brushes, combs, theatre, seats, bed sheets, bed rolls, train bed rolls, and many other inanimate objects. So through live diagnosis, we can diagnose through either wood lamps inspection or KOH or this chlorophore white stain, or we can do the diagnostic gold standard for culture confirmation. Sometimes when necessary, we can go for biopsy or PCR or MALDIT of MS investigation. If we classify, we can classify either in the term of epidermomycosis or trichomycosis or onychomycosis, or by the habitat as said, anthrophilic, zoophilic or geophilic, or by either location of the body parts. So these are the beautiful pictures of the tinea. Now, how the trend in the current fungal infection, what is the trend in the current fungal infection? The story of this dermatophytos dermatology decades. So in a study published in Indian Journal of Dermatology in 2014, titled A Clinical and Mycological Study of Dermatophyte Infection, 46% of patients showed multiple site involvement, and the total number of clinical pattern observed exceeded the number of patients due to the overlapping presentation. Tinea corporis was the most common infection, followed by tinea cruris and tinea pedis. Tinea corporis was 44%, was the most common clinical pattern in females, whereas tinea cruris was 68% predominant in males, followed by tinea corporis. Most cases of tinea angum was observed in 31 to 45 years age group, and Trichophyton rubrum was the main isolate in the clinical pattern, followed by Trichophyton mentagrophyte, which was about 20% at that time. Similar finding was reported in India with epidermophyton. This flocosum was the most commonest agent in the study were done in Tehran. Now coming to the current scenario, current status of dermatophytosis in the hospital-based study in 2026 in eastern part of India by Samit R. Dalai et al. Male is to female ratio was 1.5 to 1, and Trichophyton mentagrophyte isolate was 61.98%. And the Trichophyton rubrum was 31.67. So there is a decreased trend in Trichophyton rubrum cases. Now, tinea corporis was again the most common clinical variant in all atopic abscesses. Now there is a pregnant shift in the clinical aspect of tinea. The chronic and recurrent infection and recalcitrant infection, highly contagious disease, pediatric infection and unusual location was found. Highly inflammatory, intensely pruritic and rapidly spreading infections, and rampant topical corticosteroid, either misuse or unscientific combo creams. Trichophyton rubrums to Trichophyton mentagrophytes as a dominant pathogen, there was a shift, and therapeutic failure, antifungal resistance, particularly to the terbinafine. Now chronic and recurrent dermatophytosis, there is a multi-centric cross study conducted in 13 centers in 11 cities, work done by Manjunath Sinha sir, and more than 41,000 patients was screened. More than 7,000 was glabrous tinea was there, and this chronic and recurrent dermatophytosis was 78% to 21.95% of chronic and recurrent dermatophytosis. Now, chronic dermatophytosis means the presence of glabrous tinea for a duration of 6 months or longer, continuous or recurrent. Recurrent dermatophytosis means a reoccurrence of the glabrous skin tinea for 4 weeks. After 4 weeks of stopping the treatment following the clinical cure, and recalcitrant means jiddi, persistent glabrous tinea, generally in the setting with like chronic, recurrent corticosteroid modified or resistant cases with poor or no response with the standard treatment. In this CRD, the tinea cruris was 79.9 multiple sites were involved in 69.58%, and family history was present in approx 50%, and the sharing of mites was around 50.37%, and the synthetic tight clothing was seen in 43.47%, and misuse of topical corticosteroid was seen in 50.9%. So the pregnancy shift in the mycology of tinea. The microbiologist view, topical formulation may get rid of large population of organisms, but not all. A small pockets of persistent cell regrows. These cells may be more hardy and drug tolerant. Impermeability or inaccessibility to the drug, to the nooks and surfaces or a deeper layer of the skin and nails, organisms are protected from the drug. And the fungi-static nature of the drugs such as azole result in a regrowth of the organism over time. The thick multi-layered biofilm of the fungi form soft tissue on the soft tissue like yeast balanitis are inherently drug resistant. Now these are the different trends from shift to from Trichophytum, this rubrum to Trichophytum mentogrophytes. Now Trichophytum mentogrophytes genotype 8 in the Asian, it in the NCBI database from the India, but also from the Iran, Oman and Australia. So these are the systemic and topical antifungals. Now comparatively according to Wolverton, the topical antifungal in vitro study says that alanine or benzylamine group have a greater activity against the common dermatophytes, where butyramine is the highest and again less the terbinafine and cyclosporine is as equal as nystatin, and the least is the azole group. In an animal study, nystatin and terbinafine showing 74 to 100% dermatophyte inhibition, whereas the azole group 57 to 73% inhibition. The latest activity is aclunazole was around 34 to 53%, and ibuproconazole and cetoconazole better than other azoles, and luliconazole is as equal to alanine, strongly mycological, there is strong mycological activity, and ambrolfin best role in onychomycosis and also as an use an adjuvant. Now in clinical trials, by 4 weeks, mycological cure rate in higher in the terbinafine than clotrimazole, and this alanine and benzylamine produce a significant post-treatment relapse low rate than azole antifungal. The summary of this study was alanine and benzylamine are fungicidal, whereas the azoles are primarily fungistatic. Highly lipophilic and alanine benzylamine exhibit a reservoir effect, so the patient continues to improve even after the stopping of the drug. So the retention plus the fungicidal effect, it reduces the duration of the therapy. Now coming to silent point, this alanine and benzylamine group possesses a greater degree of anti-inflammatory action, whereas the azole group is a key player in antibacterial properties in topical antimycotic group. Gram-negative bacterial activity of cyclopus olamine is superior than any other antimycotic. Especially in pregnancy in vulvovaginal lesion, azole group is superior to the nystatin therapy. Topical and intravaginal azole groups actually reduces the prevalence of preterm birth. And itraconazole and fluconazole is category C, and terbinafine is category B. And we must avoid oral antifungal in pregnancy. Oral antifungal is treated on breast milk, so contraindicated in the lactating mother. Sometimes we see after application of the drug there is oozing and some contact dermatitis like lesions are there. So the main cause may be the propylene glycol. This is a percutaneous penetration enhancer vehicle ingredient. Now again my question is are we losing tinea? What are the role of poor prognostic factors? Relapse, reinfection and recurrence, treatment failure and drug resistance. So the poor prognostic factors are more body surface area involved, history of systemic disorder, comorbidities, history of uncontrolled diabetes, positive culture at 24 weeks, extremes of age, history of topical corticosteroid, stria marked, tight clothing, humid environment, workplace, abundant population of the fungal IP in a scrap specimen, and low immunity and bad prescription of ours. Now coming to the relapse. Now coming to the relapse of the same infection, whatever time has elapsed either due to reinfection or recurrence, we can say reinfection implies contracting the infection again after having achieved cure, usually after a period of 1 year. Multiple factors in reinfection like lifestyle, age, genetic, occupation, climate, nature, and extent of initial lesion and comorbid condition. Whereas recurrence is return of disease within 1 year of the therapy completion. Now, therapy failure, we can say, is an appropriate failure of an appropriate therapy for a certain indication to result in a clinical response, either due to lack of diagnostic accuracy, inappropriate choice of drug or mode of delivery, presence of dormant fungal condition or resistant fungal species, and lack of persistent penetration. Now, coming to resistant, a number of safe and highly efficacious antifungal agents have been introduced for the treatment of superficial fungal infection. Though the new drugs are welcome additional, other antimicrobial, they pose the potential threat of resistance. Now, coming to the term resistance. The term resistance is used to describe a relative insensitivity of microbes to the antimicrobial drug as tested in vitro and compared with other isolate of the same species. Resistance may be primary, which occur in organism never exposed in that host to the drug of interest, or in contrast to secondary resistance, also defined as acquired resistance, arise only after the exposure of the organism to the drug. Intrinsic resistance is defined as the resistance of all or almost all isolates of one species to a certain drug. In addition, the term clinical resistance can be used to describe the failure of the therapy or relapse and rejection. The drug resistance mechanism, microorganism develop mechanism to contract the fungicidal or fungicidal effect of the antifungal cases that are based on the three major mechanisms, namely reducing the accumulation of drug within the fungal cell, decreasing the affinity of drug for its target, and modification of metabolism to counterbalance the drug effect. So these are the various antifungal drugs listed and with the mechanism of resistance. The resistant factor is indiscriminate or irrational use of antifungal, poor compliance by the patient, inadequate duration of treatment, and incorrect diagnosis, as well as there is change in spectrum of the disease. So more obvious reasons are lack of persistence by the patient to extend the treatment period, relapse occur due to misuse of drug, off and on therapy, or recurrent currently available formulation not patient friendly and lead to poor compliance. Low resistance time for drug on the onto the site of the action, and persistent violence of the compliance to the proper personal hygiene. Now coming to the new term, this is Trichophyton indotinea. Two highly terminafin resistant, that is Trichophyton interdigitally like strain from Nepal, and an Indian patient with that tinea corporis in Japan was isolated. 100% identical to this two highly terminafin resistance, that Trichophyton intergelated from the India on its sequencing. To avoid confusion in the taxonomy of the Trichophyton mentogrophyte or the Trichophyton intergelated complex, they suggested a new species named that Trichophyton indotinea. Refers to the cause of the epidemic dermatophytosis in India. Not originally observed in India, the earliest isolate was contacted in the Australia in 2008, later Oman 2010, and Iran in 2016. So the terminafin resistance, clinically significant terminafin resistance strain previously identified as mentogrophytes are now being recognized as a distinct species called Trichophyton indotinea, first noted as an epidemic of the severe recalcitrant dermatophytosis in the Indian subcontinent, and it has been documented spreading across India, Europe, US, Australia, and Africa. The resistance in Trichophyton indotinea is primarily caused by the post-mutation in the gene that codes of the SQLE enzyme, and the altered enzyme has a significantly reduced affinity to the terminafin, preventing the drug from binding and inhibiting this effectivity. Itraconazole in 40 patient, according to the Handa et al. Trichophyton mentogrophyte species complex 91.7%, and Trichophyton rubrum was 8.3%. Itraconazole MIC was within the susceptibility range from 0.1% to microgram per ml, 2.25 microgram per ml. At the day of 14, 8 and 13, 61.5% participants achieved mycological response, and two participants, 15.4% had failure, and 90 showed a clinical response. The real-world study confirmed that the clinical efficacy and mycological susceptibility to itraconazole. So why it is refractory? Inherent terminophen resistance of the currently prevailing agent, that is trichoderma mentacrophyte, high MIC to other systemic antifungal except itraconazole, persistence in the environmental formites for a long time, lack of following management guideline, inadequate and faulty treatment, topical corticosteroid misuse, and lack of hygiene, formite transmission and reinfection. So what need to be done? A good prescription and a standard treatment, patient counseling and education, rule out the systemic disease, check all parts of the body parts including nails, confirm the patient compliance to prevent onset of drug resistance, and maintain the clean hygiene practice. So bedside collection of the clinical specimen is ideal. Proper transport of the specimen and early identification of the etiological agent by a microbiologist is needed. Monitoring drug susceptibility pattern at least twice within the treatment period is suggested, and the development of new drug delivery system that can improve the efficacy of the existing drug. Thank you so much.
Thank you, Dr. Vikas Shankar, for such an elaborative presentation. Now, is there any question from the audience?
Two questions. One is the soap and powders and all, they are so much promoted. Do they have any place in the management of the fungal infection? Ketoconazole soap, powders.
Sir, actually there is two school of thought, but personally I don't promote this. But in some school they say ki, for the hygiene part they may use, but it's
Any other soap will do that, no? We don't have to add the
but particularly if you, I don't promote this antifungal soap or anything.
Second is, this is a very conjectural question since you have gone so deep into it. In leprosy, we use multi-drug therapy to prevent resistance. And those drugs are also very toxic. So why don't we go for multi-drug therapy in case of fungal infections to overcome this? Why do we always say that we should give only one drug at a time and not combine two drugs?
Sir, many of the cases in practically when we see the prescription from other dermatologists, actually they are using two-drug, multi-drug, but no documentation has been done. But personally, I am not using this because it says ki if you, there is again two things. If you choose the molecule, what molecule you're using, the same drug you should not use, but it's a good idea, we can do this.
Dr. Vikas, very nice presentations. So topic is, are we losing tinea? There are some, lacuna in our day-to-day practice and in the literature. Is there any updated guideline regarding what is the current treatment durations for different types of tinea? If yes, please share. Second thing, what is the definition of clinical cure when we think that patient is completely treated for tinea, okay? And what is your opinion regarding the shared dermatophytosis? We ask family history in scabies, but why not in case of dermatophytosis? Maybe a person, a family history positive, and the fomites that may cause recurrent, and that we rename as a recalcitrant or resistant tinea. Please.
For the guideline, I have not gone through the guideline of tinea, very honestly I am telling you. But what we follow practically is itraconazole we are using but there is again two school of thought. One is that suprabiological dose and one is conventional. So this debate is also going on even in our institute also. But I personally prefer the conventional dose for this. But again, the guideline is don't use the same molecule as a topical as well as oral. So it will promote the this resistance. Then your second question was?
Shared dermatophytosis means if there is a family history, suppose that may cause recurrent tinea,
Yes. So in my presentation, I have already said you have to take a proper history. You need to see all the body parts, including nails, because nails is a reservoir part. But family history is almost most important. Then again, the sharing of the clothes, how you wash it. So these are the factors which may promote the tinea infection and later on the resistance.
Since there is no more question, therefore I would like to conclude the session. Thank you.
Thank you.
Thank you, sir, for enlightening session on such a common topic. I would request our chairperson and speaker to kindly collect their memento. Proceeding forwards for the next session, I would like to invite Dr. Anita Badua ma'am, Dr. P.C. Rath sir, and Dr. Umesh Chandra Gupta sir kindly on the dais to chair the next session. Dr. Anita Badua ma'am, Dr. P.C. Rath sir, and Dr. Umesh Chandra Gupta sir. Kindly grace the dais.
Now our next speaker is Dr. Mandeep Bhukar. He is the consultant dermatologist, the Sri Sai Skin and ENT Clinic, Rohtak, Haryana. Now at the present, the President IDVL, HSP 2026, member of IDVL, AQC Legal and Ethics Committee 2025-26, member of IDVL Constitution Committee 2026, member of IDVL SIG Aesthetics 2026, life member of IDVL Clinicon Association, eminent speaker at national and international conferences, and he is MBBS and DDVL, designated consultant dermatologist. Now I request Dr. Mandeep Bhukar to please come to the dais and deliver a speech.
Good afternoon, everyone. Thank you, sir, for the nice introduction. So today I'll be talking about the cutaneous marker of HIV. Mucocutaneous manifestation are common in HIV with prevalence ranging from 68.8 to 90%. They may indicate the presence of HIV or a degree of immunosuppression or a failure of antiretroviral therapy. The lesions in the HIV usually presents as atypical features. The starting and continuing the ART reduces the chances of recurrence and induces the remission phase. In the frequency of mucocutaneous manifestation, most commonly seen is oral candidiasis followed by dermatomyositis, herpes zoster infection, bacterial infection, and seborrheic dermatitis. In the classification of different types of mucocutaneous changes which we see in HIV can be classified into infective, non-infective, hair changes, nail changes. Coming to the infective causes can be classified into viral, fungal, bacterial, and parasitic infections. We will be covering each in detail. And non-infectious manifestations like seborrheic, pruritic papular eruptions, eosinophilic folliculitis, Ritus syndrome, psoriasis, xerosis, demodex, pityriasis, folliculitis, papular urticaria, and neoplasm like Kaposi sarcoma. So coming to the infective causes, first of these infective causes are more common than the non-infective dermatosis in HIV. They usually present late in the disease. Most of the time they present when the CD4 count range in 200 to 500 cells per microL. So we can consider skin as an organ for assessment, prediction of immune status, also for the management of HIV and AIDS, and especially in the resource poor settings. The first foremost is acute exanthema. It denotes the seroconversion. Usually it is seen after 2 to 3 weeks of HIV infection. It presents as a maculopapular rash which is symmetrically distributed, and it is a self-limiting condition. Coming to the next infection, HSV infection. HSV infection is a synergetic relation with the HIV. The patient having a HSV infection have a risk of developing HIV as a 2 times risk. When the HSV non-healing ulcer present more than 1 month duration, it is a AIDS defining lesion. The initial lesions are usually the typical and they heal spontaneously, but as the AIDS HIV infection advances, the lesion become atypical and run longer course and respond poorly to the treatment. Here we can see the classical lesion of the HSV. One, when the genital lesions are present, they extend up to the perianal area, buttock and abdomen. When the lesion present on the tongue, they can also involve linear and branches on the tongue, leading to a geometric pattern. On the fingers, it present as a herpetic whitlow. Coming to the next type of viral infection is varicella zoster infection. When herpes zoster present in HIV, it has a 3-time risk when it is seen in a HIV patient. The incidence has reduced due to the ART therapy. Normally, when the HIV infection in initial stages, it present as a typical unidermatomal, but as the HIV infection or AIDS develop, it becomes multidermatomal, having a severe systemic involvement, and it run a longer course than the usual course. Here we can see the multidermatomal involvement of herpes zoster infection in HIV positive patient. Human papilloma virus infection, the relationship between HIV and HPV infection seems due to an altered cell-mediated immunity, increased susceptibility, reactivation of latent HPV infection, and a local cytokine imbalance which facilitate the infection of HIV in a patient in HPV infection. Condyloma may promote the HIV transmission. HPV infection in HIV positive cases tends to become diffuse and occur at multiple sites. It can be present as an oral fluoride papillomatosis or EDV. When there is a risk of invasive carcinoma of both cervix and anal canal, in a HIV positive, it becomes the marker of the disease. Next infection of viral is molluscum contagiosum. Incidence is 10 to 20% when the HIV patient. The lesions commonly present at genital, face, especially on the periorbital area, axilla, groin, and buttocks. Molluscum contagiosum in HIV tend to run a prolonged course and they are resistant to the treatment. In AIDS, we can see more than 100 lesions which show a little tendency towards the involution. Here we can see a molluscum lesion. Sometimes they mimic the wart also because of the bigger size and a grouped molluscum bodies. Next infection is oral hairy leukoplakia. This infection indicates declining immunity along with the oral candidiasis, which is a marker of immune status. It indicates lower CD4 count, higher viral load, and faster progression to the AIDS. It presents as an asymptomatic raised, corrugated white colored lesion frequently seen on the lateral side of the tongue. It resembles the oral candidiasis which appear on the surface of the tongue and buccal mucosa. Oral candidiasis is easily removable, but oral hairy leukoplakia is not easily removable. It is diagnosed by a clinical presentation, no specific treatment, resolved about 5 months after the treatment of starting of ART. Recently, literature says the oral hairy leukoplakia has no longer regarded as a pathognomic to the HIV or a systemic immunosuppression. Here we can see the lesions of oral hairy leukoplakia. Cytomegalovirus infection usually seen when the immunosuppression is severe, when the CD4 count less than 50. About 90% of the patient of AIDS develops cytomegalovirus infection, and 25% of which later lead to life-threatening condition. Coming to the bacterial infection, in bacteria, Staphylococcus aureus is the most common cutaneous and systemic pathogen seen in HIV-infected patient. This will be due to the higher rate of nasal carrier in HIV-infected patient. It can present as folliculitis, furuncle, carbuncle, impetigo, ecthyma, cellulitis, or botryomycosis. Bacillary angiomatosis caused by a gram-negative organism Bartonella hansleyi and Bartonella quinetana. Usually it is seen in the late stage of the HIV patient when the CD4 count falls below 100 cells. It presents as an angioproliferative lesion affecting skin, mucosa, and internal organs. On the skin, it presents as a small violaceous to red papule and nodules. Lesion clinically resembles to those of Kaposi sarcoma, pyogenic granuloma, and angiosarcoma. The lesions of bacillary angiomatosis must be regarded as a marker of possible internal involvement in the cases of HIV. Mycobacterial infections. It's a reinfection or reactivation of Mycobacterium tuberculosis seen in early HIV infection. Clinical presentation can be seen as a scrophaloderma, scattered, voliceous papule, nodule, palmoplantar, keratoderma tuberculoids, or keratotic papules. Culture positivity is not always obtained because the skin lesions are typically post-bacillary. We can see the cervical lymphadenitis, paraspinal cold abscess are seen. In atypical are due to the Mycobacterium avium intercellular. It occurs as a part of disseminated infection when CD4 count falls below 50 cells. Next condition is histoplasmosis. A disseminated histoplasmosis can be a most frequent opportunistic infection in AIDS, especially in people living in an endemic area. The skin lesions are present in 10 to 20% of the cases. Clinical picture will be exanthema-like maculopapular rash or molluscum-like papillonecrotic lesion, oral mass, oral ulcer, diffuse purpura, or paniculitis. Among the fungal infection, candidiasis remains the most common mucocutaneous infection in HIV, irrespective of the geography, race, or adult or children. Heart does not have highly active antiretroviral therapy does not have any effect on the oral yeast colonization. CD4 count falls below 200, and then we can see the candidiasis infection. Candida albicans is the most common pathogen found. It can present as a pseudomembranous, atrophic, or hyperplastic. When there is involvement of esophageal candidiasis is a AIDS defining illness. Vulvovaginal candidiasis occur in early HIV infection. Cutaneous candidiasis is not very common. Here we can see the oral candidiasis as a pseudomembranous and hyperplastic. Dermatophytosis. This infection is usually more commonly seen in the people who have more immunosuppression. So homosexual men are more likely to have a superficial fungal infection regardless of their immune status. Tinea corporis, cruris, pedis, onychomycosis all occur in the patient with the HIV infection. The lesions of tinea are they don't have a raised border or central clearing in AIDS cases. These are the pictures. Trichophyton rubrum is the most common pathogen found in HIV with the tinea infection. Widespread dermatophytosis is not common in HIV. Atypical presentation like pseudoimbricata, purpuric lesion, facial papules mimicking eosinophilic folliculitis can be seen. Tinea capitis is in adult could be a sign of HIV infection. Coming to the parasitic infections. Scabies, the crested scabies or Norwegian scabies is a clinical manifestation depending on the degree of immunosuppression. In the early stages, it presents as a typical scabies lesions, but as the later stage of AIDS, it becomes more contagious, fulminant, involving the head and neck involvement, but there is no itching as the disease progresses. On any atypical itchy rash in HIV patient, we should always think of scabies first. Lesions are usually ranging from classical to thick crusted plaque to red papule or a psoriasiform plaques or hyperkeratotic yellow papules or eczematite lesions. Leishmaniasis typically present on the exposed part of the body, especially face, scalp, and arm, appear initially as a painless erythematous papule which later enlarges to form nodule or plaque up to 2 cm. End stage represented by a scar accompanied by hypo or hyperpigmentation. Non-infectious manifestations. Seborrheic dermatitis, the common HIV-related cutaneous manifestation occur when a CD4 count is more than 400. Patient develops severe and extensive spread. It's a HIV marker could be present. The presence could be indicate a rapid progression of HIV. Although the hypersensitivity of pituitary yeast was considered to be the cause, but recent studies fails to show yeast overgrowth in the seborrheic dermatitis. Erythroderma due to seborrheic dermatitis could be a sign of HIV. Advanced HIV, the disease is more disseminated, affecting the forehead, malar area, chest, neck, growing area. Pruritic papular eruptions is a common manifestation, more commonly seen in tropical and subtropical countries, more commonly seen in advanced HIV. It's a diagnosis of exclusion. Other DTs for that is eosinophilic folliculitis, scabies, drug reaction. Eosinophilic pustular folliculitis, unknown etiology, usually present as a sterile inflammatory dermatosis. Sudden onset, a disseminated follicle centroid by the pustule, typically on the trunk. Lesion seen when the CD4 count falls less than 250. Ritter syndrome is evidence for the increased incidence for both Ritter syndrome and psoriasis in HIV is a conflicting. Ritter syndrome with AIDS is a more serious condition with showing a rapid progression and refractory to the treatment. Psoriasis is an immunodysregulation resulting from HIV which may trigger the psoriasis. JAD guidelines suggested avoidance of cyclosporin or methotrexate when the HIV is present in a psoriasis case. Psoriatic lesions in HIV are more severe, acral, extensive, destructive and recalcitrant to treatment. Psoriasis in HIV is a predilection for the scalp, palmoplantar area and flexor areas. The paradoxical exaggeration of the psoriasis in HIV has not been fully explained. The proposed reason could be some immunological event like decrease in the number of Langerhans cells, altered CD8 to CD4 ratio, increased synthesis of nitric oxide by the macrophages, or increased colonization of the skin by Staph aureus. Oral manifestation could be early marker of HIV and the progression. With start of antiretroviral therapy, the incidence of oral manifestation has reduced greatly. Oral candidiasis can be present as pseudomembranous erythematous or hyperplastic or angular cheilitis. Oral hairy leukoplakia we already talked about. Kaposi, non-Hodgkin's, Hodgkin's lymphoma, melanotic hyperpigmentation, HSV infection and HPV infection can be there in the oral cavity. Oral warts are more often seen when the patient is receiving ART. Oral ulcers are common in both male and adult and the children, commonly seen over the soft palate, buccal mucosa. Parotid involvement in children is commonly seen, which is a bilateral, non-tender. Swelling usually indicates the proliferative phase of the lymphoproliferative phase of the HIV. Oral involvement, oral melanotic hyperpigmentation, unknown etiologies, they commonly seen in 30% of the cases, which presents as a blue-black patch on the tongue, buccal mucosa and palate. Photosensitivity, HIV has a higher prevalence of UV exposure, responsive skin diseases. PUVA therapy and UVB therapy shown their efficacy in the treatment of many dermatophyte-associated HIV. Photosensitive eczematous dermatitis and chronic actinic dermatitis can be a presenting feature of HIV. Girosis and ichthyosis can be seen in cases of HIV, which appear as a polygonal skin-colored or light brown scale over the legs and the trunk. Marker of the disease progression is as it corresponds to declining CD4 count. Neoplasms, sarcoma, Kaposi sarcoma and non-Hodgkin's cervical cancers. When the CD4 count decreases and AIDS advanced stages, these are the conditions which we can see multiple times. And last topic, the HIV-associated Kaposi sarcoma. 95% of the homosexual and bisexual men have the Kaposi sarcoma. Etiology can be genetic marker. Immunodysregulation, retrovirus, HHV8 infection. Clinically, they present involved as a respiratory or GI involvement. Classical lesions are on the distal extremities. Cutaneous lesion present as a 3-stage, macular, plaque and the tumor stage. Here we can see the picture. And the nail changes we can see in 8.3 to 67.7%. Color changes indicate a lower CD4 count. Onychomycosis remains still is the 4 times more common in HIV infected people than the general population. These are the infection in the nail, onychomycosis, paronychia, color changes, longitudinal melanoica, leukonychia, transfer lines, and the shape changes like clubbing can be present or onychocesia, and less common but serious are HPV related squamous cell carcinoma and monkeypox co-infection. Thank you.
Thank you, Dr. Mandi Bukar, for his excellent presentation on the cutaneous markers of the HIV. Is there any questions from the audience? If there is no question asked, then we can end this session. Thank you.
Thank you.
Thank you so much, sir, for this wonderful session. For the next session, I would like to call upon the stage Dr. Shushri Shashwat Shahu and Dr. Kishlay Saurav Jha to kindly chair the session. I would request our last speaker, Dr. Mandi Bhukar sir, and our chairpersons to kindly collect the mementos.
So, the next speaker is Dr. Shivani Shekhar, who will be talking about recent updates in diagnosis and management of scabies. And she is a senior resident in Nalanda Medical College, Bihar, and Best PG Award paper in 7th Clinicon, and Dr. Amarkant Jha, Amar Gold Medal for Best PG in PMCH, and Dr. Vikas Shankar Gold Medal for Best PG in PMCH. Over to you, Dr. Shivani.
Thank you so much, sir. So, today I am talking about what is new in scabies. I think scabies is something which is considered as a marginalized section in clinical dermatology. We see it daily, we deal it daily, but we don't think twice before treating the patient, and we just take it lightly. So, let us discuss about this light topic. So we all know that scabies is an ectoparasitic infection which is itchy, highly contagious, and is caused by female Sarcoptes scabiei mite. It spreads from direct skin to skin contact, and it may transmit through fomites in case of crusted scabies. So what is the actual burden of scabies? Actually what happens that when scabies patient walks in, what we do, we see the patient, we treat the patient, and then we forget about it. But we never think what is the burden of scabies in the society that we are living in. So yes, WHO has recognized in 2017 it as one of the most important neglected tropical disease. And according to 2021 Global Burden of Disease study, scabies affects approximately 206.6 million individuals worldwide at any given time, with an annual incidence reaching 622.5 million new cases. Imagine the load of scabies in the society that we are living in. Scabies is prevalent, and prevalence ranges has a very wide range. It ranges from 0.18% to 76.9% in population-based studies. And high prevalence is seen in obviously poor areas like Pacific Islands, Sub-Saharan Africa, and Southeast Asia, the place we are living in. So we need to talk about scabies. So in East and Southeast Asia, the highest disability adjusted life years are observed in children who are aged between 1 to 4 and followed by adults which are older than 70. That means scabies is affecting the most distant age groups, means younger age groups and older age groups. It is affecting those which are neglected in the society. So we must think about it. And since the early 2000s, several Western European countries have reported a rising incidence in the general population due to travel, refugee status, and COVID-19. Post-COVID-19, there has been a surge in the case of scabies, obviously due to known reasons, due to lockdown which has occurred. People have gathered together, and there is insurgence of scabies cases. So we all know in developed countries, it is generally seen in those areas where there is grouping of individuals in schools, in old age homes, in jails, and in refugee camps. So actually, why are we bothering about scabies? So in 2021, it was seen that scabies caused 5.3 million disability adjusted life years. Case load has increased after COVID-19, as I have already talked about, and it has been seen that the age adjusted disease adjusted life year is more than ALL and arrhythmia.
Just think ALN and arrhythmia, one of the most serious conditions, the DALY of scabies is more than these two conditions. And it also has many secondary complications such as impetigo, abscess, cellulitis and necrotizing fasciitis, septicemia, nephrotic syndrome and acute rheumatic fever due to streptococcal infections. So scabies being an innocuous disorder itself can cause serious secondary complications, and so we should bother about it. So we all know when patient walks in, most of us, we are doing clinical diagnosis of scabies. What we are doing, the patient comes in, says that I have itching all over my body. We ask them, when are you having itching? The patient tells at night. Then we are asking the second question, is anyone in your family is having scabies? The moment the answer comes yes, we write diagnosis of scabies and give the treatment, and then it is done. This is what we are doing. This is conventional practice that we are been practicing. But I think this is not sufficient now. Why? Because this clinical criteria is not uniform. It is highly subjective. It changes from person to person depending on their what history they are having of their clinical practice. So also there are several dermatoses which are presenting with similar complaint of generalized non-specific itching, in which atopic dermatitis, senile xerosis, papillary urticaria, and there are certain chronic diseases like chronic kidney failure which is presenting with generalized itching. So there is high time we need to have a proper diagnostic criteria for scabies, and that was what was exactly done in 2020 International Alliance for the Control of Scabies consensus criteria. In this there were three different levels in which scabies was diagnosed. First was confirmed scabies, which we kept as A. In that we have to see the causative agent or its byproduct in any form. Either we can detect it by light microscopy of skin samples, or we can see it in the individual by using high-powered imaging devices, or we can visualize it by dermoscopy. B comes clinical scabies. If we are able to demonstrate scabies burrows, or we are seeing typical lesions affecting male genitalia, or there are typical lesions in typical distribution and there are two history features, that is pruritus and history of individual in close contact having itching, then we are saying that it is clinical scabies. It is not confirmed, but it is clinical scabies. And C is suspected scabies, in which if patient is coming to you with typical lesions in a typical distribution with one history feature, then we are thinking it can be a scabies. Or if there is patient with atypical lesion or atypical distribution but two history features, that is a history of close contact and pruritus. So this is the proper diagnostic consensus criteria for the scabies diagnosis. So what is the advantage? It can be applied to a variety of settings. It can be applied in higher settings where all the sophisticated tools are available, and it can be applied in lower settings like in field settings, because it has given a place to clinical diagnosis of scabies as well. Also it has limitation. Yes, this criteria is having limitation. It does not include crusted scabies or atypical presentation of scabies. Therefore, clinical judgment is still going to be very essential for diagnosing scabies. So now what are we going to see? If we are going to do light microscopy, we are going to see these pictures. First is that of a female mite. Second is of the eggs in the female mite, and third is Kybala, that is the mite excreta. So these three things, if we are able to see in light microscopy, that is a case of confirmed scabies. Now the specificity is high, but sensitivity is low. If you are not getting it, then you cannot say that this is not a case of scabies, because the mite load in a general case is very low. It is mostly 3 to 4 scabies mite, so it may not be seen. But if you are able to demonstrate it, the specificity is very high. It is gold standard test, and detection rate is generally 10 to 70%, again a very wide range. Next, in these pictures we can see that this is used by high powered imaging devices. We can see there is a V-shaped scaling on the inner surface of fingers. So this is a sign of scabies. Again, we are able to see in dermoscopy there is burrow, and on the right side in the encircled one there is the female mite, And this is reflectance confocal microscopy. We can see the female mite in the picture. And finally, dermoscopy. There are certain dermoscopic signs for diagnosing scabies. Delta sign, in which we can see the black point in the encircled, that is the mite, and the whitish trail is there, which is the burrow. And if you do UV dermoscopy, you can see the ball sign. What is ball sign? Ball sign is nothing but burrow. At the end of the burrow, the oval structure is the female mite. And noodle sign is seen in crusted scabies. You can see so many burrows that are lined by this black lining, which is actually the excreta of the mite. So this is noodle sign seen in crusted scabies. So actually, what is new in the diagnosis of scabies? These are all things which we are doing. But what is new? So there is PCR, polymerase chain reaction. What is the target? The target is COX-1 gene, mitochondrial 16S rRNA gene, and ITS2 regions. So these are the targets which are amplified. Real-time qPCR has shown 100% sensitivity in some studies, but also we can monitor the treatment response, because in PCR we can see that the DNA copy has declined. So we can see that the treatment which we are giving is showing result or not. And sampling is done by standardized dry swab sampling, which is emerging as an easier non-invasive tool for cluster diagnosis in the peripheral areas or in community diagnosis. Second is serology. In serology, we can detect IgE or IgG antibodies against recombinant scabies antigen. It shows high sensitivity and specificity, but faces challenges because it has cross-reactivity with common house dust mite antigen. And again, there is isothermal amplification test, which offers a promising alternative to PCR, as it does not require a thermocycler and it can be more suitable for low resource settings. But these tests are not yet field ready. These are still in studies and we need to follow it more. So we all know what are the treatments we are having. We all know permethrin, ivermectin, sulfur ointment, benzyl benzoate and crotameton. These are the classical treatment options for scabies. I will be discussing first what is the current scenario, why we need to discuss about newer drugs in scabies. So early clinical reports of scabies resistant to permethrin has emerged in early 2000s, and these resistant reports have emerged not from poor countries, it has emerged from richer countries, Australia, Austria, Italy and UK. So these are reporting resistance to permethrin. So this table is a table about how resistance has spread. So resistance to permethrin is due to target site mutation. The voltage-gated sodium channel to which permethrin binds and causes its action has been mutated, and permethrin is no longer able to bind to these channels. Again, there is mutation in glutathione S transferase enzyme, which is present in mites. It causes the breakdown of permethrin and ivermectin, and the activity of these enzymes has raised in mites. So permethrin and ivermectin clears more easily in these mites. Again, resistance to ivermectin has arisen due to receptor modification. It binds to ligand-gated chloride channel, and again it has modified, and ivermectin is no longer able to bind to it. There are multi-drug resistance protein which are able to pump out these active molecules, ivermectin, outside the mite body so that it cannot cause its actions. And finally, there is signal transduction pathway mutations seen in mites to ivermectin so that ivermectin cannot cause its actions. So mites are showing resistance in all possible ways, in binding, in transferring signals, in efflux pumps, everywhere. So yes, as I have already talked about, there are so many ways in which there is resistance pathways. So what is new in our arsenal? We have got spinosad. Spinosad 0.9% was recently FDA approved neurotoxin, which was formerly approved for head lice treatment. It is derived from a bacterium Sacropolyspora spinosa. It is effective after a single topical dose with minimal systemic absorption. This is a good point about spinosad, and it has shown higher efficacy for classical scabies with a strong safety profile. Again, there is one oral drug which is moxidectin. It is a macrocyclic lactone related to ivermectin. It was FDA approved for onchocerciasis. It acts on GABA and glutamate-gated chloride channels. It has an advantage that it is having a longer half-life, that is of 23 days, which can cover the full mite life cycle and has superior skin penetration. So single dose is efficacious. And current status of this drug is that it is in its preclinical trials showing better efficacy than ivermectin, and human clinical trials are currently underway. Again, other drug is oral afoxolaner. This is isoxazoline group class of drugs which are veterinary medicines for management. It targets the nervous system of mites. It is also having a very long half-life and single dose is effective. It has shown promise in porcine models. Again, there are some agents which can be used as permethrin synergists or combination therapies. It inhibits the metabolic enzymes glutathione S transferase and thus helps to prevent and keep the drug for a little longer in the mite body. These synergists are piperonyl butoxide and SS-tributyl phosphor triethioate and diethyl malate. These are the chemicals which can be used as permethrin synergists, and it is usually used in combination with oral ivermectin and topical permethrin. Again, there are some natural and plant-based agents which are under investigations. In this, there is tea tree oil. It contains terpenine 4-ol, which has shown potency in vitro acariciidal activity, which is superior to ivermectin, and zerianol, which is derived from Apiaceae family, and it has demonstrated 100% mite mortality in vitro tests and is being researched. So this is my last slide. I would not like to end it without discussing something about crusted scabies. So there is grading about crusted scabies as well. So in crusted scabies, we need to see the distribution and extent of crusting. If the body surface area is less than 10%, the number is 1. And as it goes on increasing, we give 1, 2, 3 like these points. Similarly, crusting or shedding is considered. If the depth of crust is less than 5 mm, this is 1 scoring, and if it is more than 10 mm, it is 3 scoring. And if the patient is having past episodes, again scoring is done according to it. And again we consider the skin conditions. If there is no pyoderma, no cracking, then the point is given 1. And if there is deep skin cracking with bleeding, widespread purulent exudates, the number is 3. So depending on the grades, depending on the scores that we calculate, we can give grade 1, 2, 3 to crusted scabies. If score is 4 to 6, it is grade 1, 7 to 9, it is grade 2, 10 to 12, it is grade 3. And if there is grade 1 crusted scabies, we need to give 3 doses of ivermectin on day 1st, 2nd and 7th day. If there is grade 2 of crusted scabies, we need to give 5 doses of oral ivermectin, which is day 0, 1, 7, 8 and 14. And if the grade is 3, then we need to give 7 doses of oral ivermectin, which is 0, 1, 7, 8, 14, 21 and 28. So at last I just want to end this, that till now scabies has been treated as something which we are just seeing and dismissing. But we need to be more conscious, we need to be more clear about what we are dealing with, and we should be little more considerate about scabies. Thank you.
Thank you so much for such an informative as well as interesting topic. Is there any question from the audience?
You mentioned spinosad, right? Is it available in India? And
I don't think, till now I don't think it's available in India.
because I think it is there in the Gulf now, Dubai and now
Yes,
they're using.
yes, sir, but so it is not available in India.
And the second one, moxidectin.
No,
also.
so it is still in preclinical trials. Yeah.
Acha.
Yes, yes.
Thank you.
One of the greatest issues is the mite coming from the pets, animals. So how do you go about tackling that? Means if a person comes in the history taking, you said about family and all, but you did not mention about the pets. So what is the role and how do we tackle
So
that?
actually we all know that when it is transmitted through pets, it doesn't spread from one person to another. It's like an end of the cycle. So we are going to treat the person and it will get treated. So
And the pets?
the pets also we need to get treated, but from person to person it is not going to transmit like classical scabies.
And what is the treatment when we get it from pets? The same? Once now and after 7 days, same way? The regimen is same?
Yes, sir. According to my knowledge, we are treating it in the same way. But sir, obviously you can enlighten us.
I don't know. I am asking you.
No, sir.
You are the
No, sir.
scabiologist today.
No, sir, but we are treating it in the same way.
Sir, I have known about animals. So if they get scabies, we repeat it after 1 week again. Like one dose of
would you-
ivermectin, 10 milligram.
As a dermatologist, would you ask them to give the same medicine to this thing? Or
Sir,
to take them to the
ivermectin
vet?
is same. Like the ivermectin we use for ourselves is same that
same
is
in for
used in
pets.
dogs and cats
So
as
you
well.
tell them to give it to the
Yes.
animals also.
That comes in a 10-gram dosing. 10 milligram dosing. So either we can give the 12 milligram dosing that we have for us, or the one that is available for dogs is 10 milligrams. So treat them as well. So the cycle ends. Thank you so much, Dr. Shivani, for this wonderful presentation. Thank you, chairpersons. I would like to request Dr. Shivani Shekhar and our respected chairpersons to kindly collect their memento. For the next session, I would like to call upon the stage Dr. Mercy Paul sir and Dr. Sukumar P sir to call up our next speaker.
Very good afternoon to you all. We have a very interesting session to be led by Dr. Sunil Kumar Gupta. Very interesting topic. He has been the professor and HOD of All India Institute of Medical Sciences, Bhubaneswar, and he has got several publications to his credit. And his field of interest are clinical dermatology and impact of lifestyle on diseases. And he has received several awards to his credit. It's too long to mention. Okay? He's really a very good speaker. Over to Dr. Gupta.
Thank you, madam. There is some correction is required. I am Dr. C.S. Sirka.
Sorry, okay. Sorry.
Thank you very much.
Because
Okay,
I'm
no-
supposed
no-
to chair
no
the
problem.
session of Dr. Gupta. So.
Okay. So I was a Seki before coming to the stage because I has been told that I'll talk on the case-based cutaneous tuberculosis and atypical mycobacterium. I thought that when I got a call that I thought that I'll just speak from the book and they will be satisfied. But suddenly I got a second call that they told me that the way that you teach in the word, you do have to teach. So when I was thinking that how I'll talk to you, I could see that there is a third sense that you need to teach someone or to make a diagnosis. You cannot make a diagnosis just by reading book because you do have to identify that one on the skin. That means you do have to apply that knowledge on the skin and you got to have a skill for the applying that one. Otherwise if you don't have a skill, you cannot do it. So I'll show you some examples before I go into the topic proper. My understanding about the case-based talk is the application of the book knowledge on patients with use of skill, application of skill that is learned by the hard work. I'll also give some examples what are those hard works you need to do. Without doing that hard work, you won't be able to do anything. Then another one is just self-reliance. You must remember that the post-graduation skill, what we teach them, the clinical skill, it is a self-reliance skill. They don't need anyone's help. They do it themselves. And another one is application of a discipline. If you are not disciplined, then you won't be able to make a diagnosis. My layout is example of a skill, discipline learned during the hard work. And another one is case-based discussion on cutaneous tuberculosis. Let me tell you, this is the ideal one that what you follow. You listen to the history, examine, make a clinical diagnosis, do a test, and make a final diagnosis. But what I feel is that it is not good for a dermatologist. The dermatologists don't just simply listen. They just see, They will see that one, they will inspect the lesion, then they will listen. If you tell something wrong to the dermatologist, he will not will to listen. Like if you have a vesicle and if you try to tell him that it started with a scaling, he's not going to just simply listen. That means you need to inspect, then listen, then examine. Then what you have to do is when you have this one, you do have to this thing. Whatever is there on the skin, there is another thing. You cross check. You just simply don't listen anything. Somebody tells you something and you don't listen that one. You cross check and do this one. Then what is that? The next one is relate these findings to the pharmacokinetics of the drugs that what he used and the risk factors what he is exposed to. Because it could just simply change that one. If you are not having this skill, then you won't be able to do that one. Then the next one is you do have to prioritize. If you see a scale, then you think that whether it is a part of some disease scale, primary disease, or it is a secondary one. So you also make a prioritize. Just you do not listen that anything is there can lead to a diagnosis. Once you have this one, you do have this one. Now, once you make a clinical diagnosis, it will allow you to make a test that is based on your clinical diagnosis. It's not just that you order a diagnosis based on the clinical diagnosis. Then once you do this test, then you try to correlate the test results also, whether they are correct according to your thinking or not. That means these are the steps that you do have to use. That these steps are required for making a clinical diagnosis. But if you are not doing that one, then you might do a blunder. Suppose you do a test first and try to do this one and don't do these steps. That means complete blunder. That is what we are doing at this point of time in all the cases, especially we are doing in tinea. We do this one and try to make a diagnosis. We do not correlate. We do not do this thing. So that is why we are having a real problem with the situation. Let me tell you some few examples. For examples, this is a patient of tinea. Then he came, we wanted to do a test. You see, you can go you may go and do a blunder. Because test is something will come, and if you don't correlate, then it will give you something else. And if you are not doing a hard work, then also you won't be able to do it. If you look at the hard work, there are papules, they might undergo this kind of changes. They might undergo this kind of postulation. They might undergo this kind of postulation. And sometime they might dry up and scale, and sometime an individual papule can evolve into this thing. If you are not used to this system, you see a pustule, you say a secondary infection. You see a pustule, you say it is a pustular psoriasis. You see a something and you do. So you do have to be a regular in your duties so that you try to understand every beat of the changes that takes place in a lesion on every other day, so that you can say this is quite possible with that one. Otherwise you won't be able to do this one. Let me tell you one thing, the daily hard work if you do, if you have a postulation, you look at this, tinea can undergo this kind of changes. It can have a postulation, it can have this one. Second change, it can undergo this kind of changes. Suddenly, each papule can evolve into this one. That means if you are not having a clear-cut, hard work experience of yours, if you don't have a skill, then you will do wrong. You will have always a thinking that everything appears on the treated tinea site is a tinea, and if the KOH comes, then it is also tinea. And you got to have an extra skill, something like this. If you have an extra skill, if you are marking the border and if the lesions are not spreading, there is a strong indication that it is not tinea, because tinea has a very characteristic idea that it will move beyond the border, because it will need food and it will move for a food. But if it is not enlarging, then you will have this one. And if you are not examining also, there is another changes that you see. You might have suddenly erythema appearing, or you can have an appearance of erythema this thing, and you see suddenly they will also subside within scaling. If you are not examining daily, if you are not doing a hard work, then you will think that these are tinea also, because the scales are always seen in there also. And if you have a massive edema, then you can have a vesiculation and blister formation. And you might have a pustulation too. And if you are having this thing, you might have this kind of changes. If you leave it chronically, if you don't treat, then it can look like this. That means these are the skills that one has to have. If you don't have this skill, you cannot make a diagnosis. Can anyone say what is this? This is cutaneous tuberculosis, scroflodoma. So scroflodoma is a very simple one. A lymph node swelling, then they will have an ulceration. But somebody would ask you why. Visibly you can make a diagnosis. Why? That means you do have to identify the morphology which are there. That means let me tell you one. Mild inflammation, that is why no peeling and no erythema also. It is almost like a skin color. That is why mild inflammation. Gradually enlarging over weeks. If you ask the patient, even the center part is also not softened. And almost the same in texture or consistency if you are palpating one. Ruptures over 3 to 2 weeks. It will take some time to get softened in the center. And serosanguinous discharge, because it will have a necrosis of the tissue in the center, and that will have this thing, cageating necrosis, that will have this thing. And since the tissue has come out, it will have a puckering. Since the chronic change of an inflammation was mild, you are going to see a perilesional pigmentation. So this is what. That means if you can recognize, you can identify, then you can make a diagnosis like scroflodoma. It looks like this. Look at every lesion has got that perilesional pigmentation. Then there is a dipping, there is a perilesion pigmentation and all that. And there is a this thing. So that means it is a consistent finding. That one you do have to really identify that one. Then the next one is, what is this? Can anyone make a diagnosis? This is tubercular gamma. Because everybody will ask, why did you say that one? So if you look at this one, they almost look like a scroflodoma only. They do have a faint erythema, no peeling of the skin. Only there is a center part is getting softened, and they will have in this one. They do have almost the same morphology, but only one thing is that these patients do have a lesion different, not a contiguous one. There will be hematological spread, so you will have a lesion on both the legs, other part of the body you are going to have this one. Evolution is a more important one. It gives you a pigmentation, is a very faint one, indicating that it is a chronic one and gradual and mild one, and there is no peeling of the skin, just like in furuncle or some other things like carbuncle. So that makes easy for you. Then another one is a evidence of a hematological spread, because that is why both the legs have been involved, because hematologically it spreads onto the different part of the body and it has caused these disease. You will see this kind of changes, but sometime it will become like this. If you see the Mantoux stage, it can become like this. Sometime we do say, but I told that the Mantoux stage can become like this if you have an atopic association also. So one has to assess that one. If you are not correlating, because that might induce a post-traumatic inflammation. So you do have to be really checking that one to find it. But otherwise, all the tuberculosis lesions, they do have a very peculiar finding, is a perilesional pigmentation, and the center part either ulceration or a puckering. This is one of the case we had this thing. Here also we had made a diagnosis for lupus vulgaris. They do have a very, lupus vulgaris has a very peculiar finding. They will have this area, as you can see. The nodular lesions, they will coalesce together to form that one. I'll show you the better one photograph I do have probably. What is this? This is lupus vulgaris. Everybody can make a diagnosis, but the question is why? Why did you say so? So if you are looking into this one, if you look at this, there is every lesion, there are, if you can see that multiple nodular lesions coalescing. So they are nodules, coalesce to form plaque, then the spontaneous healing may occur, then heal scar, and you see all the lupus vulgaris on this thing, what is there in the literature, you see, everything is a nodular lesion. So you do have to really learn to see that what is written. Otherwise, the book written is a plaque with a healing at one side and other side, and it can happen within many other diseases. Just you do have to really identify where is the primary disease, what is happening to that one, and how the larger lesion is been formed. That will give a sense to you. That will give you a clue that how you are making. Otherwise, you see all the lesions do have that kind of a nodularity. This is also the lupus vulgaris. If you carefully look at that, These are the nodular lesions what I am talking about, you are going to see. These are the nodular lesions, that is why they are not smooth, they are up and down. Psoriasis is a completely a smooth one, you do have this one. So this is what is, like, that is why we are trying to tell that it is also a Atmanirbhar skill when you do a post-graduation properly. Here you do have to look at this one, there are lesions. What is this? This is tuberculosis verrucosa cutis. And you see, this is just a transformation of a lupus vulgaris. Those I'm talking about a nodular lesion. Just only thing is because of the immunity, it has got a surface change in the form of this one. So that means you have to be very careful about and how you are examining. They will give you an example that, like, these are nodules developing verrucosity on the surface, enlargement of the lesion by the development of the nodules coalescing together. And the faint erythema is seen in this one because, like, it doesn't have in tuberculosis, doesn't have a massive erythema. And black dots are absent, that is why it is not chromoblastomycosis. This is what is tuberculosis verrucosa cutis. You can have a black dots, then you can think about a chromoblastomycosis. And this is another one which can look like this. Can anyone say what is this? This is botryoomycosis. Only the peculiarity is botryoomycosis, the nodular lesions, all the nodules will have a surface change over the nodule. Look at that. All the nodules, they are different from the surrounding skin. They don't produce a sinus. I'll show you something. Look at this. That is why the people call it like, it is a bunch of grapes. It looks like a bunch of grapes because the background skin is different and they are there. If you're looking at this one, they are also almost looking like that one. There is a surface change on the nodule and it doesn't have that. So this is what, like, if you, so some people do say is that failing to achieve a set skill, discipline, and you might develop a dilated pupil. So if you are not disciplined and if you are not having a skill, then you might have a dilated pupil. And the doctor's code for a dilated pupil, the brain death has occurred. So you must do the post-graduation with a much careful ideas. Means hard work has to be done. Everyone can make a cutaneous diagnosis tuberculosis. It's not a difficult one, but you do have to master this PG skill, and this can only be mastered by the hard work that I told. Means you do have to go daily, see changes after half an hour, see changes after 1 hour, see changes after 3 hours, what is happening, that will give you an idea. That is why the postings are like that. Hard work will help you to solve all the challenges, including TB, whatever the challenges now we do have, you can solve them also. Thank you very much.
Thank you, Dr. Sarka, for a very enlightening talk. Took us back to PG classes. Any questions from the audience? Apparently not. Thank you very much.
Thank you.
Thank you, sir, for such an enlightening session on cutaneous TB. I would request our chairpersons and speaker to kindly collect their memento. For the next session, I would like to invite Dr. Jayashree Das Pramanik and Dr. Radhakrishnan S. Nair to kindly chair the next session. Dr. Jayashree Das Pramanik and Dr. Radhakrishnan S. Nair. I would request our chairperson to kindly introduce our speaker.
Now, for the next talk, we have Dr. Sunil Gupta. He is the professor and head of the Department of AIMS, Gorakhpur. And he's a coordinator of IADVL SIG Leprosy 2023, WHO Working Group, the Skin NTD, Disability in Inclusion Team, Honorary Secretary of IADVL UP and UK 2023 to 25. He is Vice President of Indian Society for Precision Medicine and Molecular Medicine. Now he is going to deliver his talk on management of recalcitrant lepra reaction, a practical approach. Dr. Sunil Gupta, please.
Thank you, Chairperson. Very good afternoon to all. At the outset, first of all, I thanks to the organizing team of ACDI for inviting me. So as we know that leprosy is one of the ancient disease, and even still in our country, in different pockets, it is understand as a, the curse of the god. Okay, and in the indolent course of the disease, sometimes there are reactions, and that reactions leads to deformity and disability. That's why we must know how to address these reactions in leprosy. So I declare no conflict of interest and acknowledge to our junior resident, Dr. Rohit Singh Chauhan. So the disease burden about the lepra reaction is that 30 to 50% of MB cases develop reactions within 6 months after initiation of the therapy. And it is a leading cause of disability and deformity, and it is driven by, specifically driven by the immune dysregulations. Sometimes there is a heightened of immunity, and sometimes there is decreased immunity, and of course there is imbalance between the immune systems and the bacillary load. So what is lepra reaction? As already told, it is a acute episodes in the indolent course. It may occur before, during, or after the MDT, and it become a medical emergency if there is involvement of nerve, because if there is nerve involvement, it may lead to deformity and disability. But important thing, if patient develop reactions in leprosy, never stop MDT. What happens most of the time, patient consider that after taking the MDT, he or she develop reactions and he or she immediately stop the drug. But during the prescription of MDT to leprosy patients, always advise and counsel, never stop MDT. If you feel any problem, still you should continue the drug. So all of you know there are two major clinical presentations paradigms of lepra reaction, that type 1 and type 2. I don't go in details, but of course type 1 is very common in borderline lepromatous leprosy and BTSD and BBSD, and it is a type 1 hypersensitivity reactions. At the another pole, that is ENL or type 2 lepra reaction, it is mostly seen in case of lepromatous leprosy and sometimes the borderline lepromatous leprosy. And nerve damage is very important thing that most of the time is seen in type 1 lepra reactions. So what happens in type 1 reactions, that is reversal reactions, it may be upgrading or downgrading. Basically there is a balance when a patient develop leprosy, and there is a balance between the bacillary load and the cell-mediated immunity. If when we start, MDT, there is sudden decrease in bacillary load. So this balance is imbalanced. So there is heightened immunity, and that heightened immunity causes reactions, and that reactions present in the form of inflammations like the rubercular dolor and functionalisa. And this is very common in borderline pole, not in the polarized form. How can you recognize? In the form of sudden erythema, edema of the lesions, there may be painful nerves, and systemic symptoms are very rare. But always examine and check for nerve involvement. If there is nerve involvement, this is a medical emergency, and immediately manage the case. Sometimes what happens, clinicians confuse. If the patient is already treated with MDT and develop acute episodes, clinicians confuse, is that reactions, type 1 lepra reactions, or it is a relapse. So type 1 lepra reaction is acute onset, but relapse is insidious. Generally, type 1 reactions occur within the 6 to 12 months, and relapse occur after stopping the treatments and within the 3 to 5 years of MDT. That's why we advise to follow the patients even after the treatment. And in type 1 lepra reactions, there is erythema, edema of the existing lesions, but in relapse there is occurrence of new lesions, and in type 1 lepra reactions there is severe neuritis sometimes, and BI is not changed or decreased in type 1 lepra reactions, but in relapse, sometimes it increase. So if you diagnose that this is a case of type 1 lepra reactions, our primary goal should be rapidly suppress the inflammation to rescue peripheral nerves and prevent permanent paralysis or anesthesia. WHO recommend first-line agent in the form of systemic corticosteroids, prednisolone, 1 milligram per kg body weight, and supportive care includes the rest, psychological counseling, NSAIDs, and monitor nerve deformity in each and every visit. What the WHO said that we should start prednisolone immediately in moderate to severe type of lepra reactions with 1 milligram per kg body weight starting from 40 to 60 milligram, and we should continue for 12 to 24 weeks. Do not afraid with oral steroid, you should continue, and when the inflammation resolved, then you should taper in the monthly basis or weekly basis. Type 2 lepra reactions is also known as the erythema nodosum leprosum. This is generally seen in LLSD or BLSD. Here what happens, there is a type 3 hypersensitivity reaction, so there is immune complex depositions, generally seen on the dependent part of the body, and it is characterized by erythematous, evanescent, painful nodules in crops associated with constitutional symptoms in the form of fever, arthalgia, arthritis, architis, and keratoconjunctivitis sometimes. And the triggers are different types of intercurrent infections, physical or even mental strains. Even during pregnancy or parturitions, these conditions may precipitate. So you clinically diagnose with a crop of painful nodules present with systemic symptoms. And if you diagnose, you should grade the ENL. There is an enlist scoring system. You should found that in internet or on Google, that score the ENL in mild, moderate, and severe. For the mild ENL, we should continue MDT and advise rest and anti-inflammatory and check for the nerve involvement. But if there is severe ENL, then we should start either steroid or other supportive drugs. So the core principle is to avoid corticosteroids if there is reactions and it is purely mild. But if that is severe, we should start oral and systemic corticosteroids and with NSAIDs and supportive therapy in the form of bed rest and psychological supports. The first line drugs, corticosteroids in the form of 1 milligram per kg body weight. And if no response, then we should add or increase the dose of clofazimine 100 milligram TDS. And if there is further no response and if there is no contraindication, then we should start thalidomide in dose of 100 milligram TDS to QID. And important thing, you should always check with double tests for pregnancy if you are prescribing this drug thalidomide in a women of reproductive age group. Other established steroid-sparing drugs are pentoxifylines, colchicines, and chloroquines, and these give the variable results. Sometimes when there is necrotic lesions, we prefer pentoxifylines and colchicines, and if there is a arthritic ENL, then we prefer chloroquine and methotrexate. Azathioprine, there is a few studies regarding the management of ENL and type 1 reactions with azathioprine. The results are not very good. Cyclosporine is very good drug for the management of type 1 lepra reactions because it acts on the nervous system. The novel biological therapies includes the TNF-alpha blockers like the infliximab, etanercept, even the adalimumab, and some of our colleagues also used apremilast for the management of type 2 lepra reactions in a recalcitrant conditions, and we can try. And in last, we can try IVIG and plasmapheresis in case of ENL. Now, what is recalcitrant ENL? Suppose what to do when everything fails. Patient becomes steroid dependent, there is no response to thalidomide, and there is recurrent development of ENL or persistent lesions of ENL. We tried MIP vaccine in such situations, And what happens, MIP decreases the overall bacterial load, and at the same time, it also decreases the inflammatory response. We had tried in more than 12 cases of ENL, recalcitrant ENL, who didn't respond to the conventional therapy like the steroid, thalidomide, and methotrexate and apremilast. And the outcome was very good. So MIP is, indigenous developed vaccine. It activates both innate and acquired immunity, forcefully shifting the immune response from TH2 to protective TH1 and TH17 response. And there is a, different opinion. Sometimes what happens when we give MIP vaccine in a general case of leprosy who has no reactions, there is inflammatory reactions, and it may present like lepra reactions. So it is a paradigm. Sometimes it may precipitate reactions in normal case of leprosy, but it can help in recalcitrant of cases of ENL in which BI and MI is very high. Another important reactions that can occur in leprosy are like the immunological emergencies. Recalcitrant ENL with HLH, hemophagocytic lymphohistiocytic syndrome is very, very rare. But if patient develop this condition, it poses serious consequences. Neurological in the form of acute neuritis and nerve abscess or chronic sequelae. Ocular in the form of iridocyclitis, leg ophthalmos and keratitis. Visceral in the form of epidermoarthritis and secondary amyloidosis, and arthritic type of ENL, and sometimes trophic ulcers and Charcot arthropathy. HLH is very rare, but you should suspect if a case of ENL becomes severe when there is persistent fever, when there is cytopenia, and when there is very high level of ferritin and hypercholesterolemia. So if you suspect that patient is going into HLH, then you should immediately start dexamethasone, preferred, and if possible, you should give IVIG. There are other drugs like cyclosporine and etoposide, but IVIG is a very good drug to tackle HLH. Neurological complications like crying of hands and foot drop. In this case, the judicial use of systemic corticosteroids at right time is very important and crucial to prevent the crying of hand. Sometimes what happens, steroid not help, even cyclosporine not help. In such cases, we tried intraneural PRP, and intraneural PRP improve the conditions and prevent the disability and deformity. Ocular and visceral complications, we should always follow the case and take consultations with the ophthalmologist and manage with eye patches and glasses. Dapsone hypersensitivity syndrome, it is now very common, though in some of the country like in China, each and every patient of leprosy, if he is on Dapsone, initially he is screened for HLA-B1301, but not in India. But if you suspect that patient is developing Dapsone hypersensitivity reactions, like there is sudden development of rash all over the body with facial edema and eosinophilia and other deranged LFT, then you should immediately stop Dapsone and start systemic corticosteroids. Remember, this type of DHS persists for longer durations, so immunosuppressive therapy requires for a longer duration. Rare modalities, the Lucio phenomena, that is sometimes misdiagnosed as erythema necroticans. This is not very common, but frequently seen nowadays. And the most important causative agent is Mycobacterium lepromatosis. So if you diagnose that this is a case of Lucio phenomena, you should immediately start with a steroid and manage the conditions with continuation of the MDT and other antibiotics. What happens when you give corticosteroids for longer durations? Patient develop steroid dependency. So patient develop some of the steroid associated adverse effects. So you should check and prevent infections with supportive antibiotics. Check for bone health. Metabolic monitoring is very important, and also the GI system, because such type of patients on long duration of corticosteroid develop gastritis. So PPI is required in such cases. Physiotherapy and rehabilitation is also required for early recovery of the disease. So this is a flow chart that indicate when you suspect lepra reactions, and then you should start. You should continue MDT and never stop, and diagnose is that case of type 1 lepra reaction or type 2 lepra reaction. If the case is type 1 lepra reactions with neuritis, you should assess the severity and manage according with the steroid and other supportive drugs. And if the patient develop ENL, then you should again manage according to that protocol. For the type 1 lepra reactions, if that is mild, start manage with NSAIDs. If moderate to severe, start prednisolone. And if there is persistent or recurrent and not response to steroid, then you should add other therapy like cyclosporine and azathioprine or methotrexate. And if that is again failed, then you should plan for intraneural PRP or surgical decompressions. For the ENL, in mild case, NSAID and continuation of MDT. For moderate ENL, prednisolone, and severe ENL, prednisolone, clofazimine. And if no response, then thalidomide or apremilast or minocyclines. And if patient develop dependency, then we can plan for TNF blockers and MIP vaccines or plasmapheresis. So this is all about the management of recalcitrant lepra reaction. Thank you so much.
Thank you, Dr. Sunil Kumar Gupta, for an excellent and informative talk. Any questions from the audience?
In reactions involving peripheral nerves, what literature or what strength of evidence do we have for the role of perineural infiltration with steroids, triamcinolone typically?
Actually, this is a regenerative management, and we had tried as a pilot study in our centers, and that is submitted for publications. And I forget one thing, if there is recurrent ENL, we should also check for the resistance. If the BI is more than 2 or there is recurrent ENL, we should always send the specimen, either slit skin smear or skin biopsy for drug resistance. Thank you.
Sir, one question. So do you prefer intraneural steroids for like management of neuritis? Intraneural?
No.
So means you have never tried?
No.
Okay, okay.
Thank you.
Sir, for how long we will give the MTX?
Pardon?
Methotrexate, you said that we can give.
Methotrexate for the management of ENL, we generally give up to 3 to 4 months, because the effect of methotrexate is quite slow. So we should wait for at least 6 weeks to 8 weeks.
Thank you, sir.
Sir, do you prefer to taper methotrexate or you just stop it at once?
No need of tapering, you just stop.
No more questions, we will conclude.
Thank you.
Thank you, sir, for such an enlightening session. I would request our chairperson and speakers to please collect their memento. Proceeding towards the next session, I would like to invite Dr. Anu Chandra C. and Dr. Mukesh Girdhar, sir, to please chair the next session.
Good afternoon, everyone. It's my pleasant duty to invite Dr. Sitaram for his talk on some difficult clinical cases in dermatology. Dr. Sitaram, sir. Dr. Sitaram, sir, doesn't need any introduction. He's the president-elect of IADVL, a senior dermatologist qualified from AIMS Delhi. Dr. Sitaram, sir.
Thank you, Dr. Mukesh. Good afternoon. For the next 15 minutes, I will just take you through some cases. Look at this. He's a 35-year-old male having fever for 2 weeks, weight loss of 5 kg in last 1 month, anemia, diarrhea, and he was RVD positive. This was biopsied outside before coming to us, and he received ATT for 4 weeks, and there was no response. The biopsy says suggestive of tuberculosis, so it was ATT was given, and there was no response, rather it was worsened. The lesion was increasing, also developed on the other cheek, another ulcer. In addition to that, you can see here, there are umbilicated papules on the entire forehead. Systemic, nothing, generalized lymphadenopathy is there, anemia is there, moderate hepatosplenomegaly is there, lungs were normal. So we thought of tuberculosis because there are umbilicated papules on the forehead and the ulcer. So thought cryptococcosis and histoplasmosis, because these two conditions can produce umbilicated papules. Further investigation showed leukopenia, and of course CD4 was 60. Viral load 1,74,000. So because he was not responding to the ATT and he developed the umbilicated papules where we were suspecting cryptococcosis, so we did another biopsy, and that showed this multiple septate spores. So the septate spores, and then we did culture that which showed the red pigment. So the multiple septate spores, fungating ulcer, and molluscum-like papules, red pigment of the culture, all these things were suggestive of telleromycosis, which is previously called penicilliosis, which is a deep fungal infection. The molluscum-like papules we can have in 4 conditions, of course, including molluscum, the histoplasmosis, cryptococcosis, and the telleromycosis. Then how do you differentiate? The molluscum, we have seen in the morning also, the HP bodies. The histoplasmosis, it will be a pseudocapsule, spores with clear halo, whereas the cryptococcosis, we have true capsule, that is, which is stained with the red with the mucicarmine, and the telleromycosis, which have a septate spores, which you are able to see here. This is the spores with halo, this is the stained with red mucicarmine, and these are the septate spores. So this is mainly seen in the discovered in the bamboo rats and common in the northeast states, and also from Mumbai, Delhi, Chennai, and Assam. The treatment is amphotericin B, itraconazole, and fluconazole. And this patient was given injection amphotericin B along with itraconazole, of course, along with the heart. And this was the result. After giving 2 weeks of amphotericin, and this was the latest photograph, which is completely healed. Even the molluscum-like papules, you can see that entirely they disappeared. Case 2. 40-year-old male, again RVD positive, but he was not on heart. Multiple nodules on the palate on 4 weeks. There was cervical lymphadenopathy. There was no fever. The cervical lymphadenopathy huge, enlarged, and FNAC was done. And again, it was suggestive of tuberculosis. Started on ATT. There is no improvement even after 6 weeks. And we all know that ATT given for 6 to 8 weeks, if there is no response, you have to reconsider your diagnosis. That was the classical teaching since our PG days. In the meantime, the nodules also got ulcerated further in the mouth, extensive enlargement of the entire hard palate. So those were the nodules which got ulcerated. This was the biopsy. We did a re-biopsy again. That was a dense inflammatory infiltrate. And these were multiple epithelioid histiocytes. And this was the picture which had a spores with clear halo. So nodules ulcerated, spores with clear halo. I just have shown you that was the histoplasmosis. So presenting as again oral lesions, nodules, ulcers, and the lymphadenopathy. After 2 weeks of amphotericin B again, entire ulcers healed, completely healed. This gentleman is 16 years old. For 4 years he is having the ulcerated plaques linear on the left upper limb. So there was a history of preceding trauma, and not very significant treatment history. Plaques are extending onto the chest, right hand and left thigh, and you can see here almost an ulcerative growth which resembles almost a malignancy, a squamous cell carcinoma, an ulcerated nodule. So we thought of lupus vulgaris with SCC, mycosis fungoides, and the blastomycosis. Montrose was negative, chest X-ray was normal. The skin biopsy, before the skin biopsy, our resident, because he was seeing something black crusted and black spores on the plaque, he scraped it, and then we saw this on the lesion, the multiple rounded, septate, brown, colored sclerotic bodies, which are copper penny bodies. Clinically looks like lupus vulgaris. When we investigated, it found to be, where we see this is a chromomycosis. It's a lupus vulgaris like chromomycosis. So sent for culture, started on treatment without waiting for the report, and after 3 weeks of itraconazole, there was no significant change in that. But culture cause as of course pedrosi only, which causes chromomycosis. So because there was no improvement with the itraconazole, we added potassium iodide, and that was the improvement. A combination of itraconazole and potassium iodide, the entire lesion healed, including that ulcerative growth which resembled squamous cell carcinoma. The lesion on the hand also healed completely. So this was the other reports which can have been presented and published, the lupus vulgaris like chromomycosis, and which showed this type of bodies. And it can be nodular, it can be verrucous, it can be plaque, tumoral or atrophic plaques can occur. And this was the huge lesion which responded itraconazole with potassium iodide. After seeing this report only, we added the potassium iodide to that our case, and then the lesions were completely healed. These were the areas epidemiologically in our country. Look at this. So you have seen penicilliosis, you have seen histoplasmosis, and chromomycosis. Here is a 26-year-old male, ulcer below lip, started as red nodule, became ulcer, not painful, mild discharge, no comorbidities, cervical lymphadenopathy present, not painful, there is no matting, they are discrete and not tender. So he has another lesion also on the neck and on the forehead. You can appreciate one lesion here on the forehead. So investigations, viral markers are negative. The discharge which was coming from the ulcer, the smears were negative. The RT-PCR was done. There was no tuberculosis. There is no non-tuberculous mycobacterioles. They give both. Montrose was negative. So in the investigations, we did the chest X-ray and the biopsy. Chest X-ray showed this. A radiodense opacity noted involving the right, upper and middle zones, and the radiologist says probably of infective etiology. This was the histopathology. You can see here numerous giant cells in this, and here giant cells with hyphae. When we did the pass, there are beaded hyphae there, and this is, you can see the acute angle here. And a beaded hyphae with an acute angle with chest X-ray showing the opacity. Any, this thing, clue? Aspergillosis. The culture showed the Aspergillus fumigatus, and the only thing is usually they will be in the immunocompromised people. Here this gentleman was an immunocompetent, it was secondary from the lung. These are the various treatments which can be given: voriconazole, amphotericin, itraconazole, and the surgical debridement. We give voriconazole, 200 milligrams twice a day, and this has the response after the 6 weeks of treatment. Even all lesions have subsided. Even the chest X-ray, there is a lot of improvement in the X-ray lesion. So the biopsy gave us a surprise showing the aspergillus there. Then we did the culture. So you may say that why voriconazole, why can't itraconazole was given in this patient? So whenever there is systemic involvement, the lung involvement is there here, the voriconazole seems to be the drug of choice. So even though slightly it was expensive, we preferred to give that, and that gave us good response. A 50-year-old male is a farmer by occupation. The two swellings were the dorsum of the foot, cystic swellings associated with the pain, no comorbidities. Inguinal lymphadenopathy is there. You can see those cystic swelling, they are soft. Nothing much here. Chest X-ray normal, Mantos negative. Naturally, any swelling on the foot, we always try to exclude the tuberculosis. And we try to aspirate because it was cysting. There was the fluid, absolute pus was coming out of that. And that was cultured, and that showed this. The dark olive green to black colonies with black rivers. The histopathology, the PAS stain showed the septate hyphae with spores, and the lactophenol blue showed the classical Exophilia dermatitis species. Treatment given, you all know. So what is this? This is a pheohyphomycosis with all this. So then the incision and drainage was done, and then pus has come out with gush-like thing. Surgical debridement was done, and he was given itraconazole 200 grams twice a day with complete improvement. Pheohyphomycosis, of course, is a dermatitis fungi which produces the pigment in the culture, which you have seen. This is interesting. Once we see this female, 38-year-old female, severely itchy scaly erythema, progressed 1 month with episodes of tiny pustules, burning. See the back also. Thought of clinically, naturally, the pustular psoriasis because tiny pustules everywhere on the abdomen and back. Biopsy also has come with pustular psoriasis. Gave methotrexate for 3 weeks, no response. It has worsened further. Now you see the lesions. So with a very clear-cut margins, developed another lesions with the clear-cut margins. Then we did the KOH smear, and that showed the fungi. See, it's a cursory examination. Pick pustules we have shown, some did biopsy, pustular psoriasis came, so treated with methotrexate. This margin was there, even in the beginning, if you have seen the cases very thoroughly, very keenly, it was there in the first picture also. So we missed it. So this is how finally itraconazole was given, and all the lesions improved. So no to the cursory examination. I have 1.5 minutes. This case is for the opinion from you. I mean rather suggestions for the treatment. Again, it's nothing but it is a case of chromomycosis, multiple lesions, and biopsied, cultured, it was chromomycosis positive. Culture was also positive. Then we gave itraconazole and combination of terbinafine in this case. After 8 weeks, it improved. These lesions also on the leg also has improved. So most of the lesions have improved. So far, so good, fine. But after 4 months, he came like this. Progressive. Everywhere, he developed multiple lesions. Again, so the lesions were chromomycosis only. This time we gave voriconazole and terbinafine. Nothing happened. Lesions worsened further. So, deranged LFT. So we stopped the treatment for some time. Terbinafine and these things. Potassium iodide added. Nothing. No improvement. After 6 weeks of potassium iodide also. All the lesions worsening. Then we gave, because nothing was working, combinations of voriconazole, terbinafine, and this thing. We gave MIP. You may ask me why MIP here? Because it was an immunomodulatory thing we thought, because we were frustrated. We don't know what to do with this gentleman, so we just gave MIP. But nothing happened. Lesions worsened further. So initially he developed lesions in the glans penis also. So, considered iris, given him oral steroids, Imivac was stopped, voriconazole and potassium were continued. So lesions partially decreased but never responded fully. We don't know what to do. So this is the present status of this gentleman. So any suggestions from the seniors, faculty, anybody, any guidance to treat this patient? So with that, I stop. Thank you. Sir? It was done 3 times, sir. There was never a malignancy anywhere. The repeat culture also showed the same thing. Twice, I think it was cultured the same thing. So, okay, I think we will leave the stage for the others. We can discuss it later. So, thank you very much, sir.
So very interesting cases, Dr. Sitaram. Thank you so much. And this case really foxed, I think, all of us. We have no clue as to biopsies have been done repeatedly. The diagnosis is confirmed, and the patient is not responding. Anyway, we have to conclude this session. Thank you so much, sir. Thank you.
Thank you, sir. It was such a wonderful session, such a beautiful collection of cases. We all are inspired. So for the next session, moving forward for the next session, I would like to invite Dr. R.P. Gupta, sir, and Dr. V.P. Kaushik, sir, to please kindly chair the session. I would request our speaker and chairperson to please collect their memento. Dr. R.P. Gupta, sir, and Dr. V.P. Kaushik, sir, kindly grace the dais.
Good afternoon, everyone, and it's my privilege to chair this session. And the speaker is an old friend of ours, Dr. H.K. Kar, who was heading the department in RML Hospital, Delhi. He'll be speaking on case series of unusual necrotic lepra reactions. Dr. Kar, please. Dr. Kar is Emeritus Professor of Dermatology, STD at Leprosy at Kalinga Institute of Medical Sciences.
Thank you, my friend, Dr. R.P. and maybe also all my old friends from Delhi. Thank you so much for introduction. So after Dr. Sitaraman has told already 5 beautiful cases, I will speak only 2 cases of atypical presentation of leprosy. You know, the leprosy continues to surprise clinicians because of varied manifestations, protein manifestations, particularly atypical manifestations of leprosy reaction, particularly after MDT therapy in last 10 years. We are seeing so many atypical presentations, and now I just 2 cases I will encounter recently in KIMS. I'll just describe those. When leprosy ulcerates, we know the leprosy ulcerates, maybe in type 1 reaction, we call it Lazarin leprosy, main ENL necroticans, type 2 reactions, and sometimes Lucio phenomenon. Lucio phenomenon caused by Lucio leprosy caused by mycoectomy lepromatosis. It can also produce a reaction that's called Lucio phenomenon, producing a lot of ulcerations. And sometimes, very, very rarely, we find non-reactional leprosy ulcers. We have given some examples in our IL textbook on leprosy. Sometimes leprous nodules also undergo ulceration. We do not know why it happens. Dr. Dharmendra and Ramu has described the leprosy exaggeration, lepromatous exaggeration. And in addition, we have some neuropathic ulcers also. That's called trophic ulcer. That's very typical ulcers we get leprosy. This is the case I saw just 3 months back. I just wanted to show how it looks, how apparently you never thought of could be leprosy. It's a male, 46 years male, apparently all right, just 2 months back, developed low-grade fever, more in evening time associated with chills and rigor, relieved partially on taking medications. 15 days he developed ulcer. After 15 days of developing fever, sudden onset of painful solid red raised lesions, approximately coin size, both bilaterally, both arm and trunk. Subsequently developed similar lesions over the entire body, almost 20 to 30 lesions per day over the next 4 to 5 days. With acute condition, we admitted the patient in the ward. gradual lesions began to enlarge and ulcerate. There is yellowish, scanty, foul-smelling, blood-stained discharge, followed by yellowish brown, thick crusting in next to 5-7 days. Patient denied any history of photosensitivity. We thought of so many other conditions, dermatological conditions. No chronic cough, no purpura, no mucosal involvement, there is no recent sexual contacts also, no genital ulcerations, no history of joint, bone, muscle pain also, no history of intracranial infection, recurrent surgery, or significant physical emotional stress also. When you go through the past history of treatment, he told he was a case of Hansen's disease, completed 12 months therapy almost 10 years back during March 14 and 15. The patient has treated multiple Ayurvedic homeopathy medicines, all these things, and they didn't, even tofacitinib, one of our dermatologists gave tofacitinib for last 7 days, didn't respond, then finally he landed in our hospital. Physical examination shows there is temperature, there is pallor, he is very much anemic. When his systemic examination did cardiovascular, respiratory, gastro, CNS, nothing came abnormal. And you can see the lesions, cutaneous lesions, multiple, bilateral, symmetrical, innumerable plaques of various size. It may not be symmetrical. You can find all over the body, and it undergo ulcerations. And you can even the buttock area and the lower extremity, you can see huge bluster in 15 days. In 15 days fever, and next 15 days this type of ulcerations, including face also. But when you examine, when you found past history of some leprosy, we tried to examine his nerves, peripheral nerves. We found there is bilateral nerve thickening, radial cutaneous nerve thickening, lateral vertebral nerve thickening, or grade 2, grade 1, 2. But of course, there is no plowing of the fingers, so no grade 2 deformities. And there is no sensory loss. We kept the differential diagnosis, could be a Lagerine leprosy, ulcerated with type 1 reaction, it could be erythema nodosum leprosum, it could be Lucio phenomenon, or it could be cutaneous small-scale vasculitis, or any type of subacute cutaneous lupus erythematosus, or any form of neutrophilic dermatosis like gangrenosum Switch syndrome, and all kept in your mind could be secondary syphilis also. We did the investigations. Hemoglobin is 10, but there is huge total leukocyte count, almost 28,000, around 28,000. And when you do ANA profile was negative, and CRP was very high, 120, and ES was 46. Then we did the post-culture sensitivity. The staff was isolated, blood culture was negative. When you do the slit smear examination, the earlobe eyebrows are negative, but when one of the active lesion, the trunk ulcer age, we find few bacilli are present, and one of the buttock lesion also we find BI1, so total BI comes to 0.06. We did the histopath, the very classical shows the periappendigeal perivascular lymphoplasmacytic infiltrate, and good epithelial granuloma with few Langerhans cells with marked dermal edema. So finally, we give the impression of borderline leprosy. In the case of borderline leprosy, we type 1 reaction, and AFB stain we look for, you can see the left side, the AFB stain also 1 or 2 sites that is positive. So finally, we put the diagnosis of, is a case of relapsed borderline leprosy with severe ulcerative type 1 reaction, very classical we call as Lagerine leprosy, but this is not typical Lagerine leprosy. When Lagerine leprosy usually occur 1 or 2 lesions all over the body, but here we find all over the body. So this is a very atypical form of Lagerine leprosy, we give the name, and we started treating monthly pulse regimen we give that is our standard departmental research leprosy protocol we follow. 3 drugs regimen we give rifamycin, clarithromycin, minocycline monthly pulse dose. We put it in our research protocol. And for type 1 reaction, we give prednisolone 1 milligram per kg body weight. Of course, supportive wound care, we give IV antibiotic and debridement, analgesic, and nutritional optimization, all we treated. And finally, gradually, after 4 weeks, patient shows very good response with the steroid and almost recovery, lot of response of the lesions and the ulcerative lesion seals and almost development of scarring. Case number 2, next case is another case of male, 30 years, residence from Odisha. He's by occupation is a carpenter. He also developed painful red raised lesions all over the body, last 15 days only, and with intermittent fever with joint pain. Patient was apparently all right 15 days back, following which sudden onset of pea-sized painful erythematous lesions over the back, bilaterally, lower limbs. Lesions gradually progressed, involved the whole entire body within 3 to 4 days, and patient developed almost 20 lesions per day, and associated with low-grade fever, continuous in nature, with no associated chills and rigor. But also patient has bilateral ankle, knee and elbow joints associated with fever, no history of morning stiffness, few lesions over the right knee. If you look on the right knee, one of the lesions undergo a very soft, big plaque developed, a very soft plaque, and they undergo ulcerations, and there is serosanguinous discharge from the plaques also. There is scanty yellowish, non-blood tinct, non-foul smelling discharge in the next 2 weeks. Patient didn't have a history of photosensitivity or chronic cough, mucosal involvement, no history of bone muscle pain also, no history of intercalated infection, all these things are negative. But when you try to see the past history, he again a case of lepromatous type of leprosy. He completed 12 months MDT, almost 1 year back. He just within 1 year and 2 months, he developed all these type of lesions. Patient, when asked what type of any type 2 leprosy reaction, patient also had one episode of documented type 2 leprosy reaction towards the end of MDT. When he completed 12 months MDT, in last 12th month, he had reaction, type 2 reaction, and was treated with oral prednisone and is okay. Then they stopped the treatment. So here the question comes, whenever the patient is developing a reaction, type 2 reaction at the end of 12 months, as Dr. Gupta very well advised, Professor Gupta, and this is the presence of live bacilli. You should not stop MDT, as at least you should continue MDT as long as you are giving prednisone for treatment of type 2 reactions. So this case also, this is the cutaneous examination case, and he also, when you examine, you find the sensory examination is okay, but he has a bilateral outline of thickening and non-tender, no deformity. And we keep the differential diagnosis of erythema necroticans, ulcerated by type 1 reaction, could be cutaneous small vessel vasculitis and neutrophilic dermatosis. And we did the investigations, and we didn't find much. TLC count was normal, but here AN was negative, LFT, RFT was normal, everything was normal, but CRP was 120 milligram and ESR was 38 millimeter. When we did the slit smear examination, we found almost all sides, that is BI was positive, both earlobes, eyebrows, active lesion, ulceration lesion 1+, and buttock area also 2+, total BI was 2+. And when we did the histopath, we found there are seeds of foamy macrophages in the upper dermis, lower dermis also show periappendigeal and perivascular neutrophilic infiltrate, and AB stain also positive, and histopath given impression lepromatous leprosy with type 2 leprosy reaction, that is erythema and noticeable necroticans. Very classical case of foam cell, full of foam cells with AB, and with AB stain you can see the lot of bacilli almost every felt. And finally, we made the diagnosis of a post-release from treatment, just beyond RFT, case of lepromatous leprosy with severe ulcerative type 2 reactions, we call erythema noticeable leprosy. So the most important, the message we want to give here, don't stop MDT. If the patient is developing reaction, maybe type 1 reaction or type 2 reaction at the end of 12 months, please continue MDT and treat for reactions at least till the reaction is subsided. Here we give the, again we give monthly, as per our departmental research protocol, we give him RCM, pulse regimen, 3 bactericidal drugs, rifamycin, clarithromycin and minocycline as per the, and here we give, for type 2 reaction we give prednisolone 1 milligram and along with thalidomide. Earlier he was taking prednisolone and relapsed, so we could give a combination of prednisolone and thalidomide. And because it's a type 2 reaction, we give MIP vaccine, also immunotherapy, because of, as per the, again, we are doing a conduct research study, in a reaction, leprosy reactions, use of MIP vaccine, and we started the MIP vaccine also, and also supportive treatment. So gradually, after 4 weeks, patients show very good response clinically, and also you can see the big plaque, soft plaque become very confined now, and also gradual healing. So this is the difference between Lazarine leprosy and necrosis. So always confusion occurs whether it is a type 1 reaction or type 2 reaction when you will find ulcerative lesions. So you have to differentiate whether it is a ulcerative type 1 reaction or ulcerative type 2 reactions. And there are a lot of reports reported from our dermatologists from India also, how the confusion occurs for type 2 leprosy reaction as a case of Sweet syndrome, or type 1 reaction as a case of cellulitis, or so on and so on. So that's why, and also some vasculitis also. You should keep in mind vasculitis. So final, the take-home message is, atypical prevention can easily mislead the clinician, delaying the correct diagnosis, leading to dreaded complications like normal image or permanent disability. The high index suspicion is very essential. Leprosy truly remains a great clinical imitator. Therefore, whenever we encounter unusual inflammatory or necrotic dermatosis, especially in endemic region, careful history of Hansen's disease and a thorough peripheral nerve examination is essential. And finally, tests like slit smear examination is must, and also skin biopsy. This must be to exclude Hansen's disease. So thank you very much. I am very much thankful to all my postgraduate students who prepared these slides, particularly Dr. Sadhvi, and this is my hospital where I work as a emeritus professor. Thank you so much.
Thank you very much, Dr. Carr, for such an enlightening talk. So any question, please? So there are no questions. Here we conclude the session. Thank you.
You say that you are using an alternative protocol. What is the advantage of this alternative protocol over the common MDT which we have been using till date? Why should we, in fact, should we be switching to this? And if we should be switching, why should we be switching?
Yeah, that's a very good question. We are seeing many cases of reactions are developing when still viable bacilli are there, even at the end of 12 months also. And many cases, resistant bacilli, there are a lot of case reports has come up, viable bacilli and not responding to dapsone or rifamycin or immunofluoxetine also. So in that case, we have taken two projects we are carrying out to, because in the absence of, we are sending the biopsy for resistance study. At the same time, we are starting multi-drug therapy in a pulse regimen for 12 to 24 months, giving all 3 bactericidal drugs, because dapsone produces a lot of complications nowadays. Clofazimine pigmentation is not accepted by others. So we are carrying out this project. Probably our first preliminary report will come up soon in leprosy review. And that is, we should now switch over to giving multiple bactericidal, because we have now good bactericidal drugs. Instead of giving dapsone, producing a lot of dapsone sulfur reactions, clofazimine, a lot of pigmentation, many of the patients doesn't like that pigmentation. So probably let's hope we should try a multi-drug, multicentric trial, taking a huge number of patients to see the efficacy of 3 bactericidal drugs pulse therapy, because Rome regimen is very popular. Rome regimen also has been given good result. If you give 24 months Rome regimen, and Rome, it will be RMM regimen is much better than Rome regimen, so also RCM regimen. So we are trying that. Let's see, maybe next 2 years we'll get the finding whether it is almost equal to the normal immunity or it can be better than that. Better than that. I hope it should be better than that.
Monthly once, sir? Monthly once?
Monthly once, yeah. All supervised. All 3 drugs, patient will come and take all the drugs, and it's free completely. Yeah. And doesn't have any dapsone problem, will not be there. Pigmentation will not be there, because of clofazimine produces a lot of pigmentation.
Thank you very much.
Thank you so much, sir, for such an enlightening session on leprosy, such a common disease seen in our part of the world. I request our chairpersons and speaker to kindly collect their memento. Without further ado, moving forward, for the next session, I would like to invite Dr. Hariram Kumar sir, Dr. Rajendra Mehta sir, and Dr. Surendra Kumar sir to kindly chair the next session.
Next speaker is Dr. Rajneesh Kumar. He is Senior Dermatologist, SMO under Bihar Health Services, Government of Bihar, ex-senior resident, at present practicing at Darbhanga. Please, Dr. Rajneesh. His subject is approach to genital ulcer disease due to STI.
Thank you, sir, for the kind words. Good evening to all of you. Myself, Dr. Rajneesh Kumar, and moving to the next segment of this conference, that is venereology revisited. Starting with the introduction of genital ulcer, my topic is approach to genital ulcer secondary to sexually transmitted infections. Coming to the introduction, as we all know that genital ulcers are defined as the breach in the continuity of genital mucosa and or skin. The genital ulcer disease may occur due to sexually transmitted infections or due to non-STDs like trauma, FD, etc. The clinical diagnosis these days may be misleading because of increasing HIV co-infection. Mixed infection often alters the morphology of ulcer. Ulcers do not remain confined to the genitalia but can also seen in extragenital sites due to the changing sexual behavior patterns. As I mentioned in the previous slide, etiology of the ulcers, it can be due to the venereal causes or due to the non-venereal causes. Among the venereal causes, the common etiology include herpes simplex, syphilis, chancroid, LGV, and granuloma inguinale. And among the non-venereal causes, the causes include trauma, non-STI infections, some adverse drug reactions like Stevens-Johnson syndrome, FT, vesico-bullous diseases, non-bullous disease like Behçet syndrome, Rhesus disease, Crohn's disease, and malignancy like basal cell carcinoma, squamous cell carcinoma, some pre-malignant conditions like Paget's disease, and erythroplasia of Querette. In this presentation, I will be discussing only regarding STD due to the genital ulcers due to STI. Now coming to the management of genital ulcer steps, first of all, history taking is an important point in the managing genital ulcer. After history taking, proper physical examination, some bedside tests, lab investigations, diagnosis, management, counseling, and follow-up. These are the protocol while managing a case of genital ulcer. We will see in the individual points in the subsequent slides. Coming to the history taking is very important as it points to the diagnosis. First of all, the general details of the patient should be taken like age, sex, occupation, and address of the patient for follow-up after treatment. In the lesion history, any associated prodromal symptoms, initial presentation, duration of lesion, local and systemic symptoms, any history of topical or systemic remedies, any history of similar symptoms in the past should be inquired, and history regarding the partners with similar symptoms should be taken. History of abortion or stillbirth in case of female patients, history suggestive of sexual abuse in cases of child, duration of ulcer and if healed, the duration of healing, sexual history, the nature, the gender of the partners, the number of partners, the nature of intercourse, was it vaginal, anal or oral intercourse, exposure with commercial sex workers, and sexual contact, was it single or multiple, with exact dates to approximate the incubation period. Medical history should be taken like HIV status, drug allergies, and medication. Travel history, that is the geographical areas where the sexual intercourse has taken, and history of associated STD needs to be inquired. After taking a proper history, proceeding to the clinical and physical examination. In this, the inspection and palpation of lesion, the genital and perianal area examination, lymph node examination. In the lymph node examination, the groups involved, tenderness, consistency, overlying skin, and attachment to the surrounding structure should be taken. And general examination include this examination of skin, oral cavities, skin of palms and soles, liver, spleen, chest, CVS, and neurological examination are important in case of neurosyphilis. Coming to the inspection, we should examine the number, site, size, depth, presence of necrotic and slough tissue on the floor of ulcer, erythema surrounding the ulcer. In the palpation, the tenderness, induration, bleeding on manipulation, attachment to the surrounding structure, per rectal examination and palpation of inguinal node may also aid in the diagnosis of ulcer. Laboratory test, microscopy, that is dark ground illumination, zinc smear, gram staining, serology, molecular techniques like PCR, histopathology, and viral markers should be done. Serological test like the various serological tests performed with the patient's blood serum include VDRL tests, TPHA to confirm VDRL reactive samples, FTAPs to confirm VDRL reactive samples, and ELISA for IgG and IgM antibody detection against HSV. Now coming to the incubation period and healing time in case of genital ulcer disease, I'll be discussing the important causes of genital ulcer, their incubation period and the healing time. First, the primary chancre incubation period ranges from 9 to 90 days. Spontaneous healing time is 3 to 8 weeks, and on treatment the healing time is 1 to 2 weeks. For genital herpes, the incubation period is 5 to 7 days. Spontaneous healing time is 14 to 21 days, and on treatment the time is 6 to 12 days. Chancroid, the incubation period is 5 to 8 days. It is self-limiting but may persist for years, and on treatment the healing time is around 1 to 2 weeks. For LGV, the incubation period is around 10 days. The range is 5 to 30 days. The spontaneous time is 2 to 5 days. For donovenosis, the incubation period ranges from 9 to 50 days. It has no tendency for healing, and on treatment it takes 3 to 4 weeks. This is a chart showing a comparative study of the ulcers caused by common etiology. We will be discussing regarding each. Like in case of syphilis, the primary lesion is a papular lesion. The number of lesion is usually 1, and diameter is around 5 to 15 mm. Edges are sharply demarcated, elevated. It may be round or oval. It may be superficial or deep ulcer. Base is smooth, non-purulent, covered with serous exudate. It has a button-like induration. It's painless ulcer. Lymphadenopathy is firm, non-tender, and recurrences are uncommon. In case of genital ulcer due to herpetic causes, the primary lesion is vesical. The number of lesions may be multiple, and it may coalesce. The diameter ranges from 1 to 2 mm. Edges are like erythematous polycyclic. These are superficial ulcers. The base is erythematous. In duration, there is none. It is a painful ulcer. Lymphadenopathy is firm, tender, often bilateral, and recurrences are common, yes, in around 80% of the cases. For chancroid, the primary lesion is pustule. It is usually multiple and may coalesce. The diameter may vary. Edges are undermined, ragged, irregular. Depth is excavated. Base is purulent and it bleeds easily. It's a soft chancre, so induration is soft. It's painful. And lymphadenopathy, it is tender, may suppurate or loculated. Recurrences are uncommon. For LGV, the primary lesion is papule, pustule or vesicle. Number of lesions is usually 1. Diameter ranges from 2 to 10 mm. Edges are elevated. It may be round or oval. Depth may be superficial or deep. Base is variable. Induration is occasionally firm. Pain is variable. Lymphadenopathy, it is tender, may suppurate. Recurrences is uncommon. For donovenosis, the primary lesion is papule. Number of lesions may vary. Diameter may vary. Edges are elevated, irregular. Depth is elevated. Base is red, velvety, and it bleeds easily on touch. In duration, it's firm. Pain is uncommon. Lymphadenopathy, the pseudobubos are seen, and recurrences are uncommon. Now coming to the causes of ulcer individually. Coming to the primary chancre, as we all know, the primary chancre is caused by Treponema pallidum, a motile bacterium having regular tight spirals with rotatory flexion to and fro movements. After a highly variable incubation period, that is 9 to 90 days, average 2 to 3 weeks, chancre appears at the site of inoculation. Starting as papule, the chancre ulcerates to form a single painless button-like indurated round to oval clearly defined ulcer. The common sites of predilections include prepuce, coronary sulcus, frenulum, glans. Coming to the lab diagnosis, direct microscopy, that is dark field illumination. The fresh exudate from the primary chancre should be examined under dark field microscopy immediately after collection. Look for the treponema morphology and motility, that is thin, delicate, helically coiled corkscrew-shaped organism. The rapid rotation along its long axis and slow backward and forward movement, that is the characteristic. Coming to the serological tests, that is non-specific antibodies like VDRL and RPR, these are non-specific, while some specific tests like FTAPs and Treponema pallidum hemagglutination assay. Coming to the treatment portion, to cover syphilis, injection benzathine penicillin 2.4 million international unit IM after test dose in 2 divided dose with emergency tray ready. In patient who are allergic or intolerant to penicillin, doxycycline 100 mg orally twice for 14 days plus azithromycin 1 gram orally single dose, or ciprofloxacin 500 mg orally twice a day for 3 days to cover sanchroid. Coming to the second cause of genital herpes ulcer, that is due to secondary to genital herpes. Genital herpes is caused by a DNA virus, that is herpes virus hominis. There are of two types, that is type 1, type 2. The predominant type isolated from genital area is type 2. However, type 1 may also be isolated in 1/3 of the cases. The lesions start as a vesicular eruption but rapidly become pustular and ulcerate. During presentation, the large coalescent areas of ulceration, often with polycyclic margins, are usually present. New lesions continue to form in the first 8 to 10 days, and reepithelialization may take up to 3 weeks. Systemic symptoms like fever, headache, myalgia, and malaise may be present. Diagnosis: direct smear for giant cells. Zank smear is done. In this Zank cells, that is multinucleated cells, can be seen. Specimen swab may be taken from the base of ulcer or vesicular fluid. Viral isolation can be done in viral culture. Genomic detection like HSV, DNA detection using PCR, and serologic tests like ELISA, HSV, specific IgG. However, these are non-diagnostic. Treatment of genital ulcer due to herpetic cause, the KIT 5, that is from the syndromic management we know. Acyclovir is given 400 TDS for a week for the management of genital ulcer due to herpetic causes. Coming to the sanchroid. Sanchroid is an acute autoinnocable genital ulcer disease caused by the bacterium Haemophilus ducrei. After an incubation period varying from 1 to 10 days, a small edematous papule appears which progresses to form pustule and ulcerates. Subsequently, multiple painful non-indurated ulcers of sizes varying from 3 mm to 2 cm with ragged undermined edge may appear. Floor is covered with yellow necrotic exudates and vascular granulation tissue that bleeds on gentle manipulation. This is the characteristic. You can see in the chart, in the diagram, the tender unilateral inguinal lymphadenitis may be seen. Suppuration may occur with formation of unilocular abscess. Coming to the diagnosis, microscopy, that is gram staining. Gram-negative coccobacilli resembling the red rod or the school office appearance are characteristic. Culture, the organism culture on specific media with X factor can be done, and the fluorescent labeled monoclonal antibody for H. ducrei can also be done. Treatment to cover sanchroid: azithromycin 1 gram orally in single dose, or ceftriaxone 250 mg IM in a single dose, or ciprofloxacin 500 mg orally twice a week for 3 weeks, or erythromycin 500 mg QID for a week can be given. For dunovenosis, dunovenosis is a genital ulcer disease caused by intracellular gram-negative bacterium, that is Klebsiella granulomatosis. Incubation period is around 3 days to 3 months, average around 40 to 50 days. The initial lesions are painless, slowly progressive papules or nodule that may ulcerate. The lesions are highly vascular with a beefy red appearance, bleeding easily on contact. The ulcer when formed are clean based with an irregular border without any associated regional lymphadenopathy. Coming to the diagnosis, Giemsa stain, tissue smear or sections are done. That is visualization of dark staining Donovan bodies, like that is numerous bacilli in the cytoplasm of macrophages demonstrated in the Giemsa stain, that is cftip in appearance. The organism is difficult to culture. PCR can be done. Coming to the treatment, as per CDC 2010 guidelines, doxycycline 100 mg BD for at least 3 weeks and until all the lesions have subsided completely, healed completely, or azithromycin 1 gram once per week for at least 3 weeks, or ceftriaxone 750 mg BD for at least 3 weeks, or erythromycin based 500 mg QID orally for at least 3 weeks. Or you can give trimethoprim sulmethoxazone 160 mg 80 mg combination, 1 tablet twice daily for at least 3 weeks. In case for LGV, LGV is a chronic systemic STI primarily affecting the lymphatics, and it is caused by L1, L2, L3 serovar of gram-negative obligate intracellular bacteria, that is Chlamydia trachomatis. Incubation period ranges from 3 to 30 days. The disease manifests clinically in 3 stages. The first stage is a transient painless papule showing the sallow ulcer. Second stage is with buboes, and the third stage is a genito-anorectal syndrome leading to the destruction of these areas. Coming to the diagnosis, the nucleic acid amplification test for LGV serovars, serological test, that is complement fixation test and immunofluorescent antibody test, and cytology, the swabs from the genital area or from the lymph node aspirate for the presence of cells with inclusion bodies. This can be done. Coming to the treatment, doxycycline 100 mg orally twice daily for 21 days to cover LGV, plus azithromycin 1 gram orally, single dose, or ciprofloxacin 500 milligram orally twice a day for 3 days to cover sanchroid. Now, important considerations regarding the management of all clients of RTI STI. Educate and counsel the clients and sexual partners regarding RTI STI, genital ulcers, safe sexual practices, and importance of taking complete treatment. Treat partners wherever indicated. Advise sexual abstinence during the course of treatment. Provide condoms. Educate the correct and consistent use. Refer to the voluntary counseling and testing center for HIV, syphilis, and hepatitis B. Consider immunization against hepatitis B. Schedule a return visit after 7 days to ensure treatment compliance as well as to see reports for tests done. And if symptom persists, assess whether it is due to the treatment failure or reinfection and advise prompt referral. Thank you.
Thank you, Dr. Rajneesh Kumar.
Thank you, sir.
Excellent presentation. Any questions from the audience? Thank you.
Thank you, sir.
Thank you so much, sir, for the wonderful presentation. For the next session, I would like to call upon the stage Dr. Mukesh Raj and Dr. Pankaj Kumar Agarwal, sir, to kindly chair the session and call upon our next speaker.
Hello everyone, I am Dr. Mukesh Raj from Hyderabad. Sorry extremely for the delay. I got delayed in the flight. I'd rather call Dr. Manoharan for a presentation.
I would like to introduce Dr. Manoharan K. His qualification is MD DNB postdoctoral fellow in pediatric dermatology and is an associate professor, Sir Venkateswara Medical College Hospital and Research Center, Arur, Puducherry. He is a winner of PG Quiz Clinicon 2016 and was awarded with MRC second certification in 2018. Treasurer IDVL Puducherry, content editor IGDVL. Now you can proceed, Dr. Bala.
Thank you for the warm introduction, sir. Very good evening to one and all. At the outset, I thank the organizing team for giving me this opportunity. Today, I'll be talking on is syndromic approach of STI practical routine day-to-day practice. So we all know sexually transmitted infection continue to be a major public health problem, especially in the post-HIV era. About 357 million new cases of curable STIs occur in adults every year. That comprises almost 6% of adults affected annually. Several STIs increase the risk of transmission of HIV, and control of these STIs will prevent HIV transmission in the community. To achieve that, prompt diagnosis and treatment is essential for control and prevention of STIs. And currently, the conventional approaches of STDs are either we have etiological approach or the clinical approach, which means etiological approach, it identifies the specific causative organism of the STI, and it is the most accurate diagnostic method to arrive at the diagnosis. However, it has some limitations. It requires a laboratory infrastructure and trained personnel to achieve the diagnosis. Also, it involves equipment storage facility and transport facilities of the specimen, and it results in delay of diagnosis and initiation of treatment because of laborious activity. Limited availability in a resource-poor setting is also one of the greatest limitations of performing an etiological approach in all STI cases that we encounter. And the other conventional approach is the clinical approach, wherein the diagnosis of an STI is based solely on the clinical presentation. We know there are close clinical mimics which pose a challenge to make a clinical diagnosis confidently in pertaining to STIs. So, to bridge the gap between early diagnosis and the non-availability of infrastructure, syndromic approach has been advocated. And what is syndromic approach? The syndromic approach, we know STIs are caused by diverse microorganisms, but the clinical features can be clubbed together into a limited number of recognizable signs and symptoms called as syndromes. This syndromic diagnosis, which means identification of consistent group of symptoms and easily recognized signs, followed by syndromic treatment, which means treating common pathogen for a particular syndrome, is based on clinical presentation and standardized flowcharts for management. These flowcharts are very simple, practical and easy to use. They can be effectively used by even trained non-specialists at primary health centers, healthcare settings. So this makes the approach to STIs into three-pronged approach. Like etiological approach, we have a syndromic approach and the clinical approach. So how this syndromic approach works? As I mentioned earlier, syndromic approach divides STIs into various syndromes based on the constellation of specific signs and symptoms. We have genital ulcer syndrome, urethral discharge syndrome, vaginal discharge syndrome, inguinal bubo syndrome, lower abdominal pain syndrome, acute scrotal swelling, and recently added one, anorectal discharge syndromes. So etiological agents, they are listed on the table on the right side of the table. I am not going into detail of it. And I will just take you how syndromic approach works. I will limit my example to only to discharge syndromes, as previous speaker spoke on genital ulcer disease approach extensively. I am not covering it. So we have a male who presents with burning micturition associated with the purulent discharge, and this person gives history of unprotected sexual intercourse 5 days back before he started the symptoms. So we know when a patient presents with burning micturition and urethral discharge, the etiological agents could be either Neisseria gonorrhoeae causing gonococcal urethritis, or it could be Chlamydia trachomatis causing non-gonococcal urethritis, sometimes with MSM habit, or if a female partner has a trichomonal vaginalis, even a trichomonas vaginal infection can cause urethritis in males. So we have to probe some history regarding urethral discharge type and associated symptoms like pain or burning micturition and increased frequency of urination. And also it can be, patient will be subjected for examination to look for urethral meatus erythema and edema, and the nature of urethral discharge can also be studied. If there is a facility for doing microscopic examination, the gram stain from the urethral discharge can be done, and suppose if it is gonococcal infection, we might see gram-negative cocobacilli admixed with polymorphonuclear cells. And then with this background, we know that the patient is having urethral discharge syndrome. As per the NACO guidelines, we follow kit-based approach. We use the grey color kit 1, which consists of azithromycin 1 gram single dose and cefixime 800 milligram single dose, which has been recently modified. And this is the treatment that it needs to be given for patient with urethral discharge. And suppose if we encounter a patient with vaginal discharge, it could be either due to pure vaginitis or discharge could be due to cervicitis. And the causative organisms differ for both vaginitis and cervicitis. So we need to have some checklist to derive at the etiological agent based on interaction. So menstrual history, nature of discharge, and burning micturition, genital discharge, they will give some clues to what vaginal discharge we are dealing with, the etiological agent. Suppose if it is vaginitis, examination findings will give a clue. So trichomoniasis, there will be green frothy discharge, and even speculum examination will show some reddish spots on the cervix, which is the strawberry cervix. Candidiasis, we can see adherent curdy white discharge with some fissures, and bacterial vaginosis discharge, foul smelling discharge will be there. Whereas if it is cervicitis, there can be cervical erosion or cervical ulcers associated with mucopurulent discharge. And when lab facilities are there to identify the etiological agent, we can have potassium hydroxide mount, or we can have a wet mount to look for clue cells in bacterial vaginosis or trichomonias vaginalis. And gram stain will also give some clue. So how to treat them? So if it is treatment for if it is vaginal discharge alone, the treatment should target trichomonal infection, bacterial vaginosis, and candida. So we give secnidazole 2 gram single dose along with fluconazole 150 milligram, which is green color kit 2. Suppose if it is cervicitis, we have to follow Kit 1, grey color kit, as I mentioned earlier, cefixime 800 milligram single dose per oral and azithromycin 1 gram will be given. And syndromic management not only addresses the management of the index case, but also it targets approach of managing partner management, not only partner management, even if the partner is a pregnant female, so what management should be done, that guideline is also given. And to make a note, like cephalosporin to cover gonococcal infection and macrolides are safe in pregnancy, and quinolones like ciprofloxacin and tetracycline group doxycycline are contraindicated in pregnancy. Otherwise, treatment is similar to that of index case. And apart from urethral discharge, as I mentioned earlier, we have genital ulcer syndromes, lower abdominal pain syndrome, inguinal bubo, and anorectal syndrome. So the various color-coded kits are there. So white for genital ulcer, which is non-herpetic, mainly for syphilis, and patient who are not allergic to penicillin. Blue color code addresses non-herpetic ulcer and even syphilis patients who need treatment and they are allergic to penicillin. Kit 5 is red color, it addresses herpetic genital ulcer disease, and yellow color it's for lower abdominal pain, and black color for inguinal bubo, and the recently added one, 8th kit brown in color, it is for anorectal discharge which has cefixime 800 milligram and doxycycline 100 milligram twice daily for 7 days. And what are the components of syndromic management that makes it so feasible? So 7 C's are the main components of syndromic management. One is the client selection. We know we select the candidates based on the symptoms. We address them, we treat them with some medication. So chemical treatment is done, and it also addresses counseling and education of patients and safe sexual practices. Compliance with treatment is also checked because it is a single dose and it can be given right in your clinics. And contact tracing it addresses, and partner management also it advocates. And it recommends for comeback for follow-up, but it is not mandatory. And how does syndromic management is different from that of the conventional etiological approach? So etiological approach, as I mentioned, it is possible to get the exact diagnosis, but it avoids over treatment. Frequency of visits before treatment will be more in etiological approach, whereas the syndromic approach, it is a single visit, and the single visit itself patient will get treated. And more chances of loss to follow-up can be expected in etiological approach, whereas loss to follow-up is very minimal as the patient is getting treated in the single visit itself. And practical purposes, it is very expensive as trained laboratory technicians as well as infrastructure is required for etiological approach, whereas relatively inexpensive approach is syndromic approach. What are the advantages and disadvantages? So advantages are the treatment at first visit, as I mentioned earlier. It reduces the risk of complications. The follow-up is not compulsory, and no lab or trained personnel is required. Can be used at all levels of healthcare, and even at a very minimal resource per setting, and it is very, very cost effective. The disadvantages, not every every program is advantages oriented. It has some limitations. So disadvantages of practicing syndromic approach is that over treatment can be there, and drug resistance in the long term can be expected when patients are over treated. Another important thing is syndromic approach does not address patients without symptoms. So asymptomatic individuals are not addressed in syndromic approach. Suggestions to improve these limitations of syndromic management: periodic review of performance of syndromic management to understand the epidemiological profile and drug resistant pattern in the community. Supplement syndromic management with basic laboratory support to identify asymptomatic infections. And the genital herpes should be included in all cases of genital ulcer disease, even in vaginal discharge syndrome. When I mentioned the syndromic approach to cervicitis, etiological agents herpes simplex was mentioned, but we are giving only kit 2 to those patients and kit 1 for cervicitis, whereas acyclovir is not being advocated. So we have to include treatment for cervicitis patients with vaginal discharge syndrome also, only if the patient is at higher risk. And training of health service providers should be done periodically, and feedback should be taken from them on all practical purposes. So to conclude, syndromic management remains the backbone of STI care in resource-limited settings. It provides immediate, accessible and practical treatment, especially in developing countries. However, it shows limited accuracy compared to etiological diagnosis, ineffective for asymptomatic infections, especially in women, and performance is suboptimal in high HIV burden settings where the precision is crucial.
and risk of overtreatment and antimicrobial resistance persists. Despite these limitations, the syndromic approach remains the most feasible method of STI management in low-income countries. These are my references, and thank you for your patient listening. And I would like to make use of this opportunity to welcome you all to Pondicherry, as we are hosting P-Dermocon at Puducherry from July 24 to 26. Thank you.
Thank you, Dr. Manovan.
Thank you.
It was a very lucid lecture, but every treatment has got disadvantages, as you told. Being specialists, we are not supposed to do syndromic approach for all the patients.
True,
As
sir.
a venereologist, I am telling, because it looks very bad on our part to
True,
give a
sir.
systemic approach without symptomatic approach,
pra-
without
the-
going to the exact etiology and going
True,
to
sir.
that.
From practical point of view, it
I
looks
know,
so
it's
helpful,
very
but
deep. But I mean, treating this in a setup of private practitioners who are not trained dermatologists or they are not qualified dermatologists, it's good. But if you can tell this to the MBBS people, but for us, it looks very bad to write. And what sort of cumulative things?
True.
One total, one together.
Thank you, Dr.
so much.
Manobalan
Thank you.
K. The session ends actually in the next session. There's an elaboration on STI itself.
Okay.
So I end the session. Thank you. Thank you, Manobalan.
Thank you so much, sir, for this wonderful session. Continuing on to the journey of venerology, we have the next case-based discussion on STI, and the moderator of the session is Dr. Vivasat Bakaya. I would like to request him to kindly address the session and call upon his panelists so that we can have a wonderful discussion on STI and the case-based.
Thank you so much, Dr. Sriparna. At the outset, I'd like to thank Team Clinicon for giving me an opportunity to be here in this wonderful city. Without wasting further time, I would like to call upon my esteemed panelists on the stage. Dr. Manobalan, if you would be please kind enough to join us back on the stage. Dr. Chirag Saini, Dr. Bhaskar Datta, Dr. Asif Ahmed, I believe he's not here yet, and Dr. Nazish Nair. So we are going to have a panel discussion on STI. It is going to be a case-based discussion. I hope to grill the panelists and bring out as much information as I can from them. Dr. Nazish, okay, I don't think she's there. So, okay, so we'll begin with the first case. 29-year-old man, the clinical picture is on in front of all of you. 29-year-old man complained of these painless lesions over the scrotum since the past 3 months. On examination, multiple round to oval shaped erythematous to violaceous annular nodular lesions over the scrotum and the shaft of the penis were seen. The patient worked in the Merchant Navy. In the past history, when elicited, the patient gave no history of any lesion on the penis in the past 1 to 2 years. In the sexual history, the patient gives history of an unprotected sexual contact roughly a year ago at a port where his ship was anchored. These investigations were done, VDRL dilutions, we can see it was a high titer, 1:256. ELISA, HIV, HI2 were negative. I think this basically clinches the diagnosis. So coming on to the discussion part, the first question for my panelists is, like, based on the morphology and the distribution of the lesions, what would be your top differential diagnosis? Anybody from the panel can please take it up.
So based on the clinical picture and the history given by you, so the differential diagnosis include mainly secondary syphilis, which is annular or nodular variety. Then my other differential diagnoses are the annular lichen planus and genital psoriasis also. But other than that, the lesions are annular in, we can consider granuloma annulare, but genital granuloma annulare is less common. So my top differential diagnosis are this.
Any other differentials from any other of the panelists? Dr. Chirag, Dr. Bhaskar, Dr. Manobalan?
More or less the differential, I agree with Dr. Najish, but
Other than that, you can also stage the diagnosis with differential up to genital sarcoidosis. Moreover, however, it is very much uncommon, but genital sarcoid can also present like that.
Okay, perfect. So does the absence, because the patient denied the history that there was no lesion in the past 1 to 2 years, so does the absence of prior genital ulcer, does it have any influence or does it change your suspicion of syphilis in this patient?
No, sir. Not necessarily all patients will remember that they had a primary chancre because it is painless. It goes unnoticed most of the times. Sometimes it might be in the hidden areas too. So.
And also we know that over-the-counter prescription of medications is very common in our part. So might be he must have taken some sort of antibiotics and the lesion might have gone. So
also in this setting, you also have to keep in mind the syphilis DML because it can be without any sexual exposure where you may not get the primary chancre lesions.
Right, that's quite valid points, especially in a country where over-the-counter, as Dr. Chirag said, as over-the-counter antibiotics are quite prominently given. So they definitely help mask the initial primary chancre. So coming on to the next question, that what features in this case would point towards secondary syphilis rather than primary or the tertiary syphilis?
I think secondary syphilis has multiple lesions as we saw in this case, and primary chancre would be usually a single lesion. And the symmetry, I mean, the lesions were on both the sides. And with tertiary syphilis, there is more systemic symptoms that we see. So this goes in favor of secondary syphilis mainly.
Dr. Bhaskar?
Also from the history, you can see that the unprotected sexual intercourse was 1 year back. So it also matches with the incubation period of secondary syphilis. Also the lesions are to some extent moist and they have a violaceous tinge, which may be due to the underlying venous engorgement or the endarteries that we get in the histopathological images in secondary syphilis also.
And the report, the VDRL with titer is very high. That also leads to the diagnosis to the secondary syphilis.
Along with the chronicity of the lesions, because the lesions have been present for quite a long time. So that also gives a direction towards secondary syphilis. So do these annular or nodular lesions, do they fit in the spectrum of secondary syphilis? Like, would you consider it to be a typical or an atypical presentation?
Annular lesions, they are syphilids actually. Like another annular lesion, they do present. I would consider it as atypical presentation of syphilis. Nodular, when it is in Louis maligna, they can present with abrupt onset of painful nodular lesions in secondary syphilis, especially in immunocompromised individuals.
Yeah, but since this patient he had from a long time, there was no abrupt onset. So, yeah. Anybody else would like to take on this?
If you see the genital ulcer in case or the lesion in case of penile area, in case of secondary syphilis, the most common is serpiginous or snail track-like ulcer, which is not there. So we have to consider it as an atypical lesion, but index of high index of suspicion should be there in any case of annular lesion present over the genital area, and we should screen for syphilis. In this case.
Right. Okay. So nodular lesions are usually in syphilis, they are uncommon, but they are quite well described and we do see such type of lesions. Any other signs of the body areas in this patient you would like to examine?
Like oral mucosa for snail tack ulcers, and scalp for patchy alopecia patch, and palms and soles in this biot colorat, hyperpigmented lesions with peripheral scaling can be.
Any other area?
Also, we should examine the other genital region like perineal region and perianal region to look for other ulcer present.
Look for condylomelata, yeah.
Also, it is prudent to check for the lymphadenopathy also, which is also quite common in secondary syphilis.
Yeah, Dr. Chirag, any addition to this?
Mainly epitrochlear lymphadenopathy present in the secondary syphilis.
Perfect. So the closest mimickers of this presentation, I think we've discussed this in the differential diagnosis, so we will skip past it. So the patient denies, as mentioned earlier, he denies any prior genital lesion. So how common is missed primary syphilis in practice? Because I think all of us would agree syphilis is on the research. We are seeing a lot of quite few cases of secondary syphilis, at least in our OPDs. So how common is this missed primary syphilis in practice, and how much can we rely on the patient's history when it comes to these type of STI cases?
Most of the times, this recall bias will always be there, especially if it is an ulcer disease, like chronic ulcer diseases. And thing is, sometimes they even hide considering their promiscuous behavior also. That might also help us to rethink of condition without the idea of incubation period.
Also, most of the times this is something that we get retrospectively after we see the results. Then we poke to the patient that please tell us about the history. Then they would open up. So that is also always there with STIs.
Statistics says it's more like 30 to 40%. But what I see in my clinical practice, this is only the tip of iceberg. The cases are more. Usually more patients come without the history of primary chancre, because as we have already discussed, because they are inconspicuous, not noticeable. So mostly they usually come more commonly with secondary syphilis lesions.
Also regarding the patient's history, many times, with STIs, there is still a bit of a stigma or a taboo. So they are not really comfortable coming up with a history, because many a times they come with their attendants, with the wife or the parents, so they are really not comfortable. So it is quite important to take a history without any attendant present there, so that we can take the patient to conference and can elicit the history to the best of our abilities. Again, I think his occupation, obviously, does it influence your suspicion, or has it any effect on the screening approach, basically, how you would screen this patient, his occupation? Like, how important is the occupational history, but that's what I mean to ask, when we are tackling or screening these type of cases.
So that's what, like, if they try to hide, if the history doesn't correlate with the clinical manifestation, then occupational history will give us some clue whether they have this promiscuous behavior or not.
Exactly. So occupational history in these type of patients is very important, especially in patients who are basically outstationed, who are not at home much, who are frequent travelers because of their job profile. So in them, occupational history, sometimes it does give us a clue. So how will you interpret the high VDRL titer in this patient? The titer of 1:256. How would you interpret it? What does it suggest?
The VDRL titer is 1:256. That means there is an active infection present in the patient, and this much of high titer does not denotes the false positivity. So we should treat the patient accordingly.
Will it be useful in further as well, the baseline that we have taken, the baseline test that we have done, will it be useful to us further in the management as well?
Yeah, definitely. As it is a quantitative test, so it is very much important for the follow-up. Moreover, I also want to add that so much high titer is almost not a false positive. Usually more than 1:8, you have to think it is a true positive test. And also another thing is that the lab that has done is very good, because sometimes what they do, they don't do the serial dilution so much. So it will sometimes show the prozone phenomenon, which is quite common in secondary syphilis. Like if you do the dilution up to 1:128, it will show it is negative.
Yeah.
So this is also important in this context actually.
Yeah.
For the treatment part also, we have to look at the VDRL titer subsequently. So this would help.
Yeah. So in this case, like it's quite I would say fortunate that if you have a pathologist friend with you, so you can ask him how to do the proper titer, or how to do the proper dilution, as Dr. Bhaskar said. I was lucky that the pathologist with whom I interact, he's a friend of mine, so I was able to ask him to do it properly. So would you perform any confirmatory treponemal test here in this patient? Would you want to perform, basically?
Yes, I would go for this TPHA, since this is a screening test, and this treponemal test that we need to do, a TPHA test would further confirm the diagnosis.
As per the reverse algorithm method, like TPHA, recommendations are to do TPHA first, then go for VDRL. However, VDRL is positive, I would always do a confirmatory test.
Okay. Even with these high titers, you would want to go for a confirmatory test with TPHA. Okay. Anybody else has?
Actually, it depends the setup actually. If you are in a government setup, you have 1:2:6 dilution, you cannot do TPHA because it is actually almost pathognomic that it is secondary syphilis or syphilis anyway. So, but if it is you are in private practice, you need some medical support or all, or for documentation you can do TPHA. That's fine, but otherwise it's fine.
Doctor, you want to know? Okay, perfect, right. So coming on to the treatment, what will be your treatment of choice in this patient?
Benzathine penicillin after test dose.
Yeah, Dr. Man.
So since titers high, more patient has a risk of developing JH reaction too. So I would like to admit the patient and then administer benzathine penicillin after test dose. If he has a history of prior penicillin allergy or sulfa allergy, then I would go for doxycycline, 100 milligram twice daily for 14 days.
I think the treatment is more or less going to the same. Dr. Manopalan had answered my next question that if he's allergic to penicillin, what are the other treatment options that can be offered? So how do you counsel the patient? Because in this patient, in these type of patients, counseling is quite important. So how would you counsel him regarding the infectivity part of the disease?
So regarding the infectivity, secondary syphilis is the most infectious stage. So patient should be highly counseled about the safe sexual practice and consistent and correct condom use. And also regarding the infectivity post-treatment, usually the lesions, patient become non-infectious within 72 hours.
Yeah.
However, it is prudent to advise to maintain sexual abstinence up to 7 days. And also it is very much important to contact the partners and check for the infection.
Yeah, we'll come on to that. Partner notification. Now we come on to the partner notification. Anybody else would like to take it up?
All partners for last 1 year should be screened and treat accordingly if there is positive screening test.
Perfect. Regarding the follow-up, what are the things that we should be doing in the follow-up? I think I'll commit to the next question only. This will be the part of the follow-up. That what decline in the VDRL titer would you expect after the treatment, and in what time frame would you expect it?
So from post-treatment, like after 3 to 6 months, there should be fall in titer. Like if there is no any fourfold reduction in titers, then we will call it as improperly treated, or now there is a zero-resistant individuals who are on the rise. Even if you administer treatment effectively, even the clinical symptoms vanish, their zero fastness still poses a great challenge to us. So in those individuals, we can even wait till 9 to 12 months and then we can retreat them to avoid any risk of developing neurosyphilis or cardiovascular syphilis.
Anybody else would like? Dr. Bhaskar?
The prototype is you have to check the titer from 3 months, 6 months, and 12 months. And the fourfold, as other panelists have stated, fourfold decrease is showing that the treatment response is adequate. But sometimes what happens, within 3 months, the titer may not go so much as we are expecting. Usually we get the fourfold decrease within 6 to 12 months. Also, but if there is no decrease in 6 to 12 months, then we have to consider other possibilities also.
So when would you suspect that it is a treatment failure or the reinfection has occurred? When would you suspect it?
When the clinical manifestations are not declining.
Right.
And if there is no fourfold declining in the VDRL result, or if there is an increase in the VDRL titer.
So if the increase in the VDRL titer fourfold, so we will then call it as reinfection. So and if it does not decline, so then we call it that as a treatment failure. Okay, so now we come on to the next case. The clinical picture is in front of you. We have a 36-year-old male who complains of itching on the glands and burning while urination, which is associated with a thick yellow colored fluid discharge, which is more noticeable in the morning since the past 4 to 5 days. On local examination, there is a profuse purulent yellow urethral discharge, which is seen at the external urethral meatus with mild erythema and edema of the meatus. There is no history of any fever, joint pains, or skin rash or testicular pain, and there was history of unprotected contact in the last 7 days before the onset of symptoms with a female unknown to him, and HIV, ELISA, and VDRL were negative. So coming on to the first question, what would be your differentials in such a case of a urethral discharge? Anybody from the panel, if they want to take it?
I mean, it is evident from the history that it is going towards gonococcal urethritis. Differentials would be the non-gonococcal, we have to differentiate it from non-gonococcal urethritis. And given the acuteness of the symptoms, the presentation occurs within 1 week.
Yeah.
The profuse yellow discharge and the symptoms. So it suggests more towards gonococcal urethritis.
Right. Anybody else with any other differential? No? Okay. Would you like to consider candidal balanitis in them? No, not really. Perfect. So how would you differentiate with the history and the examination? How would you differentiate between gonococcal and non-gonococcal urethritis in this case or in any case for the matter?
Like the amount of discharge and the nature of discharge will be profuse and thick mucopurulent in case of gonococcal, whereas in non-gonococcal it will be very scanty.
Yeah.
And only burning micturition will be their complaints. Discharge,
Right. Right. Any other differentiating point?
Also, clinical examination is important. There may be meatal erythema and edema in case of gonorrhea.
Yeah.
And also the incubation periods. That
Yes.
is patient usually present within 7 days, as in this case,
As is in
in
this
case of
case.
gonococcal.
So we would go for a gonococcal urethritis, the diagnosis of gonococcal urethritis in this case. Perfect. So how common is co-infection of chlamydia in these cases? Have you seen co-infection of chlamydia in these cases along with gonorrhea, and how common have you seen it?
More of co-infection, most of the, some of the patients whom we treated, they present with post-gonococcal urethritis, symptoms persisting even after
Yeah.
effective treatment. So we do empirically treat them for chlamydia urethritis as well.
Right. So it's quite common, roughly in 20 to 40% of the cases, we do see co-infection with chlamydia in these cases, and therefore dual therapy is always advised to be given to them. Would you like to get any diagnostic tests done in this case, or will the clinical features be sufficient for you to clinch the diagnosis?
Not a diagnostic test lab. I mean, if we have the facility with a microscope and gram stain, we can get a gram stain done. But since the patient had a contact with an unknown female, I would like to rule out other STIs, especially HIV and HBsAg in this individual.
Yes.
For confirmatory, I will restrict myself to side lab investigation.
To gram staining. But any other test, just for maybe academic purposes, you would want to get it done in them?
Culture can be asked for, but I don't routinely.
I think in this scenario nowadays, as superbugs has come, so culture sensitivity is almost must, because you cannot treat without any antibiotic sensitivity test nowadays.
Right. No, I know it. Okay. Which would be the fastest and the most practical test in this case? I think you've answered with that would be the. So what would be your treatment of choice in this case?
I will go with ceftriaxone injection, 250 milligram intramuscular injection, single injection, sir. And since there are chances of post-gonococcal urethritis also, azithromycin 1 gram start dose I will give.
Right. Along with that for the
ceftriaxone injection.
Ceftriaxone injection. Perfect. Right. When would you label such a case as a treatment failure? Because we do see antimicrobial resistance these days. So when would you label it as a failure, that the treatment is not worked or the treatment is failed?
Maybe after effective proper dosing of antibiotic therapy, if the patient doesn't respond within 5 to 7 days, then we have to think of antimicrobial resistance or other co-infection of STIs too.
Right. Any other pointer for the treatment failure? No. So basically, if there's a positive test of cure, where if the positive culture more than 72 hours after the treatment is present along and there is no sexual contact in this period, so then also we can call it as treatment failure. So what would be the treatment? Suppose we have given the treatment, patient has not responded in the 3 to 5 days, the symptoms are still persisting and there's no history of any sexual contact. So what would be the treatment, choice of treatment in that case?
Second line agents we will give like ciprofloxacin we might give, but if there is a resistance documented or resistance is prevalence in the community where the patient presents from, then we go for spectinomycin if available.
Dr. Bhaskar, you would like to?
Two approach actually. If you are getting the culture sensitivity, you can treat according to the sensitivity report. Otherwise, you can follow the CDC guideline. which shows that you can go with the gentamicin, aminoglycoside injection,
Yes.
and azithromycin 2 gram.
Yes.
And another alternative which has come is also etravenol 1 gram IV for 3 days.
Right, perfect. So suppose we don't treat this case or the patient comes to us quite late. What are the complications that we would be looking at in this case, in the patient?
In this case, the complications would be like epididymoarchitis or present with prostatitis, then then urethral stricture, and if the infection is disseminated, then we will get the disseminated gonococcal infection or dermatitis arthritis syndrome, and that can also involve the other systems like cardiovascular syndrome and central nervous system also.
So what are the red flags that you would be looking for in this patient to rule out a disseminated gonococcal infection?
In case of disseminated gonococcal infection, we may get the history of fever along with some skin rashes like painless hemorrhagic or pustular rashes along with migratory polyarthralgia, tenosynovitis and septic arthritis.
Yeah, so we have to look for the classical triad of dermatitis, tenosynovitis and polyarthralgia. Right, so with that I think we'll shut this case down. And coming on to the last case for the day, yeah, we still have time. It's quite a simple case. 22-year-old college student, he presented with these painful lesions over the penis since the past 4 days. On examination, we see multiple grooved vesicles on an erythematous base over the glans penis, which progresses to painful shallow ulcers. The patient complained of fever, malaise, and myalgia before the lesions formed. He gave history of sexual contact with a sex worker 15 days before the onset of symptoms, and patient gave no history of such lesions in the past. He also gives no history of any drug intake. So what would be your differential in this case of a painful genital ulcer? Like we had a painless genital ulcer in the first case. So in painful genital ulcer, what would you want to keep as your differentials? We know what the case is from the morphological lesions. It's quite clear, but still, what would you want to keep the differentials as?
Like first would be herpes genitalis.
Yeah.
Then Behçet syndrome.
Yes.
Then fixed drug eruption do present, but morphology wise it doesn't fit.
It does not look like that. Plus there was no drug history in the, I forgot to write it, but there was no drug history in the patient.
And includes synchroid in this case.
Yeah, quite superficial, but yeah.
Sometimes we cannot miss, as some lesions are also pustular, so it can be an early phase of pyoderma gangrenosa also.
Yes.
And moreover, you cannot forget autoimmune bullous disorder in
Yeah.
these painful genital ulcers.
Right, perfect. I think all the differentials have been covered. Any hallmark dermatological features which you would look in this case which would help you clinch the diagnosis?
Grouping of vesicles,
Grouping of
if there is erosion, polycyclic margins of the erosions.
Right.
And a painful lymphadenopathy if it is.
Perfect. Any other?
Prodromal symptoms are there also.
Yeah, prodromal symptoms were there, so that will also help us in the diagnosis. What features in this case would strongly suggest a primary herpes genitalis?
Presence of prodromal symptoms and
Yeah.
number of lesions were numerous.
Yes.
So they will point towards. And duration is also like 15 days prior to the onset.
Prior to the, yeah.
And there is no previous such lesions, no previous
history along with this, and plus the symptomatology, the prodromal symptomatology was quite severe. Good. How important it is the history of grouped vesicles on an erythematous base?
It usually showing that their lesions are extensive, so this gives more clue towards the primary herpes lesion.
Yeah.
And also it is also showing that the lesions are early, so active disease. So acyclovir is an indication. So this will also help us in the management.
Any other point from any other take from any other panelists? No? Okay. So the prodroma, fever, malaise and myalgia would definitely influence our diagnosis. We have covered this topic. Would the systemic symptoms, first of all, the features that would help us label is as primary herpes than recurrent infection? We have discussed this. And would the symptoms, with the same systemic symptoms we expected in the recurrent episodes? Would it be expected in the recurrent
Possibility is less. Because with the episodes, there is formation of antibodies, so chance of dissemination also goes below.
Quite less. So is this a purely clinical diagnosis, or would you want to go for some lab tests? We see quite commonly herpes HSV1, HSV2 being antigen tests being done, antibody tests being done. Would you want to go for those tests, or you will just the clinical picture is sufficient for clinching the diagnosis?
Since it is primary, I would go for serological investigations.
You want to go for serological investigation. Anybody else?
Also, you have to do the vitriol and HIV status needs to be done. And for the confirmation of diagnosis, Jank smear can be done, but because it is a bedside test, takes only 10 minutes, so
Right.
it can be done.
Right. Any other take from any of the panelists? No? Okay. So the investigations we have done or covered, viral culture, PCR, I don't think we want to really get done in this. Any complications that we would want to look for in this patient if the patient is not treated? Rare complications we don't see quite commonly.
If don't treat it, the complications should be divided into two categories, local and systemic. In local, the most common complication is secondary bacterial infection. Other than that, if the lesion heals, there is a scarring, dyspigmentation. And in case of systemic complications, there would be aseptic meningitis, acute urinary retention, proctitis, and disease.
That more or less covered it up. The treatment of choice in the primary herpes genitalis, what would be your treatment of choice? We all know the drugs, what would be the acyclovir dosage that you would want to start with?
I didn't get your question.
Acyclovir. You would want to start with acyclovir.
Acyclovir.
Three antiviral drugs are there.
So
Acyclovir, famciclovir, valsiclovir. I want to know the doses of all the three from one by one from all of you. The dosage of acyclovir in this patient.
Acyclovir 400 milligram thrice a day for 7 to 10 days if it is primary. Recurrence I will restrict to 5 days. Valacyclovir, similar various regimens are there. The one I follow is 1 gram twice daily for 7 to 10 days if it is primary, or restrict to 5 days.
And famciclovir does any of you use famciclovir?
I have
no, not really. Okay, then.
Theoretically, the dose is 250 milligram twice daily for 7 to 10 days.
Does the early initiation of the antiviral, does it change the course of the disease? Like suppose the patient has come to you on day 1 of the formation when he starts feeling this, when he starts seeing the lesions. So at that point of time, the treatment has been started quite early. Will it have any impact on the disease course?
Recurrence rate have come down. So for few patients who present within, whom we start treatment within 72 hours of their initial development of lesions, they have minimal episodes of recurrence. Whereas patients who have treated later after 72 hours, the recurrent episodes, on my personal experience.
Usually, if we start within 72 hours, so chance of complications goes less.
Yeah.
Severity comes down.
Yeah.
But the thing is that recurrence also can occur because usually the antiviral therapy does not change the course of recurrence.
Course of recurrence, right. So would you want to admit that basically when would you want to admit any of these patients? We usually don't admit herpes simplex patients, but if the need arises, when would you want to admit them?
Co-added infection, especially if it is an HIV-associated patient who present with herpes genitals, we have deep ulcers, painful ulcers, and some amount of scarring will be there. And hemorrhagic lesions, if they present with those patients for evaluation purpose, I would admit.
Also, the signs of aseptic meningitis like fever, neck rigidity, if this is there, so we have to admit the patient.
Right. Just a few more questions as left. Any role of the topical therapy in the treatment? Just a yes or no answer. That's it. No, perfect. We'll move forward. How would you counsel this patient regarding the recurrence? We'll just focus on the recurrence. The transmission sexual activity we know. I would just want to focus on the recurrence since we are out of time.
Recurrence, I always tell them that chances of recurrence is there regarding herpes. So suppose if the patient has recurrent episodes of herpes genitalis, then I would go for serological investigation and put him on suppressive therapy, which I will counsel him on the first day itself.
Would you like to ask him to look out for certain triggers for recurrence? If you have noticed in your practice certain triggers, certain factors which trigger the recurrence?
For herpes genitalis, other than sexual activity, I have not noted per se, sir. Like maybe I didn't have an idea to look for.
Because many times I've seen patients coming with that, suppose they have taken alcohol one night before, a lot of alcohol has been consumed. So next day, they usually give history that last night I consumed a lot of alcohol and these days, and suddenly the recurrence is there. So have any of you noticed such thing in the patient's history?
Yeah, alcohol also stress factor, emotional stress. Other infections in the body, they can trigger the herpes infection. And for that, you can counsel the patient for the episodic therapy also.
Right. Would you screen that or treat the partner in this case?
Yes, sir.
You would screen and
Yes.
treat the partner in this case? Perfect. And when would you consider the patient for suppressive antiviral therapy? This is the last question, we'll wrap it up after this. When would you consider the patient for a suppressive antiviral therapy?
When there are more than 4 to 6 episodes per year, then I will think of suppressive thing. Or even if IgG is on a higher side.
Right.
Then
Perfect.
Yeah, more than 6 episodes per year.
Oh yeah. The treatment we have already discussed, and with that we come to threshold for starting long-term suppression. Okay. With that we come to the end of the panel discussion. Thank you so much for the Thank you so much to the panelists for keeping it short, and we finished almost on time. Thank you so much.
Thank you so much for such an enlightening panel. It was really something we face in our everyday and a discussion worth listening. Now, I would like to request all the panelists and our moderator and previous chairperson, Dr. Mukesh Raj sir, to kindly collect the mementos. Moving on to the next session, the Derma Melange, I would like to call upon our chairpersons, Dr. Amuda M. Ma'am and Dr. Santosh Modi sir, to kindly call upon our speaker for the next session.
Yeah, good evening, everybody. We welcome our next speaker, Dr. Anil Ganju, who needs no introduction. He's a senior consultant dermatologist and laser surgeon and director of Skinnovation Clinics, and presently president SARC and AAD. He has numerous publications and chapters in his name, and his area of interest are lasers, trichology, acne. Over to you, sir.
Thank you very much, ma'am. And am I audible? And thank you, Team Clinicon, for giving me this opportunity to be amongst all of you. And this is a beautiful city, and your destinations are always beautiful. We want to attend your conferences because they are at the best places in our country. So, friends, I am going to talk about patterned hair loss. And this is something that affects a huge number of our patients, and many a time we are at a loss as to what to do next, because many of our patients stop responding to treatment or do not respond to treatment or have a number of problems with the treatment. So this is a very common condition and has a huge impact on the quality of life. You know, most of the patients who have lost hair and want hair on their scalp, they are really frustrated and have a huge impact on the quality of life. And it's a very, very common condition. About 30% of the men by the age of 30 will have some degree of alopecia and androgenetic alopecia. It happens in 50% of those in 50s, and it goes on increasing thereafter. And actually, it's not hair loss. You all know it's miniaturization happening under the influence of androgens, and it is genetically, determined in those patients who have this, slow miniaturization of the hair. It's important to understand that it is not only the hair follicle which is important, it is also the structures around the hair follicle that are important to maintain the normal health of the hair follicle, like the inner root sheath, the hair bulb, the papilla, and the extracellular matrix. Lately, there is a lot of interest that has developed into the extracellular matrix and the milieu around the hair follicle, the health of which is supposed to be very important for maintaining the normal hair growth. So let's look at what is happening in this line. So the dermal papilla plays a very important role in the generation of the hair follicle, the growth of the hair follicle, the size of the hair follicle, and the cycling of the hair follicle. And then the extracellular matrix. So the extracellular matrix determines the volume of the dermal papilla, and the volume of the extracellular matrix also. And lately, a lot of studies have gone into the importance of this extracellular matrix. It has been seen that as this miniaturization is happening in patients of androgenetic alopecia, the extracellular matrix is slowly deteriorating, and the anchoring effect of the extracellular matrix on the hair follicle goes down, and this could be playing a major role in the loss of hair in patients of androgenetic alopecia. The extracellular matrix contains a number of agents like collagen 3, 7, laminin. Their presence is extremely important to provide proper anchorage and health to the hair follicle. And studies have now shown that there is progressive derangement of the extracellular matrix as we move on in these patients of androgenetic alopecia, and probably androgens play a role also in deterioration of the extracellular matrix. Not only the androgens, we'll see at a number of other factors that are responsible in the deterioration of this extracellular matrix that leads to a deranged health of the extracellular matrix, and finally thinner hair. Now, there's a concept of follicular microinflammation that is playing role also in addition to other pathways. So we were all those years thinking of a 5-dihydrotestosterone pathway being the major, causative factor to lead to this miniaturization of the hair under the influence of androgens. But there are many other things happening. As I told you, the extracellular matrix is important, and probably follicular microinflammation, which happens because of a number of environmental insults. We have the UV radiation, we have chemicals, we have climatic variations, we have various external internal stresses, we have chronological aging, and then the hormones. They are all responsible for production of a number of pro-inflammatory cytokines that lead to a subtle inflammatory response around the hair follicle. So some inflammation is happening, and that leads to fibrosis, derangement of the extracellular matrix, and finally hair loss. And despite so many years of research that has gone into this difficult disease, you all face it day in and day out, there aren't many drugs that have been approved for this condition. We have just 2 drugs for this condition that have been approved. We have oral finasteride and we have topical minoxidil. There is no other drug that has been approved. There are thousands of drugs that are available, but none is approved. Now, one out of the approved drugs, finasteride, is a very useful drug. It provides good response in a good number of patients because 5-dihydrotestosterone is an important pathway that leads to miniaturization of hair in these patients. And minoxidil works well in many of the patients, and although the response can take time, and we have seen that these 2 together can produce quite good results in our patients. For example, about 5 to 6 months of treatment, most of you have experienced that many of the patients do well with this combination. However, finasteride has its problems. So many of your patients must now be coming in saying that I don't want to take finasteride, and even minoxidil. Somehow many of them believe that minoxidil is also not a very good medicine to even apply. We are thinking of giving it orally also. Finasteride has its problem. One is this concern of sexual dysfunction, which is actually overhyped. Most of the literature is saying that it probably does not happen, but it is very difficult for the patients to be made understood. So therefore, it is sometimes difficult to give this. So although most of the studies have shown that probably there's a very, very minimal higher risk of having sexual dysfunction in patients of taking finasteride, although that is reversible also. But the problem is here. So if you go onto the net, you will see that most of these side effects are attributed to finasteride. They say you can get impotence in up to 18%. You can get abnormal ejaculation in up to 7.2%, decreased ejaculatory volume, abnormal sexual function, gynecomastia. So this deters most of our patients from taking finasteride, and you can't make them understand that it really does not happen. So if it is in their mind, it will happen because it's a very sensitive issue. If you have a disturbed psychological milieu and you think that it is going to happen, it will happen because sexual function is psychologically related to a sound psyche also. Then there were some concerns about this post-finasteride syndrome, etc. that have been, also thought to be controversial. There are also reports of finasteride causing coronary artery disease, causing insulin resistance, causing fatty liver. So these are all concerns with finasteride. So therefore, we are looking at newer therapies. And why are we looking at newer therapies? Because even finasteride and minoxidil does not work in all. It is only about 30 to 40% of the patients who will get response with this combination. And the response plateaus. After about 2 years, they will not work further, or the patient may start deteriorating. So therefore, you have to look at other avenues. There are problems of tediousness and messiness of application of minoxidil. Many of the patients will have irritation. They will not want to apply it. And since it has to be applied for years together, they don't want to continue it for a long time. So problem of compliance. Therefore, topical finasteride has come in, and topical finasteride has the advantage of being 10-fold less possibility of getting into your system. So therefore, you can explain to your patients that since it is not getting into your system, the possibility of sexual side effects is low. So this is one thing that can be really added to your treatment. And although earlier it was thought that topical finasteride does not really penetrate and have its effect, but now many of the studies have shown that topical finasteride does work and help hair growth. Now, minoxidil, the other one, as I've already mentioned, has a number of problems. The problems of contact irritation, the problems of it getting onto the face and causing hypertrichosis, the problems of it being tedious and messy, and therefore the patient compliance is low. So therefore, we now have oral minoxidil, and it's really, really safe to use, although many of us were skeptical about using oral minoxidil earlier. But now I have almost fully shifted on to oral minoxidil, and I'll tell you why. Because the concern was the side effects which were happening at a higher dose of 10 to 40 milligrams, which is used for hypertension. The side effects do not happen at the dose that we are using it at. There were these concerns which were happening at those doses, but 10 to 40 milligrams was where it was happening. So it is important to know that at the dose that we are using oral minoxidil, the systemic exposure or systemic levels of minoxidil do not go so high, which has been proven by pharmacokinetics. So they looked at the pharmacokinetics of oral minoxidil, and they compared a 2.5 milligram versus a 5 milligram dosage. And you can see that at 5 milligram oral dose, the serum concentration at 1 hour is 157 nanograms per mil. Compare it with 2.5, which is 1/5 the concentration, 28. So it is disproportionately less. You halve the dose, your serum concentration goes 5 times less. Therefore, the side effect profile goes less. So look at this graph. The green one shows you a 5 milligram dose. At 1 hour, you go here. And a 2.5 milligram dose at 1 hour, you go here only. So that makes us really happy that probably at our dose of 2.5 milligrams, we are fairly safe to use oral minoxidil. And let me tell you, most of my patients are now on oral minoxidil. Myself also, I'm on oral minoxidil, and I'm very happy with it. So time to move on. We have other therapies. We are also looking at dutasteride now, because dutasteride is a stronger and more avid inhibitor of 5-alpha reductase. Number one, it does not inhibit only type 2, it also inhibits type 1, therefore a better effect to produce with, although it is suggested that the side effect profile may also be worse. So therefore, many patients will not want to take it, but now it has been approved for use at 0.5 milligrams daily in many of the countries like Japan and South Korea. There are several studies available that showing it as good as finasteride. So we have dutasteride mesotherapy now, which again helps us bypass the problems with the oral dutasteride. So many patients are wary about taking oral dutasteride. So you have dutasteride mesotherapy. So we give mini injections of dutasteride solution, which is now available on the scalp, and about 1.5 to 3 milliliters given initially at monthly intervals, and then once every 3 months is good enough to maintain the levels within the body. So our experience has been that I give it every month for about first 3 months, and then give it once in 3 months, and the patients remain in good control. The main side effects are local pain, etc. Some patients may get a little bit of swelling, but otherwise a safe therapy. It has also been seen that keeping ketoconazole shampoo as an adjuvant in your therapy does a lot of good to the patient because of several important things. One is the seborrhea and seborrheic dermatitis that is associated in most of the patients of androgenetic alopecia and adds to the follicular microinflammation is taken care of, and ketoconazole is an anti-androgen by itself and that helps. So therefore, I give ketoconazole shampoo to all my patients, whether they have dandruff or not have dandruff, because it helps. Now, there are other preparations available like Capixil, which is a combination of biotin A, a powerful antioxidant, and a 5-alpha reductase inhibitor with this tripeptide that induces the extracellular matrix production. So a combination works better. We have Procapil. You all know these are combinations. We have Redensil. We have combinations of these available. They are all helping. The latest development that is happening is things like topical anti-androgens. So anti-androgens like clascoterone has been developed for treatment of acne. We have phase 1 clinical trials happening with a number of topical androgen antagonists like this molecule, which works in a very unique way to block the androgens in the skin and therefore helps reduce the miniaturization of the hair. The prostaglandin metabolism has been looked at a potential target for the treatment in androgenetic alopecia, and we have both prostaglandin analogs helping the hair growth and prostaglandin antagonists helping the hair growth. I'll tell you how that happens. So look at the prostaglandin metabolism. There are two types of prostaglandins, PGD2 and prostaglandin F2 alpha, which have an influence on the hair growth. The PGD2 or the prostaglandin D2 has a negative impact on the hair growth and causes miniaturization of the hair, while as the prostaglandin F2 alpha has a positive influence on the hair growth and improves hair growth. So if we use a drug that inhibits the prostaglandin D2, we would improve the hair growth, and if we have a drug which helps or is an analog of prostaglandin F2 alpha, that would help us grow hair. So how do we do that? Can you imagine your age-old friend cetirizine is now being looked at in a topical formulation for treatment of androgenetic alopecia because cetirizine is a prostaglandin D2 antagonist. So 1% serum or nanoparticle preparation is being looked at, applied to the scalp. It inhibits the prostaglandin D2 and improves the hair growth. So soon we may have cetirizine topical application. We also have a prostaglandin inhibitor in the form of certiprent, which also works in a similar way, which could be also a helpful drug in patients. And we have the iontoprost. What does iontoprost do? It works on the other prostaglandin. It's an analog. It helps prostaglandin F2 alpha to work better, express better, and that induces the hair growth. And botulinum toxin cannot be left behind. It works everywhere. It is used in everything, and now it is being used for hair growth also. So how does it work? It works by blocking the presynaptic release of the acetylcholine, relaxes the scalp muscles, and probably improves the blood flow to the hair follicle. And it has been probably seen also to reduce the gene transcription and expression of transforming growth factor beta, which has been considered to be overexpressed in patients of androgenetic alopecia causing hair loss. So therefore, if you inhibit the transforming growth factor beta, which botulinum toxin does, you can treat androgenetic alopecia. I'll not go into the procedural treatments because this was medical treatment and we don't have time, but these are all the things that are being done. I'll quickly go to one interesting thing that we are recently doing. So peptides, Regenera, we are doing all these adding to our effects. So, but this is interesting. We are now putting threads into the scalp, to improve the hair growth also. So imagine threads being done to rejuvenate the skin on the face, to lift the skin of the face or body. Now we do scalp threading. So we put PDO threads, monothreads into the scalp. Mostly patients of hair loss in the vertex, which is not doing well, responding to treatment. we have been doing this and we have found fairly good results happening. So these patients have been on treatment, are on treatment with the conventional finasteride, minoxidil, PRPs. Their vertexes do not respond. And then I have seen that if I add threads, the vertexes also start responding. So friends, androgenetic alopecia is a huge disease, very common disease, has a huge impact on the quality of life. We are always looking for newer therapies for this difficult condition. We have just 2 as of now approved, but in spite of that, we have a number of drugs available now in future that could help us treat this disease much better than we were treating it earlier. Finally, the dialogues in clinical dermatology, SARC AAD, is now happening in the city of Lakes at Udaipur. We are waiting for you. It will be 18th to 21st of December 2026. Please be with us. We would love to host you. Thank you very much.
Thank you, sir. Thank you for such an enlightening session. Some Guru Gyan from you, sir.
Yes,
sir,
please.
you talked about oral minoxidil. Any side effect till now in any patients?
Okay, I have been trying to look for side effects. First of all, when I took it, initially I was on 2.5 milligrams of minoxidil and 1 milligram of finasteride, and I started getting headaches. And I thought, I did not know why I was getting headaches, and then I suddenly realized probably this, so I discontinued, and the headaches went. So probably headaches happened. But then after that, I have been asking my patients who run in hundreds who are on minoxidil, I specifically asked them, did you get a headache? Did you get postural hypotension? I used to get a little giddiness also on standing up. But then after about 5-6 months, I restarted, again 2.5, and now I am on 3.75. So my patients are on 5 also, and I am happy. Most of the patients are not complaining of any side effects.
And sir, other oral combination with this oral minoxidil, what do you prefer? Finasteride, tutasteride, or
both?
Any other?
Both. I find them equally good. So I'm mostly on finasteride only.
This cyclic therapy? Cyclic
therapy. All my patients will be on.
You add with oral
Yeah,
minoxidil?
I add that. That is just an adjuvant. And I believe that there is some amount of micronutrient supplementation that we should do to all these patients that probably helps their hair growth.
Thank you, sir. Thank you.
Thank you, sir, for a nice talk. Dr. Manas here. Sir, minoxidil booster, when it came with a lot of noise. So where do you stand now, sir?
I am not very happy with it. Number one, it becomes very messy and tedious for the patient to apply 10 minutes before and then apply minoxidil. And I did not find it working very well. On paper, yes, it does. And on paper, okay. The other thing about oral minoxidil is that it bypasses the cutaneous sulfonyl transferase. So it gets converted into the active minoxidil sulfate in the liver. So people who are deficient in sulfonyl transferase, cutaneous sulfonyl transferase, are also benefited by oral minoxidil. So that also is taken care of. Having said that, I am not very happy with the topical booster.
So that kit I'm using, I've used in a lot of patients to test that one because it is lesser cost. So hardly out of 105 patients are having negative. So maybe we are not having that much problems in our country. That is the reason it didn't work at well.
Maybe.
Thank you.
Thank you.
Thank you, sir, for your very enlightening presentation. We have learnt a lot today. Any more questions from the audience? Otherwise,
Sir,
we'll
one
wind-
question from me. Patient don't want to take finasteride for longer time. Can we use a lower dose of finasteride?
Yes, lower dose of finasteride at 1 milligram on alternate day, 1 milligram twice a week have also been tried, and many of the studies have shown them to be equally effective. But I believe most of the studies are available on 1 milligram daily. It should be given in that proper dose.
Twice weekly works better.
It works okay on twice a week also. Many studies have shown twice a week also.
Sir, I have a question. You are talking about the injection dutasteride. So after 3 months, how do we maintain them, sir?
Every 3 months you have to keep on doing it always. Like we believe that androgenetic alopecia has to be treated lifelong. So we treat it as long as the patient.
We are not going for oral. It has to be.
Yeah, you can give it once in 3 months only,
Okay, sir.
and it maintains good effect.
Okay, sir.
Thank you, sir.
Female pattern hair loss?
Can somebody give mic to him?
Sir, I want to know about the female pattern hair loss and what topical injections do you prefer? Any hormonal injections, therapy you prefer for the female pattern hair loss?
Injections, no. In fact, I'll be careful again on dutasteride mesotherapy in females of childbearing age. Otherwise, generally in females, we use the same therapy except that if you are giving topical minoxidil, what is approved is 5% minoxidil given once a day only. And if you are giving oral minoxidil, we generally give a lower dose. I start with 1.25, go a maximum of 2.5. I generally do not go beyond 2.5 because hypertrichosis is a very common side effect that happens. Otherwise, in females, we can do rest of the all the therapies you can do.
And what about, sir, injection, bicalutamide injections?
I have not used, but I have used oral bicalutamide. I use 50 milligrams of oral bicalutamide. I use spironolactone a lot in female pattern hair loss, and I find it useful. Some patients who get problems with spironolactone, I go to bicalutamide, and that gives less side effects, like menstrual side effects, etc.
Thank you.
So one more question. Sir, what is the duration you take for updosing oral minoxidil? If you start with 1.25, then when do you make it 2.5 and 5?
Usually within a month or two, I do upscale, and in males I start with 2.5, and if they are doing well, then maybe I keep them on 2.5 only. Females, I start with 1.25. If they are doing well, beyond 1.2, if I need to, I may go to 2.5. I don't usually go beyond 2.5.
So when they come for follow-up, what are the things that you monitor?
So one, I would look at regrowth, the miniaturized hairs becoming thicker, the hairline hair. We see that the
No,
thin.
sir, I'm asking whether you monitor the BP or anything of that sort.
I don't directly, but I ask for these symptoms of giddiness, headaches, standing up and getting giddy. I ask all my patients because I am very wary, because I saw it happening to me, and therefore I ask it, and surprisingly I have not found any patient coming back with side effects.
Thank you, sir.
Okay, we are getting for the next session.
So
Thank you,
just
thank you, sir.
Thank you so much.
Thank
sir.
you so much.
Thank you.
Moving on to our next session, may I invite Dr. Meerabai Mohanty and Dr. Rajlakshmi VP to chair the session, please. So speaker for the session is Dr. Swati Shah. So I would request Dr. Meerabai Mohanty and Dr. Rajlakshmi VP to share a brief introduction of Dr. Swati Shah.
Good evening all. Thank you for the invitation, sir. Now we welcome Dr. Swati Shah ma'am. She is lecturer in National Medical College, Nepal. She has come from long way from Nepal. She is a representative member of Sodveglon and conducted multiple CMEs and published case reports and organized committee member. She is a national speaker also. We welcome you, ma'am. Ma'am's topic is an interesting topic. Dermatology in the era of steroid misuse, a silent epidemic. Welcome, ma'am.
Thank you, thank you. Good evening, everyone. Good evening, respected chairperson, distinguished guests, honorable speakers, and dear guests. Today, I am honored to present on a topic of ongoing concern, dermatology in the era of steroid misuse, confronting a silent epidemic. Topical corticosteroids have long been considered as a cornerstone in the dermatological therapy due to its anti-inflammatory and immunosuppressive properties. However, their widespread use, irrational use, and easy availability have led to an alarming rise in the misuse of steroid in the communities. Today, in this presentation, we will discuss the complication, consequences, and clinical implication of steroid misuse in the steroid misuse. Before starting the presentation, I would like to introduce oneself again. I'm Dr. Swati Saab from Nepal. I'm working as a lecturer at National Medical College and Birganj Skin Hair Laser Center, Birganj, Nepal, since past 3 years. Now, let's start the topic. My topic is dermatology in the era of steroid misuse, confronting a silent epidemic. Before starting the topic, I would like to ask why this topic matters, why it is in an alarming trend. Can anyone answer to my question? Yeah, more? Okay, I'd like to reply to this question. Why this misuse of steroids matter clinically and globally? Why professionals should care? Firstly, there is a rise in global prevalence, particularly alarming trends in South Asia. This indicates that we are dealing with the growing concern of public health challenges, not just an isolated clinical issue. Secondly, the disease carries a clinical burden due to the rise in complication, such as infection, surgical complication, cardiovascular events, which increases the healthcare cost and morbidity. Finally, this highlights the importance of clinicians and consultants. Early recognition is important to prevent the complication, and there is a strict required of institutional policy for better management. Now moving to the next slide, I'll be presenting one case. This is a case of 29-year-old male who had complaint of itchy rash over back, abdomen, and face since 8 months. He gave history of multiple use of over-the-counter topical creams. After application, there was only partial and temporary improvement. The course of disease was recurrent and gradually progressive, and there was no complete resolution. This is a picture showing hyperpigmented plaque with scaling over the back, abdomen, and face. The question arises, why a simple fungal infection is behaving chronically and in an atypical manner? Can anyone answer to this question? The case is mostly misinterpreted as antifungal resistant, but in most of the case, the issue is steroid-induced disease modification, where the morphology is changed, immune response is suppressed, and the lesion becomes atypical. Now moving to the next slide, I'll be talking about the global and local perspective of the steroid misuse. The high prevalence rate was seen among the South Asian countries, and the examples are India, Nepal, Pakistan, and Bangladesh. And the moderate prevalence rate was seen among Southeast Asia, Africa, and in Europe, USA, and Australia, low prevalence rate was seen. In Nepal, up to 3 to 9% prevalence rate was seen, while India up to 30%, which is epidemic level. And globally, it is in increasing trend, especially in low and middle socioeconomic status people. Why dermatology is vulnerable? In this poster, we can see when visible skin concerns combined with easy accessibility of over-the-counter creams and societal pressure leads the patients for the harmful self-treatment. As skin diseases affects the appearance, people suffer from low esteem and quick fixes, which is more worsened when combined with misleading media and demand for quick fixes, even in chronic skin conditions. Secondly, there is also limited specialties access and lack of awareness, which leads the patients for self-treatment. These all factors creates a chain reaction, leading from misinformation to steroid misuse and steroid abuse, which further leads to complication, and in long term, there is a chronic skin problems. This diagram shows us how the steroid misuse, where visibility meets vulnerability. Now moving to the next slide. What is steroid misuse? Firstly, there is a misinformation and inaccurate health information from any unreliable sources, which drives the patients for self-medication. Prevalence is high in many settings. Almost 59% overall prevalence rate is seen. Not all self-medication are appropriate, like the misuse of drugs, inappropriate drugs, and lack of awareness. About 16.2% were found of steroid misuse, which leads the patient of excessive dosing and high use of potency steroids, which is commonly seen in adolescents. About 21.6% were found. This all leads for complications, resulting in side effects, which was found about 31.5%. There is delay in the medical care, and even the drug resistance are seen. In severe cases, even hospitalization was found. Now the next slide, I'll be talking about the mechanism and effects of topical corticosteroids in a correct use versus the misuse. Whenever the topical corticosteroids are applied as prescribed, it penetrates the skin in a controlled amount, which binds to the glucocorticoid receptor in the skin cells, where the complex is formed and it moves inside the nucleus, leading to downregulation of pro-inflammatory cytokines and upregulations of anti-inflammatory proteins, which leads the suppression of inflammation and immune response, resulting in quick improvement of the lesion. While when topical corticosteroids are used in a misused form, such as when too potent, too much, or too often is being applied, there is an excessive skin penetration and systemic absorption, which leads to overstimulation of glucocorticoid receptors, and there is impaired skin cell function and repair. And also there is a suppression of local immune response, leading for skin atrophy and other local effects such as striae, acneiform eruptions, perioral dermatitis, and hypopigmentation. Systemic effects are also seen, such as hypothalamic pituitary axis suppression, Cushing syndrome, glaucoma, osteoporosis, and in children, growth retardation can also be seen. Last not the least, we should always remember that use of topical steroids are safe and effective when used correctly, but misuse can lead to serious local and systemic harm. Now moving to the next slide. I'll be talking about the core flow chart. This diagram shows the viscous cycle of steroid misuse. It starts from the steroid use, where there is a rapid symptomatic relief, and patient gains the trust for the drug, and he starts using the drug in a repeated and under supervision form, where there is, in a long term, there is a barrier damage and suppression of local immunosuppression, which leads in a chronic diseases such as tinea incognita and in a atypical diseases also. Patient perceives this as a treatment failure and starts using steroid more and more. This cycle shows us how a rapid symptomatic relief can trap the patient for a long-term use. Now, the most commonly misused steroids. Among topical corticosteroids, the most commonly misused steroids are super potent, and the examples are clobetasol, mainly occurring tinea incognito and steroid rosacea. In high potency, betamethasone and mometasone are used, mainly in cosmetic purpose like acne and pigmentation. And hydrocortisone cream are mostly misused in children for diapodermatitis. Among irrational combination creams, the creams mixed with steroid, antifungal, and antibiotic are used mostly, leading to chronic dermatophytosis, barrier damage, and mass infection. In oral corticosteroids, prednisolone and dexamethasone are used. Oftenly the patterns are in repeated short courses and chronic low dose use, and in a non-specific indication. We should always remember the most misused is the clobetasol, and while the most harmful pattern is the steroid-containing creams for fungal infection. Now moving to the next slide, I'll be talking about the risk factor and the dermatographics. The most common age groups is found between 18 to 40 years. This indicates young and socially active people are more oriented to the skin problems. Female are more predominantly found due to the cosmetic purpose like fairness, acne, and pigmentation. It is mostly commonly seen in urban, peri-urban, low middle socioeconomic people due to the easy availability of the over-the-counter creams. Additionally, high cosmetic concern and recurrent dermatosis patients have also been found the misuse of steroid. Now I'll be talking about the clinical consequences, the local effects. The common are steroid acne, telangiectasia, striae, atrophy, and pigmentary changes. Here in this picture we can see multiple comedones and erythematous papules with pigmentation present over her cheek. She had been applying betamethasone for 3 months for acne treatment. And in the next picture also we can see a prominent blood vessels. She had been using same betamethasone for the fairness. Now the systemic side effects, the common one are hypertension, metabolic disturbance, and adrenal suppression, and in children, growth retardation. Now the next slide, I'll be talking about the management. Firstly, and the most important is the withdrawal of the steroid. If the patient is under high potent steroid, then we should taper them into the low potent and then modulate the treatment for steroid sparing agents like calcineurin inhibitors, tacrolimus and pimecrolimus. And then after only we should target the disease, starting the main line of the treatment. Last not the least, we should always repair the skin by giving emollients and sunscreens. Now here are some case-based learning. This is a picture of 13-year female child. She had been using betamethasone for acne, and we can see prominent blood vessels and some acne also. This is the picture of 36-year female who has been using clobetasol for melasma, and here we can see increased pigmentation over her face. And this picture we can see prominent excessive hair growth. She had been using betamethasone for the fairness. And from left to right we can see a typical morphology of fungal infection, while in middle we can see the thinning of the stria, thinning of the skin. We can see the stria, and in the last we can see the depigmentation of the skin. Now, what is the role of media and misinformation? Media plays a vital role. Others such as advertisement and even word of mouth and lack of awareness and algorithm also plays an important role. So social media promotes unrealistic beauty and even influencer endorse unsafe products. advertisement of steroid cream marked as a cosmetic solution. Even non-medical advices from peers encourage the misuse. And last, we should always remember the poor knowledge about the steroid risks make the patients misuse of steroid. And the viral quick fixes spread faster than the evidence-based information. Now moving to the next slide, public health dimension. Steroid misuse is not just a clinical issue, it is a public health dimension. Firstly, there is an easy availability of the OTC cream. This makes the patients use topical steroids without prescription. And secondly, there is an irrational use of fixed dose creams. And thirdly, cosmetic misuse for fairness, acne, pigmentation. And there is strict lack of regulation, which makes the patient's use of high potent steroids in community levels. Now the conclusion, we are not treating the disease. We are treating the consequences of the treatment. My references are thank you so much. Any questions?
Thank you, Dr. Swati, for trying to tackle this alarming issue that every other dermatologist faces. Like you mentioned, this fairness fad and the Korean glass skin and all has blinded our Indian population. So because of that itself, we see a lot of cases coming up. Actually, I would like to ask you a question. You had shown a lot of topical steroid damaged face. So when you're, do you withdraw the steroid on and off then and there, or do you taper it, make it into a low potency hydrocortisone or desonide or something, and then you tackle these phases? What is your line of management?
Ma'am, if patient is under high potency,
yeah, high potent steroid for fairness, and they have all these hypertrichosis or steroid acne or rosacea.
I always taper the steroids, then only modulate them into steroid sparing agent. As these nowadays, many articles says that we should taper the steroids. We should directly stop the steroid. But I have tried, but once I have started abruptly stopping, they have recurrency. That's why.
A lot of them face burning and scaling and all. So do you add something like pimecrolimus or tacrolimus?
Yeah, I add tacrolimus for, I think, up to 4 weeks.
Okay, thank you so much. It was a wonderful talk, and I think there will be some regulatory board coming up so that there will be some check on the over-the-counter prescription, delivery of these steroids and misuse. Thank you.
I would like to say also healthcare professionals should be taught upon, and as a dermatologist, the treatment is a challenge to us also, and we should create awareness to government and healthcare professional and chemist and companies also. Thank you. Thank you, ma'am, for the wonderful lesson.
Thank you everyone.
Thank you, ma'am, for such a wonderful session. I would request our chairpersons and speakers to please collect their memento. For the next session, I would like to invite Dr. Rajiv Ranjan Thakur, sir, to kindly chair the session.
So good evening. Moving to next session, I would like to call our next speaker, Dr. Anupam Das, who is an associate professor. Anupam Das needs no introduction, but still he is an associate professor dermatology KPCMH. He is editor-in-chief Pigment International Journal, Associate Editor, Clinical and Experimental Dermatology, also Associate Editor of Indian Journal of Dermatology. So today we will give the lecture on recent updates, metabolic syndrome and skin.
Good evening, everyone. I think we are very much behind schedule, so I'll try to be crisp and to the point. Now, the connection between our specialty, that is dermatology, and metabolic syndrome is quite old. And this was one of our reviews published in IGAD, where we tried to find out what is there in the literature, and what we found was plenty of diseases starting from your psoriasis, acne, acanthosis nigricans, androgenetic alopecia, hidradenitis suppurativa, rosacea. Numerous diseases have been significantly found to be correlating with the presence of metabolic syndrome. Now, why this happens? Now, this is a very busy slide. I'll try to make the slide simple for you. Metabolic syndrome and certain dermatological conditions like your psoriasis, alopecia areata, all of them are connected to each other by the help of certain cytokines, specifically belonging to the Th17 and Th1 pathways and Th22 pathways. So these are the three important pathways, that is your Th1, Th17 and Th22, which form the connecting link between your psoriasis, AD, atopic dermatitis, alopecia areata, hidradenitis suppurativa, and your chronic inflammatory condition, that is your obesity. Now, this is often asked in quizzes, what are the best biomarkers for metabolic syndrome? Previously, we used to think that triglyceride is the best biomarker, or maybe HDL cholesterol is the best biomarker, but now things have changed. This is very latest from Cochrane database, and they mentioned that these are the two best biomarkers. One is a leptin-adiponectin ratio, and this ratio is a far more sensitive indicator of metabolic dysfunction instead of testing an hormone individually. And another very strong predictor of atherogenic risk and insulin resistance is triglyceride by HDL cholesterol ratio. Now, this is what happens in psoriasis. A psoriatic plaque, you can see there is a haywire thing going on regarding the Th1, Th17 pathways, and all of them are interconnected to each other because of the systemic inflammation. As a result of this, what happens is there are pro-atherogenic effects on the blood vessels, specifically attributed to TNF-alpha and interleukin 17. Now, so what is the link between psoriasis and metabolic syndrome? You can see specifically, if you just look at the last line, obese patients, they specifically have very high levels of free fatty acids, and that is due to, again, due to increased circulating levels of interleukin 17 and interleukin 23. So this explains how obesity and psoriasis are connected to each other. Now, if you ask me what is the best drug which can take care of both psoriasis and metabolic syndrome, it is the age-old magic molecule, the cheap drug, that is your methotrexate. Why? Because methotrexate, it has been shown in data that methotrexate reduces the chances of development of metabolic syndrome, and it also reduces the risk of type 2 diabetes mellitus patients. Now, biologics are being used left and right. So if we think of the anti-TNF alpha group, that is your etanercept, infliximab, and adalimumab, if you think of infliximab, now it can be potentially used to treat patients with type 2 diabetes mellitus and severe insulin resistance. But yes, it can also increase the BMI and increase the body weight. So there is a catch. Again, etanercept is one drug, it improves the insulin sensitivity, but as per literature, etanercept again increases the BMI. So far as adalimumab is concerned, there are conflicting reports on the impact on different parameters of metabolic syndrome. So which one to choose if you ask me? I think etanercept is going to be the best if a patient of psoriasis has underlying metabolic syndrome. Coming to interleukin 12-23 inhibitors, specifically ustekinumab, here we have to be very cautious, because if a patient of psoriasis has a tendency to develop metabolic syndrome, ustekinumab is something which has to be avoided. Why? Because ustekinumab, if you look into the data, there is 4 times higher odds risk ratio of developing serious cardiovascular events, or MACE, that is major adverse cardiovascular events, on initiation of ustekinumab amongst patients at high cardiovascular risk. So the message is, if you are suspecting metabolic syndrome, ustekinumab is one drug which should be preferably avoided. Coming to interleukin 17 inhibitors, yes, these are the true drugs which I would definitely prefer if I am suspecting underlying metabolic syndrome. Secukinumab, this was a very good trial published in JEADV in 2020, where you can see secukinumab led to a reduction in body weight over a period of 52 weeks. Plus, secukinumab also reduces the serum C-reactive protein level. Now, we all know C-reactive protein level, it is a very important molecule when it comes to thinking of metabolic syndrome. Apart from that, ixekizumab, which belongs to the same class, it is highly effective for treatment of moderate to severe plaque psoriasis, and it has a very good effectiveness in managing the comorbidities like your prediabetes, metabolic syndrome, and type 2 diabetes. Apremilast, yes. Now, apremilast, this again has to be taken with a pinch of salt. It either works very well or it does not work at all. In my limited experience, apremilast works specifically in palmoplantar psoriasis and also those patients who have underlying psoriatic arthropathy. Now, on patients on apremilast, significant weight loss has been reported if the drug is prescribed for a particular duration. So, if apremilast is working well, it has a very good effect on the metabolic parameters also. Metformin again this is one drug, metformin, your glucagon-like peptide 1 agonist, DPP inhibitors, thiazolidinediones, they also exhibit anti-psoriatic effect. And there is another group of drugs that is your statins, that is simvastatin and atorvastatin. They have a beneficial effect on the lipid metabolism and they also decrease psoriasis. This has been found in trials. Now how statins reduce psoriasis, this has to be studied. So this is in brief, methotrexate. If you ask me what is the best drug, methotrexate for psoriasis and metabolic syndrome. And so far as the biologics are concerned, secukinumab and ixekizumab is the best. And so far as ustekinumab is concerned, that is something which has to be avoided. Coming to acne and metabolic syndrome, now whom to screen? Any patient with acne keloidal nuchae, any patient who has acne along with acanthosis nigricans, acne suggestive of underlying PCOD, that is insulin resistance. Also, if there is adult onset acne and any obese patient who comes to acne be of any grade or any severity, those patients have to be screened for metabolic syndrome. These are different patients of acne keloidal nuchae. On the right hand side, you can see a patient of acne, treatment refractory acne, and there are also features of cutaneous hyperandrogenism. You can see the acne is specifically located along the jawline. You can see features of hirsutism. So this is something very important. Now, why acne is connected to acne keloidal nuchae is connected to metabolic syndrome? This is again very much studied in details. So first is obesity. What it does is obese patients, there is an increased chance of friction and excessive moisture in the scalp skin folds, specifically in our occipital and posterior neck regions. And because of that friction, what happens is follicular occlusion. So this follicular occlusion is incriminated as the central pathogenic factor when we think of acne keloidal nuchae. So any acne patient, if you are suspecting metabolic syndrome, just a simple blood pressure measurement and asking for the lipid profile is always helpful, because studies have demonstrated that acne patients who have hypertension, there is a very high chance of these patients going into metabolic syndrome in future. Also, if you do a lipid profile, if the mean HDL level is lower than what it should be, chances of these patients going into metabolic syndrome is again high. Also, there has been debate regarding the role of low glycemic index food in the management of acne. This is again debatable, why milk increases acne, why cheese reduces acne. This is again beyond the scope of this presentation. So this is one connecting pathway which explains why acne and metabolic syndrome are connected to each other, and that is because of the mTORC pathway. So this mTORC pathway is now very extensively studied in different basic science research labs, and there it has been found that whenever this mTORC protein is hyperexpressed, there are more chances of diabetes mellitus, there is more chances of insulin resistance, acne vulgaris, obesity and everything. So if you can suppress the mTORC, it can lead to beneficial effects on the acne as well. So very simple thing is reduction of milk consumption. Not in all patients. If an acne patient has chances of development of metabolic syndrome, if an acne patient has features of deranged lipid profile, it is always prudent to advise reduction of milk consumption, reduction of hyperglycemic carbohydrates, and in such patients, apart from routine acne treatment, metformin is something which works very well. Also, if there is no derangement in the lipid profile, there could be other parameters of metabolic syndrome. Something which works very well is a low dose isotretinoin, that is 0.5 milligram per kg per day for 1 week, every 4 weeks for 6 months. So this was another very good study published in JAD in 2019, and it was a study, you can see, a nationwide study of 6 lakh adolescents where acne has been connected with obesity and metabolic syndrome, but again information was lacking regarding the potential confounders and acne severity. So yes, this study has to be taken with a pinch of salt. Coming to metabolic syndrome and pigmentation, this is the list of disorders which have been reported to have connection between pigmentary disorders and metabolic syndrome. The first one, of course, is acanthosis nigricans. Then you have maturational pigmentation, vitiligo. So far as melasma and acquired dermal macular hyperpigmentation is concerned, reports are conflicting whether these two entities are associated with metabolic syndrome or not. Acanthosis nigricans and METs, we all know this is an age-long thing, but what is important is facial acanthosis nigricans. This was one of our multicentric case control studies where we documented that facial acanthosis nigricans is considered to be one of the morphological markers of metabolic syndrome. And here you can see there were certain factors which were more correlated with the development of metabolic syndrome, like male patients, a positive oral glucose tolerance test, a HOMA2-IR value of more than 2.2, a waist-hip ratio high, a BMI high. One interesting finding was smokers with acanthosis nigricans are probably less susceptible to develop metabolic syndrome in future. But of course, we do not advocate smoking to reduce metabolic syndrome. Again, there is a confusion between maturational pigmentation and facial acanthosis nigricans, but if you ask me, this is just an academic difference. So far as from a practitioner's point of view, if you come across any patient with a pigmentation on face, specifically facial acanthosis nigricans or maturational pigmentation, such patients must always be screened for underlying metabolic syndrome. No point distinguishing between the two conditions, just find out whether METS is there or not. Again, this is one of the very important diseases whenever we think of hidradenitis suppurativa, and that is, if you go to the JAD recommendations, it has been mentioned that every patient of HS have to be screened for underlying metabolic syndrome, and if you are not getting any features suggestive of metabolic syndrome on baseline visit or first visit, the screening has to go on every 12 months. So far as HS and metabolic syndrome management is concerned, so if you are having a patient of HS and you are suspecting metabolic syndrome, rifampicin is one molecule which we love to use in patients of metabolic syndrome. But if you are suspecting HS, remember that the rifampicin capsules, they contain sucrose. So if a HS patient has underlying diabetes, rifampicin may be preferably avoided because it has a caution warning in diabetic patients. Also, if a diabetic patient is given levofloxacin, because levofloxacin is used in patients of HS, we should monitor the blood glucose very carefully. So far as biologics are concerned, adalimumab is something which is a big no because it can cause hyperlipidemia and it can cause hypertension. But again, you can ask me, adalimumab is approved for hidradenitis suppurativa. If hidradenitis suppurativa is not associated with other features of metabolic syndrome, adalimumab is a very good choice. But if there are features of metabolic syndrome and hidradenitis suppurativa, we may better avoid this drug. Maybe other drugs like your bimekizumab or ixekizumab could be better. Yes, I was surprised to find this. There are connections between androgenetic alopecia and metabolic syndrome as well. Not all patients. Whom to screen? Specifically who have early onset AGA, specifically patients with obesity. And also this has been found, there has been a statistically significant correlation of presence of vertex baldness, which has been found to significantly correlate with an underlying metabolic syndrome in comparison to frontal baldness. We all know AGA in males, it has a vertex pattern and it has a frontal pattern. So vertex pattern corroborates more with the underlying metabolic syndrome. This was another interesting article which is very relevant for quizzes also, because androgenetic alopecia and metabolic syndrome, there is one particular molecule, that is your alarin, and this serum level of alarin has been found to be significantly high in patients who have AGA and metabolic syndrome together. Before I wind up my presentation, this is one of the newest kids on the block, because we all know this GLP-1 agonists, they are now being marketed, and it has encroached our specialty also. So the 5 important molecules in this group are your semaglutide, you have your tirzepatide, you have liraglutide, you have dulaglutide, and you have exenatide. Semaglutide is something I think which is already available and many of us are using. I don't have any personal experience because as long as it is approved for dermatological conditions, I am a bit wary of using. But yes, I have heard from my seniors that semaglutide has been used in psoriasis, it has been used in acanthosis nigricans and multiple other diseases. So this is, these are the molecules like exenatide, it was approved in 2005. Liraglutide, it was again approved in 2010. So one of the newest molecules is semaglutide. Of course, I cannot take the brand name. It was approved way back in 2017, but we have to remember that it has been approved for type 2 diabetes and weight loss only. So we are using it in dermatological conditions, we have to use carefully. So take home messages, metabolic syndrome and dermatology, what works best? That is weight loss. So this was one of our reviews which we published in CED. So weight loss is something which is beneficial in everything, starting from your acne, starting from your HS to psoriasis to lichen planus, everything. So any patient of psoriasis who comes to us, because we live in a metabolic syndrome capital of the world, any patient who comes with psoriasis must be screened for metabolic syndrome. And in this group, methotrexate, secukinumab and ixekizumab are the 3 molecules which could be the game changers. So far as acne keloidless nuclei is concerned, screening is always mandatory, and low-dose isotretinoin is something which works very well. Minocycline is another drug which has been found to have anti-inflammatory effect, and very interestingly, minocycline has a beneficial effect on the CRP levels also. Acanthosis nigricans, even if you're not screening acanthosis nigricans of the classical sites, please do not forget to screen for metabolic syndrome if a patient of acanthosis nigricans on face comes to you. And in these group of patients, metformin and myo-inositol are the two drugs which seem to be very promising. So far as hidradenitis suppurativa is concerned, of course, we will screen all the patients, but what works best, we don't know. Androgenetic alopecia, I've already told you, early onset cases and vertex involvement are the red flag signs. And any patient who is coming with an early onset vertex AGA, they should be regularly screened for metabolic syndrome. And apart from that, excessive weight and metabolic syndrome, they have been found to lead to worsening of other diseases like your urticaria and vitiligo as well. Though the data is sketchy, there is no harm in investigating the patient. So I would just wind up by mentioning that metabolic syndrome, it's a complex interplay of oxidative stress, genetic factors, insulin resistance, and abnormal metabolism. Oxidative stress, we cannot do anything. Genetic factors also, we cannot do anything. So far as insulin resistance is concerned, yes, if it is an acquired thing, we can take care by reducing the weight and modifying the lifestyle. But if it's a genetic thing, of course, we cannot help it. Thank you.
Thank you, Dr. Anupam, for the nice presentation. Regarding semaglutide, recently Alkem has launched with semaglutide injections, and they claim faster results in weight loss and control of metabolic syndrome. And if we compare to this Mounjaro, it's cheaper than it, and the doses are also low. So it can be preferred, we can use it. Thank you. Any questions from public? Thank you.
Thank you.
Thank you so much, sir, for such a wonderful presentation. I would request our speaker and chairpersons to please collect their memento. For the last session of the day, I would like to invite Dr. Umaneshwari ma'am, Dr. Shwetalina ma'am, and Dr. Amit Mistry sir to kindly chair the session.
Good evening all. I am inviting Dr. Najiba Riaz ma'am. She is a professor and head dermatology, KMCT Medical College, Calicut, Kerala. There is a bunch of accreditation of her. Now I tell the ma'am to start her session.
Good evening, everyone. At the outset, I would like to thank the organizers, especially Dr. Vikas Shankar and the entire team, for this privilege to be a part of this wonderful Clinicon. Well, as you know, pruritus is an unpleasant sensation which elicits an immediate desire to scratch. So chronic pruritus lasting for more than 6 weeks is a challenging situation, as it can produce significant impact on the person, can cause significant sleep disturbances, distress, and so on. But chronic pruritus without skin lesion is still challenging because there are no cutaneous clues to pinpoint the diagnosis. So we may be forced to think systemically, as this may be the first sign of a sinister systemic disease. It has been estimated that about 10 to 50% of chronic pruritus may be due to an underlying systemic disease. And the skin will be always healthy looking in such cases. So this is an overview of conditions associated with chronic pruritus without skin lesions, like cholestatic liver disease, the end-stage renal disease, diabetes, thyroid disorders, and other endocrine diseases. Hematologic conditions like polycythemia vera, And even iron deficiency anemia can cause generalized pruritus. It's very common in myeloproliferative as well as lymphoproliferative malignancies. So also, chronic pruritus can occur due to psychological and neurological causes. So how to approach a case of chronic pruritus without skin lesions? So a thorough systemic evaluation is essential. A detailed history regarding the onset, duration, and progression of pruritus, whether it is localized or generalized, whether any nocturnal exacerbation, history of drug exposure, and associated systemic symptoms related to that particular system. There are certain red flags to suggest the possibility of underlying malignancy like weight loss, night sweats, and a persistent generalized itch. So physical examination may reveal some non-specific findings like excoriations or lichenification secondary to the pruritus. Always check for generalized lymphadenopathy, any mass palpable, hepatosplenomegaly, and all. So a thorough detailed lab investigation may be required, like a complete hemogram, liver and renal functions, thyroid functions, and other relevant investigations. So specific investigations may be tailored to the, depending on the clinical clues like X-ray, CT, MRI, or USC abdomen, skin biopsy, and so on. So let's have a look at one case scenario. This child presented with intractable pruritus since early childhood. It was so intense that he used to dig into the skin, causing such excoriations which used to bleed, leading to cutaneous mutilation. So it was worse at night, and it was intense on palms and soles. You can see he is deeply jaundiced, and even the teeth has become greenish yellow due to the deposition of bilirubin. So it's a case of cholestatic liver disease. Actually, it's a case of a Watson-Alagil syndrome that is due to the paucity of intrahepatic bile ducts causing a intrahepatic cholestasis. It's an autosomal dominantly transmitted condition. So hepatic pruritus is always associated with biliary obstruction, whether intra or extrahepatic. And you can see that there is a severe pruritus in pregnant ladies due to intrahepatic cholestasis of pregnancy. So the main pruritogen in hepatic pruritus is a lysophosphatidic acid, which is derived from the lysophosfatidylcholine by the enzyme autotaxin, which act on the nerve fibers causing pruritus. Centrally acting pruritogenic endogenous opioids, serotonin, or are other pruritogens in hepatic pruritus. Hence, the first line of treatment is bile acid lowering agents like cholestyramine, cholestyramine, and cholestyramine. It may reduce pruritus within a period of 1 to 3 weeks after starting treatment. Ursodeoxycholic acid is a hydrophilic tertiary bile acid obtained from the bear bile. It helps to excrete the toxic hydrophobic bile acids. And it's a first-line drug for intrahepatic cholestasis of pregnancy. Enzyme inducers like rifampicin may be useful in hepatic pruritus, which help to detoxify the toxic bile acids by inducing the mixed function oxidases. Since endogenous opioids are the pruritogens, these opioid antagonists like naltrexone, and in severe cases, even IV naloxone can be useful in hepatic pruritus. Apical sodium-dependent bile acid transporter, or ASBT, usually helps to reabsorb bile from the terminal ileum normally. So ASBT inhibitors will prevent the reabsorption, thus helps to reduce hepatic pruritus. So these are the novel drugs like maralixibat and odevixibat, which are very useful in severe intractable hepatic pruritus as in Watson-Alagil syndrome. So serotonin antagonists like tropicetrone is also useful in hepatic pruritus. So coming to renal or uremic pruritus is always occur in chronic kidney disease and never in acute kidney injury. About 25 to 30% of patients on CKD develop pruritus, and this becomes almost 80% or more in those on maintenance hemodialysis. There are several pruritogens responsible for this, like the uremic toxins, the secondary hyperparathyroidism, the abnormal calcium phosphorus deposition, as well as abnormal magnesium and aluminum deposition, the associated dry skin. And there's an immune dysregulation due to the generalized systemic inflammation associated with CKD, which may lead to a raised cytokine profile, especially leukotriene B4. And imbalance in the opioid pathways is another mechanism. There is a down-regulation of the kappa opioid receptors in uremic pruritus. Hence, the latest drug for this is a difelikefalin, which is a peripherally acting kappa opioid receptor agonist, which will inhibit its impulses to the CNS. So these are some good old treatments for uremic pruritus, like activated charcoal. This may probably bind to the unknown pruritogen and help to reduce pruritus. Acylastine is a drug which will inhibit synthesis of leukotriene B4 by inhibiting the receptor for LTB4. Thus, is very effective in patients on hemodialysis. So serotonin antagonists have also been found to be useful as in hepatic pruritus, in uremic pruritus as well. Ondansetron, granisetron, tropisetron, and even ketotifen have been found to be useful. Thalidomide also helps to relieve renal pruritus by inhibiting the production of TNF-alpha, which is another pruritogen. Pruritus is very common in hepато-oncologic diseases. Acugenic pruritus is very characteristic of polycythemia vera, which may precede the disease onset by several years. So there are some findings which may help to diagnose polycythemia, like this plethora or ruddy cyanosis of the hands, sometimes face and neck will be there. The main pruritogen is the platelet-derived serotonin and prostaglandins. Hence, pruritus may be relieved by aspirin, which will prevent this release of these pruritogens. So other drugs used for polycythemia vera are cyproheptadine and pizotifen, which are also strong antagonists of serotonin. Iron deficiency anemia is a rare cause for generalized pruritus. Iron being a catalyst for several important enzymes like catalases, peroxidases, cytochromes, and DNA polymerase, the alteration in their function may lead to metabolic disturbances and itching. Pruritus may precede the disease of Hodgkin's disease by several years, and it usually starts in the legs and becomes generalized, and is worse at night. It's usually seen, mostly seen in nodular sclerosis type with a mediastinal mass. So we'll have a clinical scenario. We had a patient who had generalized pruritus, which started on the legs. On examination, there were only such non-specific lesions. There's no response to any drug, antiscabetics, topical systemic steroids. So we investigated her, found that there's a huge mass in the mediastinum, which came as anaplastic large cell lymphoma, which was CD30 positive. It's a very rare variant of non-Hodgkin's lymphoma. So paraneoplastic pruritus is most commonly seen with lymphoproliferative malignancies, and the severity may correlate with the stage of the disease. There are several pruritogens, mediators of pruritus, like serotonin, opioids, neurokinins, endopeptidases, several interleukins, and of this, the interleukin 31 has been found to have an important role in this paraneoplastic pruritus. Hence, mogamulizumab, which is a humanized monoclonal antibody against interleukin-31 receptor, has been found to be useful in this type of pruritus. So several endocrine diseases may present with a chronic pruritus. Even though it's rather rare in diabetes, it can sometimes occur due to generalized cirrhosis, which may be due to the autonomic dysfunction with anhydrosis, and or metabolic abnormalities. There is increased levels of endogenous peptidases which may cause pruritus. Activation of kinins with a reduced itch threshold are responsible for pruritus in hyperthyroidism. And in hypothyroidism, pruritus is mainly due to cirrhosis, more than 90% of cases. So psychogenic pruritus can occur, usually associated with depressive disorders. And the mediators are dopamine and serotonin, and also endogenous opioids. So what's the most important clue to the diagnosis of intractable pruritus? So that is suspicion. So you have to suspect the possibility of an underlying systemic problem, and you have to investigate. And how to approach this is you have to take a detailed history. History is very important. Almost 80% of cases you may come with a correct diagnosis, followed by investigation, examination, findings, and then only the investigations, about 5% of cases. So we should be like Sherlock Holmes to, in a case of chronic pruritus, to investigate and find the cause. So some take-home messages: chronic pruritus, especially without skin lesions, is a really challenging situation. We have to decide whether the pruritus is due to a primary skin disorder or a systemic cause. A detailed history, physical examination, and investigations are very essential. You can see that antihistamines have a limited role in this type of systemic pruritus because histamine has not much role in causing pruritus, especially other mediators are involved. You have seen the serotonin, opioids, and so others. So drug treatment will be more important will be antagonists to these mediators like serotonin and opioid antagonists, SSRIs, tricyclic antidepressants, biologicals, and so on. So thank you for the kind introduction.
Thank you, Dr. Naziba, for this wonderful and elaborate presentation. Any questions from the audience? If no questions, then we can end the session. Yeah, thank you so much.
Thank you so much, ma'am. I would like to invite our chairpersons and speakers to please collect their memento. With this session, the scientific program for day 1 has ended. I would like everyone to proceed for gala dinner. Gala dinner will be starting shortly around 8 p.m. So I would request everyone to collect here.
I would request everyone to come back here in the dress code of black for the gala dinner at 8:30 onwards. And along with that, we have the cultural program. Everyone, please assemble in around next 15 to 20 minutes. We'll start with the gala dinner. Thank you.
check, check, check.